May not cross cell membrane freely. Urea crosses cell membrane very freely. That's why the contribution of urea to the plasma is very less. So the major solute in the plasma, that is sodium and glucose, are contributed to your plasma. That's why sodium and glucose together called as effective osmosis in the plasma. So coming to the potency is otherwise called as effective osmolality. It is contributed by impermeable major cell membrane in the plasma. So we know that sodium glucose are impermeable, but in the presence of insulin, glucose can cross cell membrane. So the major impermeable sodium is only sodium. So sodium besides petrosity, so coming to the iron fluid distribution across various body fluid compartments, if you give like 5% dextrose and hypotonic fluids like Holiday-Segar, it is going to distribute into the intracellular compartment. So it is going to 5% dextrose to expand your intracellular compartment volume. Only 10% dextrose. That's why these hypotonic fluids, 5% dextrose, oxygenation, they are not very and if you give saline is going to distribute to the plasma and interstitial fluid. 25% of your slides remains recovered. That's why they are ideal. And if you give colloids, they remain in the 100%. They are ideal for the అంటే మన హాల్ ఇన్ఛార్జ్ isotonic, hypotonic and hypertonic. Isotonic ఎక్కడ అవసరం లేదండి మొత్తం అయిపోయింది అక్కడ ఆడియో వస్తుంది example being oxygenous and hypertonic. If effect of example, the people can see and our fluid destruction is to one fluid. So to give as the resuscitation fluid or to give as the maintenance or replacement. So depending upon the clinical need, we have to prescribe our fluid. Coming to the resuscitation fluid, we all know that resuscitation fluids will save our lives, and if they are given in appropriate dose and time. The choice of resuscitation fluid should be like Crystalloid, glucose crystalloid. So usually we give resuscitation fluid as bolus. We need to take into consideration the underlying existing diseases like cardiac disease, so in such scenarios, they have to give 5 to 10. So, and very important step is reassessment. After each and every fluid bolus, it is very essential to reassess the fluid status. Whether even child is responding to the fluid bolus or not, you need to reassess after each and every of the fluid bolus. So, if child requires 40 to 60 ml per kilo of bolus and a part of initial resuscitation, it is always better to get such children in ICU because they might land up with ventilation later on. So we have two resuscitation fluids, balanced and unbalanced. Balanced solutions are vinegar lactate and plasma lactate, whereas unbalanced solutions are normal saline is considered as unbalanced. Because if you look at the chloride concentration of normal saline, it is 154 millicuries. It is in physiological range. So what happens if you give normal saline and the resuscitation fluid in large amounts? So it is going to raise chloride content in the plasma. So to maintain electric neutrality, it tries to excrete bicarbonate. It results in metabolic response. So if you give normal saline in large amounts, like 60 ml, 80 ml per kilo, it can result in metabolic response. That is the main chief side effect of giving normal saline and fluid in large volumes. So apart from that, the chloride content in the plasma can cause intra-renal malformation and it can. We are slowly moving out of solution because of these two complications. It can cause metabolic acidosis, it can can increase the risk of AKI. Coming to the balance slides, look at the chloride concentration balance slides. So it is almost similar to the plasma. So apart from that, balance slides contains buffer. Buffers lactate in the ethyl lactate and acetate in gluconate, the plasma lactate. So whenever you are resisting a septic shock chain or any shock chain, which contaminated or metabolic processes, these buffers can utilize metabolic processes. So especially they are useful when you
needs are we lose water as insensible water losses through skin and lungs, sensible water losses through kidney and gut. So insensible water losses constitute 45 ml per kilo of total body water loss. Sensible water losses are 55 ml per kilo. 30 ml per kilo of insensible water loss are from skin and 50 ml per kilo of water losses are from lungs. 50 ml per kilo of sensible water losses are through kidney and 5 ml per kilo we lose from gut. So daily electrolyte requirement, our daily electrolyte requirement, sodium requirement is sodium and chloride. We require like 2 to 3 milliequivalents per every 100 ml of water, and potassium we require 1 to 2 MEQs per every 100 ml of water. So glucose, what is the purpose of adding glucose to the maintenance fluid? So it provides calories. 20% of the calories are provided by glucose in the maintenance solutions, and it prevents starvation ketoacidosis and it maintains euglycemia. So we all know that the fluid calculation, maintenance fluid calculation is based upon Holiday-Segar formula. So which calculates the fluid based upon your caloric expenditure. So what is the criticism about the Holiday-Segar formula? The Holiday-Segar formula, basically the calculations are based upon findings in healthy children. We cannot extrapolate those calculations to a sick child. This is because sick children will have limited energy expenditure. The energy expenditure in sick children is limited because of less activity, and lot of metabolic factors will influence your energy expenditure in sick children. So that if you calculate fluid in such children, if you calculate fluids based upon energy expenditure based on ideal body weight, then always it can overestimate the intake. So sick children will have altogether different physiology. They have limited energy expenditure, and in sick children, various osmotic stimuli, various non-osmotic stimuli will lead to ADH excess states, and these ADH excess states will lead to something called as desalination. Kidney tries to retain free water and it throws out sodium, so that the water and the sodium balance is disturbed. So we are dealing with sick children where ADH is in excess state, and we are dealing with sick children with limited energy expenditure. Whereas in Holiday-Segar formula, all calculations are based upon healthy children in which the water and fluid balance is entirely normal. The energy expenditure in them is totally different from the energy expenditure in sick children. So we cannot extrapolate the calculations of Holiday-Segar formula to a sick child. So these are the various factors in sick children that can influence your water balance and sodium balance. So they can have SADH, sick children will have SADH, so that free water is retained. They can have less caloric energy expenditure, so you can lead to overestimation of intake if you use Holiday-Segar formula in such children, and it can cause solute diuresis. It retains water and throws out sodium. Lot of solutes are being excreted because of ADH excess. And another important physiology is the sodium is translocated intracellularly because of disturbance in the sodium potassium pump. How to choose type of maintenance fluid? Type of maintenance fluid, whether we have to choose whether hypotonic or isotonic fluids. So let us go through a case scenario. A 10-year-old boy weighing around 10 kilos underwent lap appendectomy, recovered from anesthesia, started on IV fluids, isolate T at 80 ml per hour. So after 48 hours, he became encephalopathic and had seizure. GRBS was like 95, serum electrolyte sodium 112, 3.8, and chloride is 108, 102. So why he developed seizures? That is because of hyponatremia. Why he developed hyponatremia? Because we have used isolate P. Okay. What are the disadvantages of using isolate P as a maintenance? So 15 to 30 children who are admitted to the hospital will have this complication, hospital acquired hyponatremia. So most serious complication of hospital acquired hyponatremia is hyponatremic encephalopathy. There is strong association between use of hypotonic fluids, isolate P, and hyponatremic encephalopathy. Usually, if the complication will develop if you give fluids for 48 hours. 48 hours of hypotonic fluid can lead to hyponatremic encephalopathy. So, hyponatremic encephalopathy will have non-specific signs and symptoms. Late recognition and diagnosis can lead to very, very poor neurological outcome. That's why we should avoid using hypotonic fluids routinely, like hypotonic fluids like isolate P and half-NS as a maintenance. So there are a lot of studies conducted which used like compared hypotonic solutions with isotonic fluids. So all studies have shown that hypotonic fluid increases risk of hyponatremia, whereas isotonic fluids are more physiological and they don't cause any dysnatremias. So what are the fluids in different situations, different clinical situations? So as when you calculate maintenance fluid children, please remember that one size will not fit all. So check electrolytes and blood sugar before starting IV fluids for maintenance, and subsequent prescriptions of IV fluids are based upon electrolytes and your glucose. So coming to the oligonucleotide states, where you don't know any clinical details, then you have to start your fluids like 25% of the Holiday-Segar formula, or you just replace insensible water loss, which are calculated as 300 to 400 ml per meter square per day. Here the ideal choice of fluid is 5% dextrose or 5% dextrose with isotonic fluids, that is 5% DNS. Coming to the edematous states, like a child with cirrhosis, child with nephrotic syndrome, child with underlying cardiac disease, in those edematous states where total body water is high, then we need to restrict fluids to 40 to 60% of the maintenance. The ideal choice is to start with, 5% dextrose. And coming to the SADH, we all know that CNS infections and respiratory infection can cause SADH. In SADH, we have to restrict fluids to 60 to 80% of the maintenance. Sometimes we may have to go down to 40 to 60% as well. So the ideal fluid here also, like 5% DNS is ideal fluid. Coming to the CNS disease, probably this is the stage where you have to start 100% maintenance fluid initially during acute phase to maintain the intravascular volume. Fluid depletion in CNS disease like meningoencephalitis can compromise your cerebral perfusion pressure and can worsen the ICP. So it is always better to start in children with CNS disease like meningoencephalitis with 100% maintenance fluid to maintain intravascular volume. Later on, we all know that CNS disease can develop SADH. Later on, if SADH is documented, if child develops features of SADH, you can cut down fluids to 40 to 60%. But to start with, you start with 100% maintenance. And sometimes you may have to use hypotonic saline to keep target sodium more than 145, and ideal fluid again 5% DNS. So in states of excessive free water loss, like in burns, excessive insensible water loss happens in burns through the skin. And in cases of diabetes insipidus, excessive renal losses, those are states where we tend to lose lot of free water. So in those states also, we have to start with 5% DNS, 5% DNS, but the maintenance fluid rate is more than 125%. So you just send electrolytes and adjust your sodium composition later on. But to start with, in free water loss states like burns and diabetes insipidus, to start with 120% of the maintenance with 5% DNS. So the bottom line is to start with only isotonic fluids, no hypotonic fluids like half NS or 5% dextrose. Even in sepsis with ARDS, we need to restrict our fluids. This is because restrictive fluid strategy results in early liberation from the mechanical ventilation as compared to the liberal strategy. And even ventilated child needs fluid restriction. This is because of ventilated patients will have less insensible water loss and they are at risk for SIDH. So we need to restrict fluids to 60 to 80% of the maintenance in all ventilated children. Here also we need to start with isotonic fluids like 5% ANS. So coming to the replacement fluids. So replacement fluids usually replaces ongoing losses. So we need to know before prescribing replacement fluids, we need to know from which compartment child is losing water. Is it from extracellular compartment or intracellular compartment? If child is losing volume through intracellular compartment, then like it increased insensible water losses in case of burns and skin, from increased insensible water loss in the case of skin and lungs, in the case of fever and tachypnea, excess urinary losses in DI. So in those states, patient loses electrolyte free water. So in those, the hallmark state, in those states, hallmark is hyponatremia. So here your goal is to replace with free water. Here, this is the condition where you use hypotonic fluids. So if child is losing excess amount of electrolyte free water, then you can use hypotonic fluids like half NS and 5% dextrose. So here also the caution is you should monitor electrolytes, especially sodium. So accordingly, you change the sodium composition in the fluids later on. So if patient is losing fluid from the extracellular compartment, like in case of vomitings and diarrhea, in case of hemorrhage in the trauma, in sepsis, dengue, they predominantly lose water from extracellular compartment. But ultimately, it can deplete intracellular fluid compartment as well. But to start with, the losses are from extracellular compartment. So the choice of fluid and volume varies if child is losing from extracellular compartment. So what is the ideal replacement fluid for diarrhea? So if you look at the average composition of diarrheal fluid, in the diarrheal fluid we have sodium, potassium and bicarb. So they tend to lose bicarb through the diarrheal fluid. So the choice of fluid is isotonic bicarbonate fluids. So how to prepare isotonic bicarbonate fluids? This is 465 ml of half DNS with 35 ml bicarb. It becomes hypotonic because the sodium concentration of this fluid is 150. So it becomes hypotonic. Isotonic with or without without potassium. This is the way you prepare isotonic bicarbonate fluid and replace diarrheal fluid ml to ml every 6th hour. This is the ideal replacement fluid for diarrheal loss. So what is the ideal fluid for vomiting and gastric aspirates? So if you look at the composition of the gastric fluid, they tend to lose sodium, potassium and chloride. So normal saline being chloride rich fluid, you can start normal saline with or without potassium depending upon the electrolytes. So here you replace ml to ml as per your clinical need. So what are the fluids for oligonuria? We have already discussed this. So here you just start with insensible water loss and urine output. We already discussed insensible water loss or electrolyte free. That's why here we start with 20 to 40% of the maintenance, or you just replace insensible water losses like 300 to 400 ml per meter square per day. Here choice of fluid is hypotonic because here they tend to lose lot of electrolyte free water. And in case of polyuria, renal tubular defects like renal losses in the case of DI, diabetes insipidus, you replace excess amount of urine output above 4 ml per kilo. Choice of fluid here is hypotonic again, half NS, and monitor urinary electrolytes very closely. So what are the parameters you monitor if child is on IV fluid therapy? So you calculate fluid balance, whether the child needs more fluid or less fluid, or you daily check electrolytes at least once in a day, because you need to adjust sodium concentration in the fluid depending upon the electrolytes, and check weight of the child. If weight gain is there, child has positive fluid balance, so cut down your fluids. If weight loss is there, then increase your fluids. And so, of course, you do routine clinical examination to look for signs of dehydration and edema. And neurological monitoring is essential because the sodium disturbances can cause altermentation. So, child on fluid regularly monitor neurological status. If there is any deterioration in the neurological status, send electrolytes, especially sodium, because sodium disturbances in a child with IV fluid can cause altermentation. So, GRBS, of course, to keep RBS in target range. So, what are the complications of the fluid therapy? So, it can cause hyponatremia, and fluid overload. These are the three complications of IV fluid therapy. Let us see how to manage these complications. So, we have a 2-year-old boy with weighing around 10 kilos, having vomitings and loose stools for the last 3 days, not passed urine for 12 hours, had severe dehydration and shock, child is lethargic, serum sodium is 124. What is your approach? So here the treatment principle of hyponatremic dehydration are: number one, you just give bolus to replenish the intravascular volume first. So any type of dehydration, whether it is a hyponatremic or a hypernatremic, if child is in dehydration, give bolus to replenish intravascular volume, and you need to calculate the deficit. How do you calculate deficit in hyponatremic dehydration? It is based upon the degree of dehydration. If it is mild, 5%, moderate, take 5 to 10%, severe, more than 10%. And add these fluid deficits to the maintenance fluid, which are calculated for 24 hours. Just deduct bolus from these fluids, and replace it over 24 hours. The fluid of choice is DNS with KCl. So, and we have to monitor electrolytes. So now coming back to the case scenario, weight is 10 kilo. So child required 2 boluses of 20 ml per kilo, 200 ml each, and deficit for 10% dehydration, 10 kilo weight is 1 liter. So here maintenance fluid for 24 hours, 10 kilo body weight, 1 liter. So deficit plus maintenance fluid minus bolus, 200 ml minus 400 ml, that is 1600 ml. 1600 ml replace it over 24 hours. That is rate at start at 66 ml per hour. So ideal choice is DNS with or without KCl. So monitor electrolytes. How to correct severe hyponatremia? Severe hyponatremia can cause encephalopathy and seizures. Just when child develops neurological symptoms, give 2 ml per kilo, 3% NaCl over 10 minutes. So maximum of 100 ml. You can repeat 1 to 2 times until neurological symptoms improve. So the rate of correction, the goal is initial 1 to 2 hours. The goal is to raise sodium 5 to 6 MEQ per liter, reject sodium after 2 hours, stop therapy when patient is symptom free. Further correction of the sodium should not exceed more than 0.5 milliequivalents per liter per hour. And because of risk of osmotic dehydration, we don't have to target normonatremia. So how do you correct hyponatremic dehydration? Restore intravascular volume, give bolus. Ideally choice is normal saline, not oral. The oral can cause rapid drop in the sodium. Calculate free water deficit and replace those fluid over 48 hours along with maintenance fluid. But calculation of the free water deficit is very complex. We have various formulas to calculate free water deficit. It is very complex. So just start with 1.2 to 1.5 times the maintenance, and fluid of choice is DNS, and monitor sodium every second hourly. If there is no change in the sodium remains high, then you can change fluid to of DNS. If rate of correction here also should not exceed more than 0.5 milliequivalent per liter per hour. So we know that fluids can save and can kill. So overzealous fluid administration can lead to fluid overload. Fluid overload can cause organ dysfunction, respiratory deterioration because of pulmonary edema, renal venous condensation can lead to AKI, and fluid in the abdomen will cause abdominal compartment syndrome. So sometimes the clinical examination can have signs of fluid overload. In fact, their intravascular volume is depleted, like in dengue shock. So appearance wise, child looks puffy and bloated, signs of fluid overload, but their intravascular volume is depleted. So in those scenarios, close hemodynamic monitoring is needed to check for the volume status. So fluid overload percent is how to detect it. So just by simple formula, fluid in liters, fluid out in liters by ICU admission, weight in kilos. So ensure cumulative fluid balance less than 5%. If 5 to 10%, just start fluid restriction, restrictive fluids and start diuretics. If it is more than 10%, it increases the mortality. So you can consider renal replacement therapy. So we know antibiotic stewardship program. to restrict the antimicrobial uses in practice. So like that, similarly, we can translate this stewardship program to fluids as well. And for D's of fluid therapy are, so treat, consider fluids as a drug. So use a right type of fluid in right clinical context, using right dose, adjust the volume of fluid depending upon the clinical state, as we already discussed. Duration, stop IV fluids when they are no longer needed and patient can take oral fluids, and de-escalation is needed when you see signs of fluid overload, and start fluid resuscitation diuretics. So a last word on oral dehydration therapy. So oral dehydration fluids are as effective as IV fluids for moderately dehydrated patients. Whenever child has no signs of dehydration or some dehydration, always start with oral dehydration salts. So they are very cost effective and not associated with complications of IV fluids. Thank you.
I would like to call Dr. C.S.N. Mitchell to felicitate Dr. Hemangiomas.
Thank you, Dr. Kumar. Excellent presentation. Starting from the basic section, many times people they confuse with tonicity and hyperosmolarity, because how the hyperosmolar dextrose normal saline becomes isotonic at cellular level, because we used to. It's a very confusing for our residents also, and also I rightly brought out the concept of the steroid. Administration of a simple normal saline can lead to acidosis in large one. That is actually the physical chemical theory of steroid. So we used to tell students about the acid-base balance both from the Boston system and Copenhagen system. The third one is the steroid system. Unfortunately, the strong ion difference becomes narrower with the administration of the chloride. So you are rightly pointed out. And various situation-based fluid therapy, you are very nicely brought out each situation and each this thing. Probably maybe because of the shortage of time, we couldn't tell the oral dehydration, especially our students face problem with the resemol. The preparation of the resemol we used to sell add mineral mixture, but there is no commercial preparation for that. That is actually how we would like to know actually from you what is the solution, a simple solution, which is with available things, how can they prepare? Most of the people who get malnourished children. So the management of it is problematic for them. And also hyponatremia management. I also remember there is a tendency to go for hypernatremic solutions, thinking that we can correct properly. So the tendency is inevitable most of the times I saw, and you are rightly possible. The maintenance of the sequence of events that you have maintained, you are rightly pointed out. And if you can, any questions from the audience are welcome if the time permits, please. Thank you.
So maybe fluid contamination can cause hygiene. I don't think. See, we take all precautions. In spite of that, no, sometimes they say the name of Rygats. So they get some shivering like, no, they come back from the house maybe after 1 hour, half an hour sometimes. So attributing to some fluid or some problem with the, either with the doctor or with the medicine, some problem. No? Suppose all precious babies nowadays, 1 daughter, 1 son, or 2 like that. So they attributed everything to the doctor. No, we take a lot of time again giving some Decatron or something. So ultimately, it will, baby will be recovered, provided pay more attention. But some problem somewhere.
Yes, sir.
So any idea for that?
Oftentimes we do see such.
See concept, they will be telling by getting like no problem.
Yes, sir.
So what is the problem? How? So just.
So oftentimes we do see this problem, sir, chills and rigors during receiving of IV fluids. But except for IV fluid contamination, I don't have any idea about that, sir. Yes, sir. As I said, while correcting hypernatremia, if your sodium levels are not coming down with your isotonic fluid, half NS, then you can change to isolute P as well. But the close monitoring of serum sodium is utmost important. So if sodium, make sure that sodium is not falling down rapidly. So whenever child is an isolate P, send electrolytes every second to fourth hourly and closely monitor serum sodium is falling rapidly, or if it is falling less than 145, then we might have to change IV fluids to isotonic fluid.
It's a beautiful speech by Dr. Hay. Thank you, sir. Thank you.
I would like to call the chairpersons of the session, Dialogues in the Dermatology, Dr. K. Obula Reddy, Pediatric at Little Heart Hospital, Kadapa, and Organizing Secretary of AP PEDICON 2019, and Dr. D. Veeraya, Senior Pediatric at Rajanpet on the stage to introduce the speaker, Dr. K. Radhakrishna.
Pointer. Hemangiomas. Pointer.
Yeah. Good morning, everybody. It's my privilege to welcome and to address Dr. Radhakrishna Garu. So he needs no introduction. He is a very popular speaker. He is director of the Beagles New York Hospital. He is the president, vice president, central vice president. He is known, he is famous for his pearls in pediatrics. He always brings pearls from Vizag wherever he is called for. So today I think he has brought very nice pearls of pediatric dermatology. So in the next half an hour, he is going to enlighten us about the dermatology and dialogues in dermatology.
Good morning, one and all. Am I clear? Yeah. Now, this is one branch of pediatrics where you require a lot of photographic memory. Many of the times you see the case for the first time, then for the second time, then for the third time you master it. Now, how did I learn dermatology? From the beginning, whenever I used to get a case which I did not understand, I used to take the child on my scooter way back in 1980s, for a period of almost 10 or 12 years on my scooter, because until then I had only a scooter. So I used to take the child, ask the dermatologist, what is this, what is this, what is this? They used to tell me. Then after 4 or 5 photographic memories, I used to learn it. Now today's presentation will be in the form of short cases. In the last 5 minutes, we'll have a lot of spotters. 5 seconds, 5 seconds, 5 seconds. They're at random. I'm not going to show you pyoderma, popular urticaria, scabies. Don't expect me to cover whole of dermatology, and I'm sure you would have seen many of the cases I'm going to present. Now, to this day, let me tell you, whatever case I did not understand in my life, let it be not only a dermatology case, neurology case, or nephrology case, I always send to a higher center. 99% of the cases, I used to get an answer. Please remember, the topic is dialogue, means discussion. So please remember, this is an interactive session. Each one cannot have a mic, you can shout your answer. This is a 10-year-old male child swelling of lips after taking Pepsi. Look at the one on the right side, the one on the left side. So he gets a swelling after taking Pepsi 10 minutes. So the diagnosis is, wonderful answer, it is cold urticaria. It is not allergy to Pepsi. The cold urticaria is characterized by rapid onset of localized pruritus, erythema, and urticaria. Imagine this child swimming in cold water. There is a condition known as cryoproteinemias, in which the child will develop the same allergic cold urticaria, but that you call it as only cold urticaria, not idiopathic. And how do you confirm in your clinic? Take a piece of ice, put it on the lid for 4 minutes. At the end of 10 minutes, you get a swelling. Now I will show you 3 or 4 dry skin conditions. All of you would have seen this condition, but most of the times you say parvaledu, parvaledu, parvaledu. Yes, the answer is parvaledu, but you should have a name. Okay, look at this tiny spots on the knees. Anybody can make a diagnosis? First time I saw, I did not understand. Second, third, fourth time I make a diagnosis. We see such cases. Lichen. Okay. See, the next 3 cases will be the same. Minute, flat-topped, shiny, foam, hypopigmented papules of uniform size. Minute, flat-topped, shiny, foam, hypopigmented papules of uniform size. You can see the coronous phenomena, scratches on it. You have got lesions on the left and right. Okay. So anybody can make a diagnosis? Lichen nitidis. Okay. Lichen, diffuse, no pattern. Okay. Coronous phenomenon can be seen in all those conditions, like infections, spots, then psoriasis, vitiligo. So that is like next time you see you have pupil diffuse, it is lichen nitidis. Okay, same lesions, hypopigmentation in a group, you call it as a plaque. You call it as a plaque of such lesions. The diagnosis is lichen, same minute, flat top, shiny from hypopigmented spots in a plaque. You call it as spilosis. That was lichen nitidis. This was lichen spot. You would have seen so many cases. I've seen probably 200 or 300 of each. So same in a plaque, you call it as spilosis. Okay, that is one more spilosis. Okay, same thing starts as a patch. Say it starts as a patch there. So it starts as a patch of these papules, gradually spreading on the limb over a period of 3 months, 6 months, or 1 year. You call that as? Right, wonderful answer, lichen striatus. So some and some, this is somewhat lichen striatus. I've seen lichen striatus 1 case per day on certain days, 4 or 5 cases for a period of 5 days. Lichen striatus, parents say, yes, it is parvaledu, but you should have a name for it. That is the lichen striatus. So initially I used to take the cases to a dermatologist or refer to a dermatologist. I'll answer the case, I mastered them. So someone will see that a huge number of lichen striatus. Initially I used to take photos, but now I've got so many images, I don't take one. So this minute, flat-topped, shiny, firm, hypopigmented papule of uniform size. The first one, nitidis, plaque, spilosis. A patch gradually spreading over a period of 6 months, 1 year is known as lichen striatus. Okay, these are all dry skin conditions, benign. You require moisturizers, you can use a steroid. Now, look at this cigarette ash lesions on the body. Cigarette ash lesions. Okay, the lesions are less than 1 centimeter. They contain fine scales which give the skin a clinky appearance. Okay, let us see from a close look. Okay, this is known as Pediatrics rosea. Wonderful answer. That is Pediatrics rosea. If you see on the back, the pattern can be that of a Christmas tree. So this is a Pediatrics rosea. Okay. The 6-year-old male child was playing in the garden the previous day, found to have a rash on the neck. See, on the lip, he was playing in the garden. And if you have a look closer, the lesions are erythematous followed by vesicular or bullous lesions. So if this is by purugu, okay, by a purugu, okay, that is known as Pathurus dermatitis. Okay, those are practicing in areas where the large agricultural fields, you will see this. Now, the only thing is, these lesions are not caused by the bite, but by the coelomic fluid of the insect. The insect gets injured for some reason, crushed in between the hands, or it gets injured, The coelomic fluid causes these blisters because the coelomic fluid is an irritant. It has pathogen in it because of pseudomonas in the coelomic fluid of this pathogen. Let us have a look at this pathogen. Okay, that is the look of the pathogen, and they show a lot of these are seen in villages. Let us see how much size it is. It will be around 1 centimeter only. So it is not by the bite of the insect, but because of the coelomic fluid which contains an irritant. Okay, here it was crushed between the hands. It was crushed between the forehand and the upper hand. So that is a treatment is washing and application of a steroid. Because the pseudomonas in the coelomic fluid, there some people will give oral ciproflox. Okay. Now, this 10-year-old child developed pink lesions after he recovered from fever. You look at the lip below. Okay. Look at the lip below. Lip below the lip, you can see that red border, pink border. So, that is the irritant contact dermatitis. Now, during fever, our lips became dry. So, because of that one, he developed that irritant contact dermatitis. Saliva is harmless to the mucous membrane, but irritant to the skin. Urine is harmless in the mucous membrane of the bladder, but irritant to the skin. Fecal matter is harmless to the GI tract, but irritant to the skin. So, that is the irritant contact dermatitis. And look at this child who had a bad habit of something, puckering her lips, habit, appearance, shy, and allergic. So that saliva is the irritant. So you have that irritant contact dermatitis. He also had fever. He was licking his lips day and night. He had an irritant contact dermatitis. So what are common irritants here? Saliva, urine, fecal matter, citrus juices, certain soaps, detergents, and other things. Now, this adolescent develops the skin lesion after 1 month of using this jewelry. Yes, there it was irritant contact dermatitis. Here, it is allergic contact dermatitis. So, irritant contact is just an irritant, no mechanism. It is an irritant. In allergic contact dermatitis, the immune system is affected. The allergen is taken in by the T cells to the into the body. Then antibodies or T cells are there against the allergen. Therefore, after 14 days, whenever the child is again exposed to the allergen, you get this problem. What are the common allergens? For example, gold items, which see gold is absolutely harmless, but the contaminants of gold, cadmium, zinc, copper, whatever are there in the contaminants of gold, 24 karat gold is a waste. You cannot prepare any item with it. They add this zinc, copper, and other things to make it 22 karat gold, and that is the reason why you can have allergy to gold, not because of the gold. So gold has been successful for millions of years as a successful item for preparing gold items. So primary irritant dermatitis means that substance is irritant, the immune system is not affected. On the other hand, in allergic contact dermatitis, the system is affected. Okay, during the last July to October, we had a lot of these cases, red skin with areas of paleness. So this 8-year-old male child, fever 5 days, when the fever came down and the rash came down, the fever came down and he was asthenic, he developed this rash. You would have seen hundreds of these cases, everybody. That is islands of white in the sea of, right? Very classical of dengue hemorrhagic fever. We have seen hundreds of cases, dengue hemorrhagic fever, which you call it as a Herman's rash. Good feature is this is seen in the recovery phase. So if the parents say we are having this, it's a good feature. It is seen in the recovery phase. You can also have a itching. Okay. In the market, there are so many steroid preparations. Which one should we advise? This is a very common doubt. Pediatricians have been 20 years ago. I also had this doubt. So, for example, I should have written it as momentosum, but you are more familiar with Elocon. We have Elocon ointment, we have Elocon cream, Elocon, the lotion. For what condition should we use what? So the answer is 3 points you have to take into consideration. One is the chemical, the other is the vehicle. Okay, the last is the strength. So 1% is more potent than 0.1, 0.1% is more potent than not 1%. So strength, then chemical and vehicle. For example, steroids have been classified under 6 categories: very high potency to the very low potency. Hydrocortisone is practically not a steroid; it is so weak steroid. On the other hand, clopidogrel, propionate, betamethasone, it will just remove the skin of a child. It is so potent, very high, mid potency, low, very low potency. So depending upon where it fits, you can say it is a very high potent or a low potent steroid. Given these days, even you need not take photos, you just mention, open Google, potency of steroids, images, you will get 100 images. Okay, now let us take the first two, clopidogrel, propionate, betamethasone. These are so high potent in a child. If you apply this ointment, the skin will just peel off on the next day. So what do you do with these two? Never use in pediatric population, especially so on the face. Category 1, don't use electrolyte ointment in a child. It is contraindicated because it comes under category 2. Category 1 and 2, don't use in a child, especially so on the face. Next, I told you, vehicle, which I am going to show you. Ointments are more potent than creams. For example, take mometasone furoate 0.1, mometasone furoate 0.1, cream and ointment. Just because it is ointment, it comes under category 2. Just because it is cream, it has come down. So the vehicle is going to matter. Okay, propionate, fluticasone 0.005% ointment is more potent than cream. Just because it is a cream, the potency is decreased. Therefore, hypothetical example, if you get 80 marks for ointment, 50 marks for a cream, lotion, you get only 30 marks. The potency is going to decrease. Same strength, I am talking about same strength, same chemical. The ointment, cream and lotion potency is going to decrease. So, I will next ask you to put the vehicle in order. Ointment, foam, cream, lotions, spray, gel, same potency, same substance, which is the most potent of all? Ointment. Wonderful answer. After an ointment, same chemical, same potency. After an ointment, what is more potent? Cream. So ointment is more potent than a cream. Cream is more superior to a lotion. Lotion is more superior to a gel. Gel is more superior to a spray. And lastly, foam is the weakest. Okay. In other words, same chemical, same strength. Ointment you get 100 marks, cream will get 50 marks, lotion will get 40 marks, foam will get only 10 marks. So the potency is going to decrease from an ointment to a spray. Okay, we'll go to the dose. A 15 kg child was brought to pediatrician, and the pediatrician for fever, the pediatrician prescribed paracetamol 250 milligram SOS. 20 kg child was brought with acute tonsillitis. The pediatrician prescribed tablet amoxicillin 250 TID 7 days. Is there any dose for ointments and creams? Yes. Even dermatologists are happy. They're saying previously we did not have a dose. Even we have a dose. So what is the dose? FTU. మనం అందరూ రాసేటప్పుడు you don't tell to the parents, you know, ఇంత ముద్ద ointment తీసి ఇంత రాస్తారండి, ఇంత ముద్ద ointment తీసి ఇంత రాస్తారు. So there is even a dose for ointment. So one fingertip units, అక్కడి నుంచి tip of the fingertip distal interphalangeal crease వరకు, that is the fingertip unit, which equals to 0.5 grams. It will cover 2 palm prints. That is the area. So please tell the parents inta mudda ant area kandi. In other words, if you translate, okay, you will require 7 FTU for the whole of the front of the chest. For the limbs, you will require 6 in an adult. In a child, you require 3 FTUs. మన వాళ్ళు ఒక ట్యూబ్ ఖాళీ చేసేస్తారు. So from tomorrow, please use a FTU. Okay. What is that? Hemangioma. 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 Hemangiomas are classically classified as capillary cavernous with strawberry. That was my concept 20 years ago. That's all outdated. Okay, what all I showed are not hemangiomas. What all red is not hemangioma. The red band there is not hemangioma. everything, your chase are having red band. No, that's not hemangioma. Everything red is not a hemangioma. So 20 years ago, our pediatric surgeon said, everything you are labeling hemangioma, everything is not hemangioma. I did not understand. Then he told me what is a hemangioma, what is not a hemangioma. Okay, a red lesion observed second week of birth grew rapidly. Similar case, red lesion in the second week which grew rapidly. Another case, red lesion on the forehead present from birth, no progression, no regression. A similar case. That was a Sturgeon birth. So what is the difference? This lady said, I had this lesion from birth, doctor, it is not disappearing. Okay, we have two categories of cases here. One is the red lesion observed from birth with no progression on the right side. Red lesion observed in the second week grew rapidly. So two categories if you can differentiate. So basically what all I showed you 10 lesions were all vascular lesions. Broad heading is a vascular lesion. The hemangiomas, so-called hemangiomas, the pink ones are, you have vascular malformations and vascular tumors. Vascular malformations, you have 5 or 10 conditions. Vascular tumors, 5 or 10 conditions. I just confined to one prototype. So the typical portoine stain, that is a capillary malformation. You have a venous malformation, lymphatic malformation, AV malformation, combined. Just forget about that. Only one you remember portoine stain in this discussion. On the other side, you have varieties of hemangiomas. I am talking about only an infantile hemangioma. Okay. So basically, vascular malformations are developmental disorder of blood vessel formation. On the other hand, vascular tumors are endothelial hyperplasia. So the lesion you are seeing on that side is an infantile hemangioma, or you don't remember, call it hemangioma. That is an example of a vascular tumor. Here you are seeing a vascular malformation, portoine Sturgeon. Okay, present in birth, they do not progress significantly, they do not regress. They do not regress. Their hemangioma, they expand, stabilize, they disappear practically. Almost 80-90% of it disappears. So that is a hemangioma. This is a vascular malformation. So vascular malformation, tumors can be deep, can be superficial, can be mixed. What will happen to this? Majority they disappear. What about the vascular malformations? They don't disappear. So what will happen to an infantile hemangioma? They shrink, they disappear. They will involute. Okay. So in this lady, she does not have a hemangioma. She has a portoine stain, which is a vascular malformation. Okay. For that, you have to go pulse dye laser or put on a cosmetic. Look at this child at 6 months. At 3 years, 80% has shrunken. At 5 years, 90% has shrunken. So that is a hemangioma. Hemangiomas, they disappear, they involute. A vascular malformation will not involute. What is this? This is neither a vascular tumor or a malformation. It is a nevus simplex. You can call it as a stork bite. So some and summary of vascular lesions would be, what all you are seeing red lesions are vascular lesions. One is the vascular malformation, which will not regress. In this child, we will have it lifelong. A vascular tumor, example, an infantile hemangioma, which will progress, stabilize, then involute. Okay. This 13-year-old child was brought with the history that her performance in examination was coming down because the examination papers were getting wet. We see a few cases like this. Parents ask, doctor, suddenly my classmate was there. He used to carry 20 handkerchiefs per day. And at the end of the day, we used to get half a liter of water from his handkerchiefs. Hands. So that was a typical hyperhidrosis, palms and so on. Please remember, there is a treatment for it. Everyone out there, parents, and is so there is a treatment for it, like aluminum hydroxide, hexahydrate form in alcohol. You now have a commercial preparation. Previously, we used to prepare, apply the ointment, put a bandage, so that the bed sheet will not get spoiled. It is effective for a few days. You apply for 2 days, the efficiency will be there for 2-3 days. For important functions, or he is writing, is giving his exam, you can do it. So sometimes in the bus or train you go, you see some people jacket anta tensipoyi untadi, shirt anta tensipoyi untadi. This person, you need not touch his hands, you can predict his hands and soles would be wet. So a clue for hyperhidrosis palms and soles would be hyperhidrosis in the axilla and the groin. Okay, look at these hands, they're wet. Okay, last 7 minutes are there. You shout out the answer, they're all very simple. Creases below the eye is a known case of atopic child. You call it as Demimorgan lines. Demimorgan lines is because of the edema. The part of the face, upper half of the face, drains through the nose into the superior vena cava. So if you have allergic rhinitis, there is edema of the lower eyelids, therefore you get the creases. A child had hand, foot, mouth disease. At the end of 1.5 months, the mother said, "Doctor garu nail ఊడిపోతున్నాయి, గోళ్ళు ఊడిపోతున్నాయి అండి" అంటది. So that is onychomycosis. Okay, at that time there is a damage to the nail bed, therefore you have this onychomycosis. When a child with hand, foot, mouth disease comes to me, I predict, tell the mother, there is some chance that nail ఊడిపోతాయి అండి అని. Okay. So not all of them go into onychomycosis, some of them go into onychomycosis. Okay, you can see the nails are damaged in the proximal part. As they grow, they become normal. Now, some of this child with phimosis, the mother says there is a small swelling in the penis and when you feel it, it is a putty-like consistency, and when you retract it, it will be like that. That is known as, wonderful answer, smegma pulse. This is so common. I would have seen 100 smegma pulse. ఏంటంటే పర్వాలేదు, treat the phimosis, it will correct. But what is it? Smegma pulse. It is the debris and the secretions which have accumulated there. This child of nephrotic syndrome has been on steroid last 3 to 4 weeks. She develops monomorphous lesions on the face. That is a acne. What acne? Steroid acne. So that was a steroid acne. Overgrowth of the fungus and bacteria concerned with acne. So once you stop steroid, it comes down. And this child was given certain drugs. He develops lesions on the lips, buccal mucosa, target lesions on the hands. So that is a typical Stevens-Johnson syndrome. Stevens-Johnson syndrome and TEN syndrome are the same. Less than 30%, more than 30%. That is less than 10%, more than 30%. And mix you have between 10 and 30%. Stevens-Johnson, TEN syndrome. This child has small nodules on the face. They were not present at birth. She started having seizures from the age of 4 or 5 years. That is the classical tuberosclerosis complex. Okay. This young infant who had a rash on the face, and when you start touching the skin, it is peeling down. Okay, it is coming down. What is the sign you call it? Yeah. What is the sign you call it? Wonderful. So this is the Staphylococcus aureus syndrome. Now, why you don't see Staphylococcus aureus syndrome in an adult of 10 or 20 years? The kidney function is good. The immature function of the kidney in an infant, whatever Staphylococcus toxin is there, it is not filtered out. It is because of the inefficient kidneys, the toxin is not filtered out rapidly. We see it in young infants. We don't see it in adults. A child with constipation, how many of you examine the anus? Most of them have a small pilaka. Mothers always say, "Doctor, chinna pilaka undandi." I also am a little lazy. I just show the image in my computer. And most of the times, please remember, parents always have a doubt. Doctor ki asal man cheppindi abbayinda ledinda. Many of the times they always wonder. So iladi pilaka rendu moodu chepte correct andi antaru. So if he has a seizure, the name just ila vastadanda correct andi antaru. Chala salu the need everite andi ila vastada ante adu cheptaru. So if he gets a confidence, manaku ardhamayindante, that's very happy. We had a child who had a seizure, mother papam cheptundi. Then I told, don't worry. I asked the child to hyperventilate, and the child then had abscess. Doctor garu చాలా సాటిస్ఫాక్షన్ అండి, ఇది ఎలా చెప్తామో మాకు అర్థం లేదండి, బలి తెప్పించారండి. సో మోస్ట్ ఆఫ్ ది టైమ్స్ we have to at least act that we have understood the situation. So this pilica is called as, those with constipation have this one. A wonderful answer, sentinel pile. Sentinel pile doesn't require anything, treat the constipation. I'm sure last 15 years, constipation treatment has become so easy with polyethylene glycol, PG. Wonderful response to polyethylene glycol. Last 10 years, the treatment of constipation, we are doing wonders. Okay, a little uncommon case as body swelling on the scalp, a fungus, Kirion. Answer is Kirion. There, I've probably seen 4 or 5 cases in my lifetime, not many. Started somewhere at the proximal part, spread distally over a period of 2 to 3 weeks. That is cutaneous larva migrans. The reason is the normal hookworm you have, once it penetrates into you or me, it goes rapidly into the systemic circulation because the environment of the skin and body is very good. On the other hand, if you have a dog tapeworm, once it enters our body, it does not get the feeling of the dog tissue. So it keeps on spreading. So Ankylostomia brazilians, the dog hookworm doesn't feel comfortable in the environment of the human tissue. So it keeps on searching for the dog tissue. So this is cutaneous larva migrans. At the front end, you can remove the larva, give albendazole for 5 days. Okay, a very small spot, a black nipple-like lesion below the nipple, accessory nipple. Okay, then these are so common. 2% of the children have this dry skin. Ichthyosis vulgaris, so common. Ichthyosis fishy skin. Vulgaris, dirty looking. Acne vulgaris, acne look dirty. Pemphigus vulgaris, pemphigus looks dirty. Ichthyosis vulgaris, ichthyosis looks vulgar. Lupus vulgaris, lupus looks dirty. Verita vulgaris, verita look dirty. No, it is common. Vulgaris means common, not dirty looking. For say, many years I thought vulgaris means dirty looking. No, vulgaris common. Acne is common. Pemphigus is common. Ichthyosis is common. Lupus was common 100 years ago. Therefore, they called it as lupus vulgaris. Verita vulgaris warts are common. Okay, that's a black lesion on the tongue, absolutely benign. Don't worry about it. And no specific treatment. You call it as a dash hairy tongue. Black hairy tongue. A black hairy tongue need not always be pathological. We had this immunocompromised child, malnourished, had these lesions which were greenish in color, and that is known as ecthyma gangrenosum caused by Pseudomonas. The baby is born with those vascular lesions. After 2 months, they become veritous. After 3 months, they become hyperpigmented. After 4 months, hypopigmented. And that is the typical incontinentia pigmenti. A nevus on the face, speckled lesion, nevus a photo, under half a minute. Okay, in the same way, Waddell-Cell swells of hypopigmentation of well. No skin bone, aplasia cutis, they heal like that. Hyperpigmentation in the neck, in an obese child, acanthosis nigricans. A lesion which is not a ringworm, okay? Ringworm, see, this itching and erythema, this is a granuloma annulare. A ring-like lesion which is not a fungus is perianal infectious dermatitis. It is not a fungus. First 10 years of practice, I used to apply candid ointment. That is not the treatment. Candidiasis, you have settle-like lesions. Perianal infectious dermatitis is caused by group A beta hemolytic streptococcus, use mupirocin. And that is Collodion baby. And these days, when we had chikungunya, infants of chikungunya cases, look at the lesions on the chin. She had an injury and the lesions are harmless, non-infection, post-inflammatory milia, and that is not a fungus, that is lupus vulgaris. On the right side part, it is healing, left side is expanded. That's the lupus vulgaris we are hardly seeing. To be continued at Miller. Thank you and all.
Thank you, sir. We have taken a wonderful artistic photograph journey last half an hour. Enjoy this dermatology dialogues. Nowadays, we are seeing dermatitis because of COVID season with a lot of mass, tight fit mass also we are seeing dermatitis. Thank you, sir. Thank you.
I would like to request Dr. K. Obula Reddy and Dr. D. Veeraya to felicitate Dr. K. Radhakrishnan. An announcement, please. Those who would like to go for rifle shooting and horse riding at Nextion International School can board the bus at 11:20 a.m. outside the venue. Thank you, sir. Thank you very much. Next, I would like to call upon the chairpersons of the session, A Journey Through Sepsis, Past, Present and Future, Dr. P.S. Pavan Kalyan Garu, Secretary of IAP Andhra Pradesh, and Dr. K. Nagendra Prasad Garu, Pediatric at Sri Yogi Children's Hospital and State President of IAP 2021 onto the stage, please, to introduce the speaker, Dr. G.V. Basavaraju Garu.
A very good afternoon, good morning to all of you. Just there is a small change. I request Dr. Durga Prasad sir to install the President Medallion to Dr. Nagendra Prasad sir. And because the Central Zone in Telugu PEDICON is being instituted by Dr. R. Venkateswara sir and Dr. Durga Prasad sir, sir is there, sir would be the chairperson. So I request you to please install the President Medallion and then take over as the chairperson for today's program. Because during COVID pandemic, we missed the presidential ceremony which we have. So please give a big round of applause to Dr. Nagendra Prasad sir, who's been the president in the year for the pandemic year, and we got 7 awards under his tenure. So it's a huge, from Bengal side, we got not only that sir has conducted so many. It's my pleasure to give this medallion to the President, Dr. Nagendra Prasad of Kadapa. Sir, please, sir. In there.
A very good morning to all of you. This has been an oration lecture which will be installed by Central Zone in Telugu PEDICON, which was conducted in Vijayawada. It was a huge success to this oration lecture, which will be installed by the President and Secretary Organizing Chairperson at the time, Dr. Holiday-Segar sir and Dr. Durga sir. It's my honor and privilege to introduce Dr. K. Nagendra sir. He was the President of 2021 of state of Andhra Pradesh, and under his tenure again, he has done so much activities. And what we are today, we enjoyed the academic feast last year. And to introduce Dr. P. Durga sir is a senior most pediatrician in the state of AP. He is the present election commissioner of IAP whole country. So we are proud that this is one of the big gestures that Central IAP has given to the state of IAP, to the state of Andhra Pradesh after we got divided, that we got a huge respect and what is Andhra Pradesh could understand because of Dr. Durga sir and Dr. Arvind sir and all the onward Dr. Sudhakar sir, Dr. Radhakrishnan sir. So it's my privilege as a secretary that I'm introducing the Durga sir and Nagendra sir. Now I would like to request Dr. Durga sir to introduce our oration lecture person, Dr. Basaraj sir.
Good morning, everyone. It is my honor to introduce a person like Dr. Basaraja. Dr. Basaraja is a household name in pediatric community. As you all know, nationwide, you were seen everywhere during that pandemic. When we were wondering what to do at home without doing any work, we were not able to see patients also. Even the government has directed to remain indoor, not seeing the patients at all. That was the time when Dr. Basaraja and Dr. Bakul Jain, they have taken initiative and introduced it to the platform, digital platform, where we have seen the flood of academic activities during those pandemic years, year 2020 and 2021, as it continued in 2021 also. Thank you, sir, for introducing such a novel platform which we are used to nowadays to watch. Dr. Vasactive is Professor of Pediatrics and Chief Intensivist at Indira Gandhi Institute of Medical Sciences, Bangalore. And it was the golden era of IAP when we were the Secretary General of Central IAP, year 2020 and 21 also. And he is currently the President of IAP Bangalore. And he has many awards to his credit, and he has delivered so many lectures across the country on so many platforms, not only the digital platform, even in the physical tour. He traveled across the length and breadth of India and given so many oration lectures also. And I think, sir, I think we need not introduce you. I think everybody knows about Dr. Basaraja. Over to you, sir.
Thank you very much, Dr. Durga Prasad sir, for your kind words. Let me thank IAP Andhra Pradesh organizing team of AP PEDICON led by Dr. Nagaya Naidu, Dr. Mullidhar Reddy, Dr. N.V. Ram Rao, and the Office Bearer of 2021, Dr. Nagendra Prasad sir, Dr. Pavan Kalyan, Dr. Sai Prasad sir, and all the team of Andhra Pradesh. And special thanks to our Central Zone Vice President, Dr. Radhakrishnan sir, Dr. Anil, Dr. Rashekar, Dr. Kiriti, and all the executive Professor Ramakrishna Paraman sir, executive board member, and respected Chairperson Durga Prasad sir, and Dr. Nagendra Prasad sir. And also let me thank our team, Central Zone and Telugu PEDICON at the time was in a Vijayawada team which was led by Dr. Durga Prasad sir, R. Yogeshwar Rao sir, Sai Prasad sir, and all the team members for introducing the Central Zone PEDICON. What I will be discussing for the next 40 minutes or so about the sepsis, what really it was in the past, what the present thing, and what the future ahead in the sepsis management. Sepsis is one of the major thing what we all come across in the. I bring a greeting from prestigious Indira Gandhi Institute of Childhood. This is where for the last 2 decades I am working in the pediatric intensive care department and also in teaching faculty. As we are aware, the leading cause of mortality and morbidity in pediatric age group is sepsis. Almost around 1.2 million cases of childhood sepsis will die in a year, and mortality it corresponds to the 4 to 50%. If you take in a poor infrastructure where mortality may be as high as 50%, the well-developed pediatric intensive care mortality can be as low as 4%. That means the health infrastructure and quality of the child care, which really plays an important role in the sepsis and outcome. Let's go back to the past. When you look at the word original term sepsis is a septomis is rotten. Hippocrates is described as sepsis as a dangerous biological decay that is a release of various substances that is causing an auto-intoxication. So that's how this concept of sepsis is came in the Hippocrates era. In 1800, that is the golden age of the germ theory, where the INFML was conceptualized the anti-G hypothesis that is reduced the puerperal sepsis. We are all talking about antigen today. This is the concept which was existing as early as 1800, and Joseph Lister, who came up with one more concept of carbolic acid testing that reduced their own sepsis. This is the whole story in the past. The big breakthrough which is really occurred in 1964 when Dr. Edward Kahn, who published the management strategy for the septic shock, which was in 1964, where he introduced the concept of continuous monitoring of systemic arterial pressure, central venous pressure, cardiac output, urine output, blood volume, and blood investigation, which is really played an important role in the outcome of sepsis. This was introduced in 1964. And also he brought up a new concept of, okay, sepsis is likely to be caused by infection, it requires a specific management like an antibiotic. So that was in year 1964, and supportive care, correction of electrolytes, volume, all these things which is emerged, including the respiratory support. And in 1960s, one of the concepts was to give an anti-adrenergic drug. Of course, now we are giving an adrenergic drug. I'll come to that in later. So this was a concept which was there in 1960s. This was the thing in the past. We did a study in the year 2000 to 2003 and published later in the 2005. We looked into the protocol of lactate level and its prognosis and outcome, where the higher the lactate level, which is associated with a poor prognosis and mortality. I'll come to this, what the present sepsis guidelines says about it. The big breakthrough in the management of the sepsis, which is came in several sepsis guidelines, which is formed in 2001 by the Society of Critical Care Medicine and European Society of Critical Care Medicine and International Sepsis Forum. The primary aim of this surveillance sepsis campaign was to evidence-based guidelines and recommendations for resuscitation and management with the sepsis. The initial guidelines, which was the committee which was formed in 2001, the guidelines which came out initially in the 2004, that has been reviewed and updated, published from there onwards till every 4 years. This is the surveillance sepsis campaign. What is the latest surveillance sepsis guidelines? This latest surveillance sepsis guideline came during the COVID-19, where the 2020, this is the surveillance campaign guideline, which really helped to manage our COVID also to some extent. What really which is looked into the approach is systemic screening and diagnosis. We will discuss about that.
antibiotics, what is the recent change we need to be looking. How do we play with vasopressor? Oxygen and ventilation is another thing, and the source control. These are the 6 fundamental principles. When you were clueless during the COVID-19 in 2020, the majority of the concept we had drawn from here and we are modified to the COVID-19 management. That's why the surviving sepsis campaign guidelines which came in 2020 really made us to work on the COVID-19 management. When we talk about initial resuscitation, this is an algorithm which is for the children. We need to understand if the patient is in a septic shock or is it in a sepsis, suspected sepsis. Why it is relevant is, suppose if the patient is in a septic shock, we need to resuscitate the child within 1 hour. If the patient is not in a shock, we can take around 3 hours of time. But if the patient is in a shock, we need to address within 1 hour. Whereas if the patient is not in shock, we can take up to 3 hours. But remember one thing, if you don't act quickly, the patient can slip into the septic shock. That's why we need to be very, very careful on that. So when it comes to the core elements of management of a sepsis, one of the things is the moment you come, child comes to you in the emergency department or in your hospitalization, first thing is to secure in a 2 IV peripheral line or in bracket. Don't try to attempt for the central line. If you can able to access it, fine. Otherwise, central peripheral line is good enough. Along with that, intraosseous line. And before giving an antibiotic, we should take a sample for a blood culture. Apart from blood culture, we also need to look at the renal function, liver function, and electrolytes and blood sugar. You need to take a sample for that also. And we need to start the empirical antibiotic. I discussed about empirical antibiotic in a subsequent presentation. Measuring the lactate level is the key, and administration of an IV fluid boluses. That's the present concept. We'll discuss about that. When do we start on a vasoactive substances, and what vasoactive substances we need to start? We'll discuss on this thing. And another core element of management of a septic shock is respiratory support, assessing if the patient is in a pediatric acute respiratory distress syndrome or respiratory failure. So that's the key. And continuous reassessment is one of the important things. And infectious source control. Where is the source of infection? Is it an abscess? Is it a pneumonia? Is it a soft tissue abscess? Is it a pathogenic meningitis? We need to look at what really the source. Unless you control the source, you are more likely to end up with a problem. Fluid and vasoactive substances will discuss, and advanced monitoring. That's the one of the important steps in a sepsis management. And hydrocortisone, when should we use an hydrocortisone? Should we use it in a fluid refractory shock? Should we use it in a catecholaminergic shock? We'll discuss that. Avoiding hypoglycemia, and if the patient doesn't respond with your invasive and non-invasive ventilation, so the next important thing, either veno-arterial or veno-venous ECMO is the thing which is really going to be useful in the management. Let us look at the diagnostic point of view. Systemic screening, whenever the patient comes to you in the ward or in the emergency department or in the PHU, one of the most important thing is systemic screening. What is the source of infection? Unless you find the source of infection, it is difficult to find. Sometimes you may not be able to find the source. But your attempt should be there, and taking the blood culture before giving the antibiotic in a critically ill children, suspected their sepsis, that is going to play an important role. Apart from acute phase reactions like creatinine, procalcitonin, these things and counts, that plays an important. When you take a counts, one of the important things you need to remember, there will be a total leukocyte count will be more than 15,000, or leukopenia less than 4,000, with a predominance of the polymorph. If you look at the peripheral smear, you will get a toxic granule, band forum, shifting up in a shift to the left, and donor bodies, thrombocytopenia. Initial part there will be thrombocytopenia. Later, there is thrombocytopenia. This is how you can screen for the acute children CBC, CRP, procalcitonin, and blood culture. That plays an important role by etiological point of view. Coming to the blood lactate level, this is the one thing what I shown study, what we conducted in 2000. We were, at that time, we did not have any clear-cut guidelines about the lactate level measurement. We looked into that one time, even though it was predicted in a poor prognosis higher level with a morbidity. But the latest survival sepsis guidelines clearly says single measurement of a lactate, no role in assessing the severity. If at all, if you measure the lactate level, it needs to be serial monitoring. That plays an important role in the outcome. Implementation of a management protocol for septic shock, that's the key we need to do. Let us look at one of the most controversial and the commonest mistake we all do it in the clinical practice is how do we choose an empirical antibiotic? When in the year 2014 and before that in 2012 also, so first initially we came out with a rational antibiotic therapy. Rational antibiotic therapy. So this is a thing which is based on what the drug you are expecting it. What is the antibiotic which is global sensitivity? Look at the national sensitivity, and the most important deciding factor is your local culture sensitivity pattern that defines the thing. On that basis, taking all these things into the consideration, did not mention about any particular antibiotic, they left it to us, but we came out with what we are using in our institute. If the patient is less than 1 year, we go with a broad spectrum antibiotic, that is third generation cephalosporin, along with an amino glyphosate. That's the antibiotic of choice. Why do we choose this antibiotic? When you look at these things, the bulk what we commonly expect in a less than 1 year, that to less than 3 months is your gram-negative. And streptococcus is another thing where we need to cover these things. That is why we need to choose a third generation cephalosporin along with amino glyphosate. Behind 1 year, it is once again it is third generation cephalosporin. One of the change here is if you are coming across with MRSA as one of the possible organism, when do you suspect MRSA? If there is a history of a child coming from a community where the MRSA is more common, if the patient is there in your hospital or more than 48 hours, coming in contact with MRSA, or if the patient is received a penicillin group of antibiotic 3 months back, or if there is a history of a trauma that's causing a sepsis, that's causing an ARDS, that's the time where we need to go upfront with vancomycin. So because what you are expecting is methicillin resistant staphylococcus aureus, that is why vancomycin needs to be used judiciously where there is a suspicious of MRSA. That is the situation where you can, otherwise third generation cephalosporin alone is sufficient. When it comes to the choosing an antibiotic, we also need to look at it, what is the source of infection. Suppose it is the neurotoxin, pyelonephritis, which is finally landing up with sepsis and septic shock. I need to look at it, amino glyphosate as a drug. Either you escalate the antibiotic or de-escalate. So this is what, as a clinician, we don't do it in the practice. Every day, you need to learn about to escalating or de-escalating depending upon the culture sensitivity. That's the message I leave it at that thing. So next thing, once after choosing an antibiotic, if it is a case of a septic shock, we need to give an antibiotic within 1 hour. And if it is a sepsis within 3 hours, always take a culture before starting an antibiotic.
and avoid multiple antibiotic wherever it is possible. Daily assessment for de-escalation is need to be there, and duration of antibiotic, it all depends upon the community acquired or hospital acquired infection and what the bug you are expecting. Depending upon that, you can choose that. Is identified, need to identify that source of control intervention as possible. Suppose if there is abscess, even a multiple antibiotic and tons of antibiotic not going to play any role unless you drain the abscess. Abscess drainage is the key in that. And if there is a catheter related infection or if it is an IV like central line catheter, unless you remove that, your source of infection may not be able to control. Coming to the fluid boluses, the moment we talk about septic shock, the one of the things should be given a crystalloid, should I give an electrolyte? That is the things which comes. Answer is crisp and clear. It is always a crystalloid. The moment you say crystalloid, there are three crystalloids which is commonly available. Routinely, you will get a normal saline, you will get a ringer lactate, plasma-lite. Some of the centers may be using plasma-lite. But what is the main difference between these three crystalloids is normal saline, which contains in a 150 sodium and 150 chloride. Your ringer lactate contains in a 131 sodium and 111 of the chloride. When you look at the blood chloride level, it is 98 to 110. But if you choose a normal saline, which contains 150 of the chloride, which is likely to cause hypochloremic acidosis, when you do not have a choice, that's the time you can give a normal saline. Otherwise, ringer lactate is the fluid where it contains the sodium of 131. But remember, before giving a ringer lactate, two things you need to be remembered. One, child should not be suffering from liver failure, because if the patient has lactate, it also contains a lactate. And if the patient is having a renal failure, ringer lactate contains a potassium 5 milliequivalent. You need to avoid a potassium containing fluid in that. So plasma-lite is another fluid which is preferred. So the carry-home message, either you can use a normal saline, ringer lactate or plasma-lite. Those are the fluid of choice for the resuscitation. Balanced and buffered crystalloids, plasma-lite is one of the thing, but thing is that it is not really available. The electrolyte content and osmolality of the plasma-lite, it is similar to that of a blood. If you look at the sodium of a plasma-lite, it is 140, whereas chloride is 98. So that's almost near to the blood. That's the most preferred, but it is not available. What about hydroxyethyl star? That's the colloid which is likely to cause two important things. They're known to cause your anaphylactic reaction, and coagulation cascade system is likely to be affected. Better to avoid hydroxyethyl star because that may be associated with increased mortality. That is what the surviving sepsis guidelines says about your crystalloids is the fluid of choice. Then comes another emphasis was been done by survival sepsis campaign is hemodynamic monitoring. This is the thing where previously we used to talk about a targeted mean arterial pressure. This is no recommendation for that. Trends of a lactate level is a very important thing. Guiding the resuscitation in the children with a shock is recommended. Bedside clinical science in isolation of categorization of a septic shocks plays an important role. Previously we used to talk about warm shock and cold shock. Still it is there, but not too much emphasis has been given to that of a warm and cold shock. Survival sepsis campaign recommends that use of advanced hemodynamic monitoring in a patient with a sepsis, like a cardiac output. Nowadays, a lot of monitors which is available. Dr. Dinesh is going to speak in the afternoon. So I'm sure he is going to touch upon the advanced instruments which is really required in the thing, in the intensive care unit. And mixed venous oxygen saturation, this is not really done in all the ICUs. Very few ICUs does that. So, but good to know, these are the things which needs to be the futuristic thing we need to recommend it. What are the hemodynamic monitoring? When you look at that, cardiac index is a thing which is basically cardiac output upon the body surface area. Normally it is around 3.5 to 5.5. So we need to target for that. Stroke index is another thing. Take a cardiac index upon the heart rate. So majority of the monitors which is available now all displays are systemic vascular resistance index. Because once you start getting into the advanced multi-system monitor, all these things can be displayed. You can every day you can review in your clinical practice. That's the thing which has been emphasized by survival sepsis campaign.
So another important thing after fluid and antibiotic, as a clinician, what we all come across with, which vasoactive drugs we need to choose it in clinical practice. Is it a warm shock which decides it? Is it a cold shock decides it? Should I use a dopamine? Should I use an epinephrine? Should I use a norepinephrine? When it comes to the vasoactive substances, now the clear is for last 1 decade, we are all using epinephrine is then a drug of choice, whether it's a warm shock or cold shock. Epinephrine is the plays an important role. So almost we have moved away from the dopamine. Dopamine, still some of the centers are using it. Why we moved away from the dopamine is, basic thing is, when you use a dopamine, if a short period it may not be, if you use it for a longer period, immunosuppression, it is likely to cross the blood-brain barrier. And when they looked into the study, there is almost a 4-fold rise in the mortality if the patient has been used with the dopamine. That's why things has been moved away from the dopamine. So immunosuppression, infection, and mortality is more with that if you're using it for a longer period of time. Suppose if it is not available in the periphery, where epinephrine or norepinephrine is not there, still you can use a dopamine as a thing for a short period time. Immediately you can switch over to the epinephrine. So epinephrine is a vasoactive substance of choice in a cold shock. In warm shock, it is norepinephrine. In general, if you say epinephrine is the vasoactive substance. What about vasopressin? Vasopressin is another thing which is where we use it in a low dose if the patient with the catecholamine resistant shock and all, but routinely we don't use the vasopressin in the clinical practice, but in a low dose if it is a catecholamine resistant, if it is not responded to steroid, that's the time where we will think about. I'll come to that point later. And next clinical question, as a clinician, we all face it in the clinical practice. Can I use a vasoactive substance in the peripheral line, or should I use it in a central line? When we were doing in a postgraduate, majority of the time we used to use it in a peripheral line. We know that it is likely to cause extravasation, thrombophlebitis. So these are the major issue which is associated with vasoactive substances. In the initial period, your answer is yes, you can use it if you are not able to access the central line quickly. That's the time where you can start, but quickly switch over to the central line. The moment you talk about vasoactive, preferred is your central line, but for a short period, you can give it in the peripheral line also. What about inodilator? This is no recommendation has been given by Survival Sepsis campaign. So when you look at dobutamine causes the peripheral vasodilatation. If you don't get a normal blood pressure and use this, and rather than you are improving the child, you may land up with a problem. That is why dobutamine is not the thing. When you long off life, so these are the thing on case-to-case basis. You can look at that dobutamine or milrinone as a drug, whether to use it or not to use it. But as per the Survival Sepsis campaign is concerned, there is no recommendation for that. Coming to the fluid and vasoactive inotropes management in children, especially, look at India is a vast country, even developing countries also. So we need to look at, is the patient is within a intensive care unit or without intensive care unit. Depending upon that, the recommendation has been given by Survival Sepsis campaign. Without intensive care unit, if the blood pressure is with or without hypotension, and with hypotension. These are the factors which is taken into the consideration, whether the intensive care available in your area or it is not available where you are managing. Is the patient is in without hypotension, with hypotension? So we need to look all those things into the consideration. If there is an abnormal perfusion with or without hypotension, if the signs of fluid overload is absent, administer the fluid of 10 to 20 ml per kg of Crystalloid. Previously, you used to think about giving a 20 ml each. Now, instead of 20, we are talking about 10 to 20 ml per kg of a Crystalloid. Repeat assessment. Once you give a fluid boluses, reassessment is the key. You can consider if there is no fluid overload, you can give another 10 to 20 ml. Maximum of you can give it up to 40 to 60 ml per kg of a fluid. You can give it in an intensive care setting if the patient with or without hypertension. Suppose if the patient doesn't have any hypotension, that's the time where you not necessarily you need to give a fluid boluses. Instead of that, you can give a maintenance fluid and subsequently you can consider the vasoactive substances. Suppose if the patient with an hypotension and without intensive care unit, that's the time where you can administer the fluid of 10 to 20 ml, maximum of 40 ml per kg. Always look at the reassessment of the child. Is there any basal crepitation? Hepatomegaly? Is the heart rate is increasing? Look at more clinical things in a resource limited setting where you may not be able to get all the time invasive blood pressure monitoring, and even non-invasive also sometimes it may be difficult, and monitoring may be difficult. More rely on your clinical settings. The shock, if it is resolved and perfusion is made an improvement, do not give a more fluid boluses. Consider a maintenance fluid and monitor the signs and symptoms of recurrent shock, because the once the patient is in a shock, the septic shock is in a distributive shock, at any point of time, it can once again, patient can slip into the shock. That's why we need to be more aware about that. So if there is an hypotension in the healthcare system, when do you say hypotension? If the age of the child is less than 12 months, that is 1 year, if 50 or less of systolic blood pressure, between 1 to 5 years of 60, and more than 5 years, it is less than 70, we call it as an hypotension. Or in a resource limited setting, in peripheries, what you need to depend upon the three things: cold extremities, capillary refilling timing of more than 3 seconds. This is what described by your WHO. And look at the tachycardia or a low volume pulse. If these three things are there, you can say this patient is in a shock. Even without advanced monitoring, advanced gauge, still you can recognize the shock in a peripheral setting. So WHO, when it recommends it, it all takes into the consideration of, so from the peripheries to the top and advanced center into the things. Coming to the ventilation, indications for intubation, there is no clear-cut guidelines. When the sepsis, it is all unit to unit to this one, and should we use an invasive and non-invasive? It all depends upon the availability of in your clinical setting. And one of the things, if the patient is in ARDS, that's the time where we need to recruit a more alveoli by using a PEEP. So when you're using a PEEP, always monitor your hemodynamics, because once your lung starts expanding, this patient may be pushed into the hypertension. Continuous monitoring of a blood pressure and hemodynamic is the key when you are increasing the PEEP. And recruitment maneuver like an IE ratio of 1:1 or reverse, you need to look at that. It is more of a bedside thing. And high frequency oscillatory ventilation, we don't use it. Some of the centers may be using it. And prone ventilation, basically what we need to look at that ARDS strategy whenever the patient with a respiratory distress things. So as far as the ventilation is concerned, no recommendation on timing of intubation by survival sepsis campaign. What we use usually, if there is a fluid refractory with the catecholamine resistant shock or without catecholamine resistant shock, we'll try to intubate the child at the earliest if there is a respiratory distress with a shock. Reason is you need to bring down the metabolic demand. We need to improve the outcome. That's why you look at your clinical settings, what really you are up to, depending upon that you can. And no intermediate, routine nitric oxide is not really recommended. Nitric oxide is only recommended if the patient is having a refractory hypoxemia sepsis with an ARDS. That's the situation where you can use an nitric oxide. What about steroid? This is another thing. When we talk about a sepsis induced along with a catecholamine resistant shock, fluid refractory along with catecholamine resistant shock, that is the time where you can use a steroid as a drug. Which steroid we use? As far as the survival sepsis campaign is no recommendation, but what we use is hydrocortisone. You can use it at 50 milligram per square meter body surface area, or to make it very simple, 2 milligram per kg of hydrocortisone. We use it for 24 to 48 hours, and if necessary, you can monitor your cortisol and electrolytes things and ABG. No role for a fluid sensitive and catecholamine responsive shock. Don't use your steroid in a fluid responsive and catecholamine responsive shock. Only reserve the steroid mainly for a catecholamine resistant shock. And maximum dose you can use in a 200 milligram, and intermittent or continuous can also be preferred. And in previous survival sepsis campaign, we used to talk about the tight control of a blood sugar between 80 to 180. Now there is no recommendation in the latest survival sepsis campaign 2020 guidelines, but you take a call depending upon your unit policy. What we do, suppose if there is a blood sugar anything more than 180, we try to intervene in our unit. So there is no target is given in the survival sepsis campaign, and routine use of levothyroxine. Previously we used to think about the sick thyroid, we used to think about the levothyroxine. That has been taken out in the latest survival sepsis campaign. Of course, antipyretic therapy is the thing. This is the most neglected thing. Whenever the child with a sepsis, with a fever, you need to aggressively act to control the temperature. Use a paracetamol. Dose you can use it in intensive care setting, 10 milligram per kg. IV you can use it. Suppose if the patient is stable, then you can use in a 15 mg. But what we use it in our unit is we use in a paracetamol in the dose of 10 milligram per kg. Coming to the nutrition, nutrition is the most neglected part. The moment we talk about a nutrition, it is not, we need to talk about micronutrient as well as the macronutrient and also the calories and proteins. So earliest, as quickly as possible, you introduce an enteral nutrition. Shock is not the contraindication unless there is an upper GI bleeding. There is no contraindications for enteral feeding unless your gastric surgery or an upper GI bleed. That's the few situations where we recommend to differ, but you start upfront with an enteral nutrition. Routine probiotic. Probiotic is another thing where majority of the units where they talk about even though some of the studies says there's good improvement probiotic, general consensus is that probiotic is not recommended as per the survival sepsis campaign. And selenium, glutamine, arginine, thiamine, zinc, vitamin C supplementation. So we need to take care of micronutrient. Routine recommendation not really required. Look at the calcium, look at the phosphorus, selenium, copper. When the patient is there in an ICU for a longer period of time, where critical myopathy, neuropathy is the thing, that's the time we need to assess as a part of a sepsis, not that these things are required. And acute repletion of vitamin D, previously they used to, some of the units used to recommend. Survival sepsis latest guidelines clearly says no need for vitamin D routine recommendation. That's about your nutrition. What about blood and blood products? This is one of the other important thing. As a clinician, we need to make a decision. Previously, we used to talk about blood transfusion in less than 10 gram per deciliter, liberal blood transfusion policy and restricted blood policy. When they looked into the both liberal blood transfusion policy as well as restricted, when they looked into the mortality is not going to make a big difference. That is why no routine transfusion if the EHV is more than 7 gram. If it is a less than 7 gram, if it is hemodynamically unstable, yes, we need to give a blood transfusion. So as far as the threshold is concerned, there is no recommendation in the survival sepsis campaign. Platelet transfusion in thrombocytopenia, generally it is not recommended. If you are attempting an invasive procedure, if the platelet count is less than 50,000, yes, you can give a platelet transfusion. Otherwise, transfusion itself can be associated with a complication. Trolley is one of the major issue. Transfusion related lung injury, need to avoid the unnecessary blood and blood product. FFB only if there is a bleeding. When we are a postgraduate, the moment the sepsis comes, PT and PTT coagulation profile is deranged, we used to give an FFP left and right. Now there is no recommendation unless the patient is having any bleeding. That is the time we need to consider an FFB as one of the things. Otherwise, routinely it is not recommended. So clear-cut message is blood and blood product needs to be restricted as much as possible. Renal replacement therapy is one of the things which need to be managed, and especially where the CRRT which is available and the patient is in a refractory, fluid unresponsive. That's the time you can consider fluid unresponsive or diuretic is not working. That's the time you can consider that. High volume hemofiltration is not recommended. Veno-venous ECMO is the preferred unless it is a refractory. That's the time veno-arterial ECMO is then a thing which is required. Because why I'm talking about ECMO, quite a few number of centers across India, now the ECMO is available with the following up in COVID-19. So we need to know that what the latest guidelines which is available, what I need to follow as a clinician. Immunoglobulin. Immunoglobulin is one of the things which has been abused, misused, overused in some of the center, not in all center. The clear-cut guidelines of survival sepsis campaign guidelines is clearly says there is no routine recommendation for immunoglobulin in the routine clinical practice. On case-to-case basis, you may think about, but no recommendations for immunoglobulin. There is a clear message from survival sepsis campaign. What about routine prophylaxis of H2 blocker? So unless there is a GI, this one of the patient is in a nil by mouth, that's the time where we need to think about H2 blocker. The moment you're using H2 blocker or proton pump inhibitor, you are propagating a sepsis. That's why unless it is required, it is not really recommended for H2 blocker. What about DVT prophylaxis? Routinely, it is not recommended. Early to move the child unless it is a bedridden. And if you have a risk factor, that's the time we need to think about a DVT prophylaxis. Routine, there is no recommendation for DVT prophylaxis. That's what we are talking till now. We are talking about what the past, what the present survival sepsis campaign, which is came in 2020, what really we are practicing. We have discussed about that. Few minutes we'll focus on what the future ahead in the sepsis. You know that sepsis is one thing which is more likely to cause a death if the patient slips into the sepsis, septic shock and refractoriness. That's the time where the mortality is more likely to be. So the sepsis and septic shock, this is the time your risk of mortality will increase. What the new things are emerging in the thing one is a Pseudomonas aeruginosa antibodies or staphylococcal antibody, that is MEDI 3902, it is Pseudomonas, whereas Survantec, it is for your anti-staphylococcal, and also antitoxin things. We need to be looked at ClO2, and thrombomodulin is another thing, IL-7, nivaximab, GM-CSF, and these are some of the stem cell and alkaline phosphatase, these things, human recombinant alkaline phosphatase. So, and celepressine, these are the things which are the new emerging modality of a treatment. Basically, what these things is, you are acting at the initial stage, not allowing the patient to slip into the sepsis and septic shock so that you can bring down the mortality. These are all things still in a trial stage. Let us look at the few things. When you look at the virulence factor, so anti-staphylococcal RS antibody, that is survantaximab. This is the one thing which may be the in the near future, it may be the thing. So at the moment, we are not using it. It is not available. Anti-Pseudomonas aeruginosa antibody, that is MED 13902. This is a trials has been conducted and promising result. We need to be looked into those things. And targeting the toxins, virulence factor, we are targeting the thing. ClO2 is one of the things where safety profile is good, efficacy in line with expected benefits in neutralizing the toxin. So when you are neutralizing the toxin, these things can be considered. At the moment, it may not be the reality in the clinical practice. Thrombomodulin, basically, this is a thing which is basically looking at a patient with a sepsis-induced coagulation derangement. That is the place where it can work, thrombomodulin. But these things, good to know, it may not be in the routine practice. Interleukin-7, so where you are acting, and basically it will help you to improve your circulating lymphocyte like CD4 and CD8. That may be the futuristic thing. Celepressine, this is a selective V1A agonist. When you are talking about vasopressin and celepressine, celepressine is one of the things where your need for noradrenaline is going to be cut down, and total duration of usage of noradrenaline can be brought down by using a celepressine. So in a selective patient where catecholamine resistant shock is there, that is the time you introduce this selective V1A agonist like celepressine, may be the futuristic thing. We need to follow it in a clinical practice. Methylene blue is one of the selective inhibitor of guanyl cyclase. It reduces the excessive production of a nitric oxide. It increases the mean arterial pressure, reduces the catecholamine, and intravenous boluses of 2 milligrams. We do use this type of a thing, but when you looked into the result, result may not be that great. We can use on case-to-case basis, not as a routine recommendation in the practice. We have tried these things in a patient who has been refractory with the catecholamic hydrocortisone. When we have just run out of an option, that's the time where we consider methylene blue is one of the things, not in things. But remember, before using a methylene blue, G6PD needs to be ruled out. There is a contraindication for that. When they looked into the literature, also methylene blue administration in a patient with suspected increases the mean arterial pressure, systemic vascular resistance, decreases the vasopressin requirement, and increases increased pulmonary artery pressure resistance. That is might be avoided within some continuous infusion and all. But my experience with methylene blue is very limited. We have used in a few cases, not very promising results. What about antioxidant? These are the things, especially stress-induced things, where it may be a tried thing, but no universal recommendation which is related to the antioxidants also. Thiamine, we are all talking about last few years, we are talking about a thiamine. Thiamine, yes, it is very relevant if it is a deficient, thiamine deficiency associated with septic shock. But in general, thiamine recommendation may not be. If there is a thiamine deficiency develops, you can give in a 2 weeks of insufficient, when there is insufficient intake during that time, you can use it, but controversial. What the literature says, when they looked into the meta-analysis, which is published in an American Journal of Emergency Medicine, which is no benefit as compared with a placebo. This is an article which is published in 2020. We did a study for almost in 87 patients. We used in a thing which compared with in a control. There is no significant differences between the thiamine and placebo group. This is our own study. We are yet to publish because this is in still in an analyzation stage. So most probably we will be publishing it in the next few months time. We are publishing this. So there is no role of thiamine in the case of sepsis unless there is a sepsis deficiency is there. Why I'm talking about these things? These are the things which has been talked in the last few years. That's why we need to remember these things. So with this, once again, I thank you, AAP organizing team, Dr. Muralidhar Reddy sir, Nagendra Prasad sir, and Dr. Durga Prasad sir, Pawan, and Dr. Radhakrishna sir, Ramakrishna Paramahamsa sir, and all the team for giving me an opportunity. Thank you very much.
That is a wonderful lecture on sepsis, septic shock, and principles of therapy. And thank you, sir, for sensing as a general pediatrician like me on various aspects of septic shock and touching upon the various newer molecules which are going to come into the therapeutic armamentarium in the near future also. Thank you very much, sir.
Thank you.
I would like to request Dr. K. Nagendra Prasad and Dr. P. Durga Prasad to felicitate Dr. G.V. Basavaraja.
Sir, small announcement. Who is Dr. N. Nagarjuna Reddy garu? N. Nagarjuna Reddy garu. Sir, please go to reception.
Thank you, sir. Thank you all. I would like to call the chairperson of the session, Approach to a Child with Viral Marker Negative, Dr. V. Sudip Teja Reddy, Pediatric at Nidwit Krishna Children Hospital, Anantapur, on the stage to introduce the speaker, Dr. V. Nahendra Kumar.
Good afternoon, sir. I would like to thank firstly organizing committee members and Muralidhar Reddy sir for giving me this opportunity to come over here as a chairperson for this session. Now I would like to introduce our speaker, Dr. Nagendra Kumar. He did his MBBS from KIMS Bangalore and MD Pediatrics from GMC Surat, Gujarat. And he has done his postdoctoral certified course in pediatric gastro from SGPJ Lucknow and DM in pediatric gastro from SGPJ Lucknow. He has presented many papers and awarded in international conferences and is a young investigator, had an award from SPGON at Geneva in 2018. And he had many publications in national and international journals. And he is now a consultant pediatric gastroenterologist and hepatologist at Manipal Hospital, Yeshwantpur, Bangalore, and consultant at Indira Gandhi Institute of Child Health, Bangalore. Please welcome, sir.
Announcement. Hall B session is resumed. Whoever interested, please move on to Hall B.
Good afternoon, all. Thank you, chairpersons. At the outset, I would like to thank Organizing Secretary, Dr. Muralidhar Reddy, and also his team, and AP PEDICON for providing this opportunity. And this is a wonderful platform where we can discuss a gastroenterology topic, predominantly hepatology. So, and I would, at the end of the topic, you'll have a lot of takeaways and messages, and so that will help in your practice in the future. Thank you. Can we roll the presentation? This one. Okay. Yeah, today I will be predominantly talking on a child walking to your OPD with a jaundice, and mostly the previous consultant or a pediatrician or yourself has got the viral markers done, which is negative. So now I would discuss about that with a lot of case scenarios. So what is jaundice? Jaundice, by simple terms, is a yellowish staining of the skin and sclera by the abnormal high blood levels of bilirubin. Sclera and skin getting stained by bilirubin is what we call it as jaundice. So most of the times what I stress upon to the parents or child that it's just a symptom, it's not the disease. So many times they have a monologous treatment protocol, just do this, do some dietary restriction and give some multivitamins and some medications. And then most of the times patients also perceive, parents also perceive that jaundice is the thing where you can go to a lot of complementary alternate medications and things will settle by 5 to 6 days. So however, this is not the case. There are so many etiologies, especially in the kids, we have a wide array of disorders, unlike adults. So we have a lot of metabolic genetic causes, and I would be illustrating those, few of those in subsequent slides. So there are a lot of clues in the history. Very simple history would almost always give you a lot of clues to the diagnosis. And most of the times with the advancing ages, we are more and more dependent on the investigation and less for the simple clinical symptoms or signs. So when you look at the jaundice, there are two reasons for jaundice. One is there is a direct hyperbilirubinemia, and second is indirect hyperbilirubinemia. How will you differentiate clinically what kind of jaundice you are dealing with? Because most of the times I see there is a lot of confusion among the treating doctors that will straight away jump into doing investigations and also explaining the parents to do a lot of dietary restrictions and all. See, simple question like what is the color of the urine? So if it is consistently yellow in color, that means you are probably dealing with direct bilirubinemia. To give you an example, so there was a child probably around 5 to 6 years of age who came with the jaundice and urine was high colored. But unfortunately, the lab over there reported indirect hyperbilirubinemia. So a lot of people, the subsequent consultant were worked up for all indirect bilirubinemia. But as the urine color was very high, so I said, no, this probably looks like a liver. It's not a indirect hyperbilirubinemia. And we repeated the LFTs. It came out to be direct bilirubinemia. So simple question is very important. And when you look at the direct bilirubinemia, you are dealing with two things. Either it's a intrahepatic causes or it is a biliary causes. So we'll see how to differentiate these conditions and how to, you have to ask one more simple question whenever child comes with conjugated bilirubinemia is the stool color. So if the stool color is pale, probably you are dealing with obstructive jaundice. If the stool colors are pigmented, probably you are dealing with non-obstructive jaundice. So these are the two simple questions. So you are almost there that where exactly the problem lies. So what else clinical questions that you would like to ask? So one is age. So unlike adults, it's mainly alcoholic hepatitis or non-alcoholic steatohepatitis or hepatitis B or C, we have a special privilege that children have a different etiology at different age. So if 1 month child comes with jaundice, the etiologies are quite diverse. The 5 years child comes with jaundice, 10 years comes with jaundice, 15 years comes with jaundice. So the etiologies vary with the age. And the second is duration of the disease. So duration of the disease is very, very important to think about so many underlying problems. Is it just an acute hepatitis? Is it just a chronic hepatitis? Are you dealing with acute and chronic? Or you are dealing with hyperacute liver failures and all. So duration is very important. Stool color and urine color I have already explained to you. Pruritus is one more important manifestation to detect the cholestatic liver disease, not to the obstructive jaundice. Definitely obstructive jaundice causes the cholestasis. So pruritus, again, if the child comes with jaundice and pruritus, you have a differential of cholestatic disease. It's that simple. And anemia, so there are some liver disorders where they have a associated with hemolysis or dyserythropoiesis. And then you have to look at the anasaka, ascites and stigmata of chronic liver disease. So then why this is very important, you'll realize in the subsequent slides when I discuss few case scenarios. And history of phototherapy, of course, it's very important. And recently I saw a child, so I'll be discussing that case. So straight away to go with the cases, 14 years boy, he came with yellowish discoloration of sclera for 2 weeks, that is jaundice for 2 weeks. And then similar episodes of jaundice since 3 to 4 years of age, at least 4 to 5 times. So parents say that his eyes are always looking yellow, and 4-5 times it became more. They gave some treatment, they gave some boiled rice and restricted all those things. and then oily foods and all that, jaundice came down. But always his friends, or we feel that his sclera is always yellow. Otherwise, there is no history. And then there is a icterus, it's a lemon yellow color, and liver is normal, spleen is normal, normal sensorium. And again, the important clue is urine color is clear. So we are dealing with indirect hyperbilirubinemia. So as we guessed in a previous slide, so the investigations also suggested that bilirubin was total was 4.21, while direct was only 0.15. So this qualifies for indirect bilirubinemia. So when will we call it as a direct bilirubinemia? If the total bilirubin is 5, so the direct bilirubin should be more than 1. Or if bilirubin is more than 5 and the direct bilirubin should be more than 20%. So that time we'll call it as direct bilirubinemia. Here it is classically indirect bilirubinemia, and then otherwise LFT is bang normal, ultrasound normal. So what are the possibilities now? So we have a child, almost adolescent boy, coming with recurrent history of jaundice. So, and investigations and clinical sense say this is the indirect bilirubinemia. So do you think hemolytic disorders? There was no anemia, Crigler-Najjar type 1, type 2, or Gilbert's. These three are the disorders of bilirubin metabolism. So hemolytic disorders are out of question because we don't have anything about hemolysis in the bloods or in the clinical history. Phenobarbital was not helpful. So some point of time, some consultant had started phenobarbital, but however, jaundice did not come down, or it didn't help. So Crigler-Najjar type 1, they generally cause quite high jaundice. I mean, the bilirubin goes beyond 25, 35, 40, 50 also. And then type 2 generally responds to phenobarbital. So this is not type 2. So probably this is Gilbert syndrome. So we got a triple repeat sequencing of this child. So it came to be a positive for promoter region UGT1A1 gene mutation. So with the phenotypic and genotypic correlation, we are more or less thinking about Gilbert's disease, Gilbert syndrome. It's by far most common compared to Crigler-Najjar type 1 or type 2. So the overall prevalence is, in some studies, is estimated to be as high as 5 to 7%. But in my general clinical practice also, I'll see a lot of Gilbert syndrome, and then few cases of Crigler-Najjar type 1 and type 2. So these are the causes of indirect hyperbilirubinemia. So very recently, I saw one more child in prestigious Indira Gandhi Institute of Child Health. So basically, this child came with yellowish discoloration of jaundice since birth almost, and child is on regular phototherapy. The moment they used to go to hospital and get a phototherapy once in 2 to 3 days. They tried home-based phototherapy. Then also serum bilirubin was around 20 milligram per deciliter. The pediatrician referred to me for liver transplantation, but by the time they came to me, so the child had stopped phototherapy and phenobarbital and went for complementary alternate medication. So this is the problem we have with the jaundice. The people go for a lot of complementary alternate medication, and they stopped phototherapy and phenobarbital. Subsequently, child had a bad kernicterus and child had a regression of milestone. And already the genetics was done. So this is a classical way the Crigler-Najjar type 1 presents. And even they have given a phenobarbital which didn't help the jaundice to come down. So coming to next one more entity of disordered bilirubin metabolism. So this child, 12 years girl, adolescent girl, she came with jaundice with high colored urine this time. So we are dealing with conjugated bilirubin and pigmented stools again. So we are not dealing with obstructive jaundice, no pruritus. Otherwise, there are no other things that suggest there is liver is involved. So we are dealing with conjugated bilirubinemia. However, there is no other manifestations of liver disease. So we should remember that there are so many times we get a liver disease even without jaundice. Very recently, I diagnosed a child with Wilson disease. Maybe 2 weeks back, that child had just elevation of SGOT and PT. and some non-specific symptoms. So don't expect jaundice to be there in all the time with all the liver diseases. So early stages, you just see the abnormal LFT. So that's why LFT. So again, you can see that there is a conjugated bilirubin. Otherwise, LFTs are normal. And there is a one important clue in this condition. So when we did a liver biopsy, it showed a dark pigmented liver disease. So what could be the cause when you do the biopsy and it is a dark pigmented? Normally you see yellowish biopsy when you do the biopsy in the liver. Okay, so what are the differentials in these conditions? Anyone? Conjugated bilirubinemia, no liver involvement, no hepatitis, nothing. Very good. So Dubin-Johnson syndrome is what we see probably the cause in this because of dark pigmented liver tissue. That's because of abnormal deposition of bilirubin pigments. Rotor syndrome is again one more differential, but you see a normal liver in that. So anyway, we didn't do the genetics and we need to do it in that child. So anyway, now, so that is the one segment where liver is not involved. That means there is no hepatitis, but there is some bilirubin metabolic defects. So now when you look at the jaundice with hepatitis, so viral hepatitis, I'm not going to talk about. Non-hepatotrophic viral hepatitis, like classical example is dengue or enteroviruses, which again I'm not going to talk. Bacterial and rickettsial infections can also cause hepatitis. So now what I'm going to talk about is jaundice without jaundice with hepatitis without viral etiology, like autoimmune liver disease, Wilson disease, drug-induced hepatitis. Most common is anti-tubercular therapy. Poisoning. Recently we had ratol poisoning. That child died while awaiting for transplant. So that child has yellow phosphorus. Metabolic liver disorders, neonatal hepatitis and cholestasis, and vascular disorders may also present with hepatitis like Budd-Chiari syndrome and biliary disorders. So what is hepatitis? So we should always, hepatitis is in a simple terms is inflammation of liver where there is an elevation of SGOT and SGPT. If transaminases are not elevated, this is not hepatitis, as simple as that. But what we get in the range, like lab specifies like 40 as the upper limit of normal. No, we should always go to the nomogram, like what we do for any other disorders in childhood. We should see the nomogram. So suppose 4 or 3 years child comes with a SGOT of 42 and SGPT of 44. So that's not the end of the story. You should generally they are around 18 to 20. If the clinical situation is like that, there is some jaundice, OTPTs are just 44, 45, still it can be hepatitis. You can't just rule it out that this is not hepatitis. So when you look at the hepatitis, there are various ways to classify or describe the hepatitis. One is acute hepatitis, short duration, within 2 months is a maximum duration that we take, 1 to 2 months. Then chronic hepatitis, when the hepatitis lasts more than 2 months. And then acute and chronic. So we should be very aware of this situation. There are some situations when there is a chronic hepatitis is going on the top of that, there is some acute insult like acute viral hepatitis, acute sepsis, or drugs. So that can collapse the liver and they rapidly go to liver failure, and they won't recover easily without early intervention, or maybe even they require a liver transplant. So this presentation, definitions, classification largely depends on clinical presentation. And LFT, I think we had a wonderful session in the morning about the interpretation of liver function test. And then final, very specific to us for the pediatricians and pediatric hepatologist is neonatal hepatitis. So coming to the case for 12 years girl, she came with very mild pain abdomen, no fever, no vomiting, nothing to suggest a lot of prodrome. Then child had jaundice with high colored urine. Shown to pediatrician, okay, this is a viral hepatitis, and started on some multivitamins and dietary restrictions. And then when child came, the icterus was there, liver was very soft, 1 centimeter, and then spleen was not palpable, nothing, no ascites, no CLD. But there was one more important clinical clue that the child had a jaundice for 1 to 2 weeks at the age of 5 years. So this is what the initial, so we thought of acute hepatitis and we got a LFTs. LFT showed bilirubin of 5.1 and 4.2. SGOT-PT, you can see it's a tremendous increase in SGOT and PT. So you can see that it was almost 620 and 728. And again, AST was 1126 and ALT was around 1230 on the repeat LFT. So now we are sure that this is a hepatitis, and now we are sure that this is acute hepatitis. Okay, so very short history, but we had a history of similar episode in the past and very high SGOT, SGPT with mild coagulopathy. So INR was 1.7, so which is considered as a coagulopathy. INR more than 1.4 is abnormal. So acute hepatitis. So what are the causes of acute hepatitis? Viral hepatitis, most common, hepatitis A and D. Autoimmune liver disease, infectious hepatitis, non-viral, like dengue, malaria, enterovirus, and Wilson disease. So in this child, hepatitis A was negative, E was negative, B and C were negative, and the ceruloplasmin was normal, which we do for Wilson disease, and KF ring was negative. So now what will you do next? So now you have a child who comes with just an acute hepatitis picture and all viral markers are negative. So we should just open up the book and see other differential, or we should have a good experience about managing these kind of cases. Autoimmune is one more very important. She is an adolescent girl. These are the periods where the autoimmunity will increase. And there was a similar history of jaundice, 5 to 6 years of age. I'm not saying that, that can be hepatitis A, this can be hepatitis E, but still you should consider single entity for both the episodes. So here you can see anti-LKM was positive and IgG was very high. If you go back and see the LFT, you have one more clue in that. So gamma globulins were quite high. You can see total protein is 8.8 and albumin was 4.4. So gamma globulins are high. So that means IgG is high. There is some inflammation going on, and the liver biopsy showed classical features of autoimmune hepatitis. So this child had a autoimmune hepatitis type 2 presenting as acute hepatitis. So now what are the causes of acute hepatitis? So infective is one. Second is drug induced. So there was a child who was given HRZ for 6 months instead of giving HRE, and the child ended up in acute liver failure, and the child had to go for liver transplant. Unfortunately, they were not affording, so the child died. Second is autoimmune liver disease, which we talked about, poisoning, resveratrol poisoning. That child also died because of acute liver failure. And then mitochondrial cytopathies can present like acute hepatitis, and acute Budd-Chiari syndrome, ischemic hepatitis. All this can present like a acute hepatitis. Coming to next case, I'll go a little bit fast. Only 10 minutes is left. So child presented with a prodrome this time. So child had a prodrome in the form of fever, weight loss and all. And then child had a jaundice with high colored urine. Then showed to multiple doctors. Then day 20, just 15 days, just 2 weeks after onset of jaundice, child developed ascites and anasaka. So admitted to the hospital, then given a diuretics and antibiotics, and then child started developing abnormal sleep pattern, probably hepatic encephalopathy, and referred on day 25. And child also had an history of similar history of jaundice for 1 month, 6 months ago, and given some locally available medicine, and then child got better. So on examination, there was a jaundice, anemia was there, anasaka, grade 2 encephalopathy, and there was a firm liver measuring around 2 to 3 centimeters, and the spleen of 5 to 6 centimeters. And this is the first albumin, at least when we received. the LFT showed albumin of 2.8. So that is quite low, suggesting there may be a long duration process. And the INR was quite high. Child was in the liver failure. So when we call the child as liver failure, with encephalopathy, if INR is more than 1.5, without encephalopathy, if INR is more than 2. So, and if there should not be any chronic underlying liver diseases, then we call it as acute liver failure. So this child ascitic fluid examination showed portal hypertension, SAG was 1.6 with spontaneous bacterial peritonitis, and ultrasound showed there was hepatosplenomegaly and signs of portal hypertension. So now you have a 14 years girl. So overall duration is just 3 to 4 weeks, and jaundice with prodrome, ascites with anasaka, hepatic encephalopathy, and past history of jaundice. Is this simple hepatitis acute liver failure, or it is? Do you think it's acute liver failure? I mean, there is something else in this child. So I think there are a lot of indicators which suggest it's not simple acute hepatitis. So my clinical differential was acute and chronic liver failure. So acute insult can be viral hepatitis or some complementary alternate medication or some other non-hepatotrophic viral infection or sepsis, autoimmune hepatitis, fulminant Wilson can present like this, and chronic hepatitis B or C underlying. So at the time of admission, we gave antibiotics and medication to support hepatic encephalopathy, albumin, paracentesis, and all support care. So hepatitis A came as positive and listed for liver transplant. If child not's gonna better, so we'll do the liver transplant. We are running a affordable liver transplant. So if patient can arrange some 5 to 6 lakhs, rest all we can take care and get the liver transplant done. So now, so we didn't stop at here because we just got hepatitis A. That's not the end of the story. So we did a chronic liver disease workup. So here you can see again, LKM was positive in this child. So this child was on the all odds. I mean, I pushed not to go for liver transplant. And even though the transplant surgeons, adult hepatologists and all were willing for getting child to transplant. So because child was doing better on corticosteroids and azathioprine, ultimately child did quite well, and now she's alive, healthy, and attained her secondary sexual characters and all, and she's going to going for her college without any transplant. So sometimes you should not stop at whatever you get. So unless you have a clinical suspicion of other things, you have to rule it out. So this was a case of hepatitis A with autoimmune hepatitis type 2. So third scenario is jaundice with high colored urine, again jaundice. And here after 1.5 months, child developed ascites and then anasaka. And we had an important family history that elder sister died at the age of 10 years with the similar history of jaundice and ascites. So this child has an examination had grade 2 clubbing. Again, it is one of the marker of stigmata of CLD, and then growth failure and anasaka. And then again, you can see very low, poor synthetic functions like albumin was 2.1, INR was 2.8, OTPTs were not very high, and bilirubin was still 9.4 and 8.8. So again, this child had the ascitic fluid suggesting portal hypertension. And then ultrasound also showed evidence of cirrhosis with portal hypertension. So now we have a child, simple jaundice for almost 2 months, 2.5 months, ascites and anasaka with a history of sibling death. And then there was a stigmata of CLD and portal hypertension. So now we have enough evidence in the history and examination that this is a chronic liver disease. So what are the causes of chronic liver disease? Most common in India is Wilson disease, followed by autoimmune hepatitis, followed by hepatitis B and C, and some rare metabolic disorders like tyrosinemia and all can present with chronic hepatitis. So viral markers were negative, ceruloplasmin was less than 8, KF ring was present, 24 urinary copper high. So according to ASLD guidelines and all, if all the 3 parameters are positive, we are more or less sure that it's a Wilson disease. So child got better after treating Wilson's. And sometimes there are some children who doesn't get better even after diagnosing at this stage. So they might require a liver transplant in future. But there are some subset of children who can get better, who will get better with just a chelation. So another case, this is smaller, I mean, infant, 11 months girl. So jaundice with for 9 months and pruritus. So this child had a pruritus and child had an intermittent steatoria. We generally don't take that history, but when there is a suspicion of cholestasis, always take this history, that intermittent steatoria. And this child again had a pigmented stools and urines. So we are not dealing with obstructive jaundice, even though there is a pruritus, but we are dealing with some form of cholestatic jaundice, which is not neither obstructive, but it's a cholestatic. So itrus was present and lot of scratch marks over the body, and the body became ichthyotic, very thick and ichthyotic and shiny nails because of lot of scratching and rubbing. No facial dysmorphism. This is very important. One of the DDs is Allergic syndrome, where you have a facial dysmorphism, and liver is firm and spleen is also firm and 5 centimeter, which suggests that there is some portal hypertension or liver fibrosis. So here the glaring factor in the LFT is GGT. GGT is just normal or low. Whenever you see a cholestatic disease, you generally expect gamma GT is quite high, but this is a normal gamma GT. And so we have a normal gamma GT cholestasis in a 9 months boy. So here the set scenario is cholestatic liver disease. We saw acute, chronic, acute on chronic, and this is a cholestatic. So what are the causes of cholestatic liver jaundice? PFIC, progressive familial intrahepatic cholestasis, 1 or 2 in this setting, but there are almost 7 to 8 types of PFICs now, and paucity of intralobular bile ducts or Allergic syndrome, and then bile acid synthetic defects or sclerosing cholangitis. These are all the causes of infantile cholestatic liver disease. So, however, in this case, we don't have anything to suggest allergies. Bile acid synthetic defects are not very common, and sclerosing cholangitis is also not very common, and the gamma jet is normal. So we are more or less dealing with PFIC. So the genetics of this child came to be positive, like progressive familial intrahepatic cholestasis type 2. So that's about the cholestasis. So now I'll be talking about the case where we have a echolic stools with the jaundice in 1.5 months or 48 days old. So here we are dealing with obstructive jaundice. So can you see the stool color? It's a pale color. Otherwise, child is doing well. So this is a problem with this condition where the stools are pale, but most of them consider it as a normal, and then urine color is pigmented, but child is growing absolutely well. So we say that show it to the sun and all those things, just give some diet and all. So many times many would do that, and child land up to us quite late where we can't do anything apart from liver transplant. So this is Taiwanese stool chart, and my parent institute SGPJ, they are developing one more stool color chart for Indian children. So this is, in this you can clearly see that they are quite pale. So liver was quite firm, spleen was quite firm, and you can see alkaline phosphatase and gamma GT both were quite high. There was a cholestasis, there is a cholestasis, and the INR was 2.82, which is corrected to 1. So this is a classical case of neonatal cholestasis with obstructive jaundice. So what are all the causes? So biliary atresia and choledochal cyst. So these are the two important differential when you get a clay colored stool with neonatal cholestasis. And the biopsy and intraoperative cholangiogram suggested this is a biliary atresia and child got a surgery done. It's a final case. So pigmented stools in a setting of neonatal cholestasis with a stormy neonatal course. The bilirubin was rapidly escalating and the liver functions were rapidly worsening. Here I could see a faint cataract in this child. Otherwise, there is no facial dysmorphism. And the liver was 4 centimeters, spleen was 1. There was mild ascites and INR is 1.8. So 20 days child with faint cataract, rapidly worsening LFTs and coagulopathy. What do you think? Galactosemia. Yeah. So neonatal hepatitis with metabolic liver disease differentials galactosemia, tyrosinemia, and other metabolic disorders. So galactose levels were high. So galactosemia was a clinical diagnosis. But here I got very specific test, galactose 1-phosphate enzyme activity, which was normal. So what to do next? GGT was normal. Yeah. So genetics will take 1.5 month time. So now the jaundice is worsening very rapidly. Child will die in 1.5 month if you leave it like that. So here I had a very strong that this is a galactosemia only, despite galactose 1-phosphate. There are some variants, Duarte variants and all. So started treating as a galactosemia. After 1.5 months, child became 2 months of age, came as a galactosemia 1, classical galactosemia. So again, clinical sense is what helps. These are the causes of neonatal cholestasis. So clinical sense and examination is key to diagnosis. Etiology is quite diverse, and we need to have a lot of differentials in mind when we consider. Again, like age and duration gives very, very important clues, and LFT is very, very valuable investigation and early identification and treatment. So that galactosemia case was referred as early as 15 days of age, so that we had enough time to diagnose. Otherwise, they'll come in completely ascites with sepsis and all. It becomes very difficult to manage at that stage. And with the expanding horizon of treatments and the investigation modalities, we have genetics, metabolic screening, we have a liver transplant to offer. So nowadays, we should not allow any child, especially with the liver disease, to die or to succumb. So with these messages, I would end my presentation. Thank you all for patient listening. Sorry for overshooting the time.
Thank you, sir. Thank you, sir. It was an elaborative presentation, very useful for practicing pediatricians to differentiate clinically from obstructive and unconjugated and conjugated hyperbilirubinemia. Thank you, sir.
I would like to request Dr. V. Sudip Teja Reddy to felicitate Dr. V. Nagendra Kumar. Thank you, sir. I would like to call the moderator of the session, Neonatal and Infant Feeding Practice and Fallacies, Dr. P.V. Rama Rao, to introduce the I would like to call the chairperson of the session, Neonatal and Infant Feeding Practices and Fallacies, Dr. P. Srikanth Reddy, Senior Pediatric from Anantapuram, on the stage to introduce the moderator, Dr. P.V. Rama Rao.
గుడ్ ఆఫ్టర్నూన్ ఎవ్రీబడి. మన తెలుగులో జగమెరిగిన బ్రాహ్మణుడికి జందమేళ అని ఒక నానుడు ఉందండి. సేమ్ థింగ్ డాక్టర్ పివి రామారావు గారు, డైరెక్టర్ అండ్ సీనియర్ పీడియాట్రిషియన్ ఫ్రమ్ ఆంధ్ర హాస్పిటల్స్. He did lot of studies on non-invasive ventilation, and he is having ample publications in various journals. And and he is doing a lot of service to the public through various programs in and around Krishna Guntur districts. చాలా సార్లు మహేష్ బాబు గారిని కన్నా రామారావు గారిని ఎక్కువ సార్లు మనం చూస్తుంటాం న్యూస్ పేపర్లో. మహేష్ బాబు గారు, రామారావు గారు కలిపి. With this, I will hand over the chair to Dr. Ramarao garu.
Thank you, sir. No, thanks for your kind introduction. So we need more audience. Please don't go away. I know it's adult feeding time, but no, stay back. I think you would definitely have some take-home messages. Note to call upon. Now I'm going to introduce our panelists. Oh, this is me, Head of Children's Services and Director, Andhra Hospital, Vijayawada. Thanks for your kind introduction, sir. And next one is Dr. Sai Sunil Kishore. This point. This change. Pointed and this one. Okay, this one. Yeah. Yeah, shall we move on the chairs now? Who is? Chairs. Sorry, sorry for this. So I would like to introduce Dr. Sai Sunil Kishore. He's a consultant, a neonatologist and clinical head from Medicover Hospital, Visakhapatnam, and he's also associate professor from some MIMS. And he's a very experienced neonatologist in the state of Andhra Pradesh, and so one of the renowned consultants in our country. And he had so many publications under his belt, and so now he contributed as a speaker in many state, national, and international conferences. No, thanks for having me, sir. Next is Dr. Vamsi. So everybody said no, all are in youth people, including me. Vamsi is a consultant neonatologist and pediatrician from Rainbow Children's Hospital, Vijayawada. He had certified training in research methodology and biostatistics, and he's a national trainer for neonatal resuscitation program and also neonatal emergency simulation team training. He's a member of editorial review board, Rainbow Pediatric Journal, and he's also executive member for IAP AP State branch, and he had so many publications on his belt, and his specialty of interest is point of care ultrasound in neonates and care of ELBW babies. So next one is I would call upon Dr. Sarath. Sarath is director and chief of child health from Kane Hospital, Vijayawada. He is a winner India 500 Startup Awards in 2019, and he is also winner International Forum on Advancements in Healthcare for Best NICU Design. That's again in 2019. He is a core faculty for the National Ventilation Workshops, and he is also a national faculty for QA and QC. His special interest is NICU dialysis and HFOV. Next, I would like to call upon Dr. Sangamitra. Sangamitra, she did MD from Deccan Medical College, Hyderabad. and she did her DM from Sri Ramchandra Medical College, Chennai. She trained in developmental assessment of Indian infants, and she had best poster presentation, and she also got in a gold medal as the best outgoing student in DM in neonatology. And her area of interest is mainly in mist. Next is I would like to call upon Shashi, Dr. Shashi Bhushan. He's a consultant and neonatologist at the Neo-Nest Hospital, neonatal intensive care unit at Chandana Nursing Home, Guntur. And he had some publications under his belt, and he's the author for Cochrane neonatal database. He's also executive member for IAP Guntur, and his area of interest is in care of extreme preterm newborns. So I think without wasting much time, we would go to the, our talk. Our talk is mainly on practices and fallacies. We'll try to engage you in the next 45 to 15 minutes time or so. So please concentrate. So I'm going to concentrate on preterm feeding and breastfeeding, complementary feeding, micronutrients supplementation, preterm formulas, bit of about preterm formulas, human milk fortifiers, and some more miscellaneous one. So first one is I'll start with the scenario. It's a 28-weeker, weight is 1.1 kilo, male baby, PROM, normal delivery. It's an RDS, surfactant deficiency lung disease was there. The given surfactant ensured, and baby was on BiPAP, so maintaining in air with pressure of 5. So hemodynamics was normal, neurosonogram was normal. So this is a scenario. So this is the nutritional requirements for preterm infant. So as you all know that preterms and in particular in the low birth weight babies, they need kind of more calories, and then protein requirements are high when compared to the term babies. It is a 4 to 4.5. And then I could say the electrolytes requirements, sodium, potassium, calcium, and other vitamins and iron. So we will go to the first question to Sunil. So when to start feeds in a preterm infant? So pretty basic one to you, but.
So I think this is one of the common scenario which we come across in level 3 and level 2 NICUs, 28-weeker, 1 kg. So initially you do your stabilization. So the straightforward answer to this question is like you have to start as early as possible. So once you stabilize the baby. So stabilization doesn't mean that actually the baby should be out of ventilation and out of CPAP. Once you are done with your initial respiratory management, surfactant, and once you start CPAP, so after that actually you can start feeding in this baby, enteral nutrition in this baby. Usually in our unit we start anywhere between 2 to 6 hours of age. Once you are done with the early rescue surfactant, so we'll do in that way, and definitely should be started on day 1. So there are many benefits of starting enteral nutrition early. So one thing is actually the time to reach full feeds will be less, and there will be better feed tolerance, better discharge parameters, and better catch-up growth also. So that's why it is recommended to start as early as possible. But having said that, actually there can be occasional situation like in certain selected group of babies, we need to actually postpone a little bit. So there are certain high-risk group of babies. One is these days actually we are commonly seeing babies with Doppler abnormalities. So many times actually you will have the scan finding absent or reverse endoastralic flow. So which means that actually there is already some in utero, uteroplacental insufficiency is there, and these babies are at risk of mesenteric ischemia. So these babies are at risk of early NEC. So in that setting, actually we delay by 24 to 48 hours of age. So once the baby is stabilized, abdomen is soft, and radiologically the gas pattern is fine, and bowel sounds are good. So you can start on day 2. Probably we delay by 24 hours or so. And another setting is like a baby who is extreme SGA, severe SGA babies, either it's a preterm or term SGA babies. So in that baby, we need to delay a little bit. Or if the baby is requiring inotropes, like babies on DOPA, DOBITA, or any other adrenaline infusion, so in those babies will delay again. and babies with severe perinatal asphyxia. So these are 4-5 important high-risk groups where you can delay initiation of enteral nutrition, but otherwise, so bottom line is like take-home messages, we have to start as early as possible on day 1.
That was excellent, Sunil. So now my question is, do we really need to delay the feeds in a baby with with the absent or reverse industrial flow? What is the recent evidence?
So actually there is a lot of literature on that, and ADAPT trial is one of the important trial actually which has looked at this particular issue. So what according to the meta-analysis and in that particular large RCT also, actually it says that even if you start on day 1 also, the incidence of NEC is not significantly increasing. But the thing is actually again there is a subgroup analysis which says that less than 30 weeker you should be less than 30 weeker with AREDF, absent reverse endosteric flow, you should be very careful. So in this subgroup, actually, there is increased risk of NEC. So the bottom line and what most of the neonatologists across the country, even in West, their practice is, if there is a definitely reverse endosteric flow, you should be extra cautious. Absent is still okay. You can start at the end of 24 hours. So reverse endosteric flow, probably once you confirm with your bowel that bowel is healthy, you can start on day 2.
Okay. Thank you, Sunil. I think it's very clear. So basically, so you need to be careful when you start feeds, in these, so babies, preterm SCA and, term IUGR babies, especially, babies with complex congenital heart disease. There is no absolute contraindication, but so you need to be a bit careful, so look at the other things and then, start feeds. And babies who are on steroids, and babies who are on indomethacin or ibuprofen treatment for PDA, and in polycythemic infants, need to be a bit more careful before we start feeds. But then, as I've said, that there is no absolute contraindication. So next question is, what is the trophic feeding? That is a minimal enteral nutrition. What should be the rate of advancement of feeds? This is to Vamsi.
Hi, sir. I think trophic feeding, as Dr. Sai Sunil Kishore was telling, we need to start as early as possible, ideally within first 24 hours of life. The volume would be around 10 to 15 ml per kg per day, or the upper limit is 1 ml per kg per day. Around 24 ml per kg per day is what we call it as trophic feeding, not more than that. So the volumes are started little carefully in the smaller babies, that is especially like extremely low birth weight babies and less than 28 weekers. We might start at the lower spectrum and gradually increase. And the second question is regarding the escalation of the feeds. Escalation of the feeds, again, on this, the science is like changing. Initially 10 years back, I think most of us were on the same page saying that it's always better to start or target slow volume increase. Around 15 to 20 ml per kg per day is what we used to do. Because initially at that time, our evidence was from only a small Cochrane analysis of 4 studies. But now if you see the same review, which is updated in 2020, there were 14 trials in that. So there was strong evidence saying that, I think even in ELBW, including, because initially we used to be confident of faster escalation in VLBWs. Now from 2020 with that evidence, we are confident about faster escalation. That is comparison between 20 ml per kg to 30 to 40 ml per kg. So we can escalate faster even in extremely low birth weights, extreme preterms, including IUGR babies. But again, the take-home message is start at the lower spectrum, especially in extremely low birth weights, IUGR babies, and also extreme preterms, somewhere between 20 mils per kg. And also we should have a fixed protocol in your like NICU. Because see, I can't take a call and some other person comes in rounds and he can't take some other like protocol. The ideal way to go forward regarding feeding is each unit, based on your practices and based on your consensus, you have to make a feeding protocol, stick to it, and make sure we closely monitor the newborns during your feed escalation. And any signs of early feed intolerance, we need to have more caution and go more slowly. Over to Ramaro, sir.
Thanks, Vamsi. I think it's very clear. So basically, basically, evidence also, recent evidence also says that you start feeds early, and then minimal enteral nutrition, trophic feeds. As Vamsi said, start with 1 ml per kilo per hour. And then the recommendation is also like that. You could see that the study by Dr. Sushma Nangia, and they've also recommended to start feeds early with trophic feeding. So escalation, as Vamsi said, so you could escalate with like 30 to 40 ml per kilo per day. And then Cochrane database also, Cochrane database systemic reviews also says that they've compared the rate of advancements, advancement of feeds from 24 to 30 to 40 ml per kilo per day. There is no increased risk of NEC or feed intolerance or death in babies. So babies who have increased to 40 ml per kilo per day. So the answer is you could increase it fast. That is 30 to 40 ml per kilo per day. Thank you. Thanks, Vamsi. So we'll go to the next. With regards to choice of milk, mother's own milk versus donor breast milk versus formula feeds. Can you tell us briefly about commercially available human milk, pros and cons, risk, expenses, and consent? Sorry, it is a bit long question. Try to.
Yes, sir. Compared between mother's own milk along with express milk versus formula, it depends on what are you looking at. Is it purely weight gain or overall development? It is purely weight gain. Formula is always better because there is predetermined fat and protein inside the formula. And mother, whatever she consumes, that is translated to fat and protein for the baby. So even in Cochrane reviews, if you look at it, the formula, the weight gain is way better than rest of the two. But mother's milk is always the best. Always consider mother's milk as your primary source of milk protein for the baby or feed for the baby. And then if it is not there, then express breast milk can be done. Wet nursing has been there for a very long time. And currently the medical legal aspects and everything has come in, and the sterilization part of come in, and commercially available for express milk has been present in the society. So you can definitely get express breast milk. And formula, in case the patients are not affordable and the mother milk is not there, there's no necessity to stop formula. Formula is not a something that it is made a devil out of something to be made out. Formula has been helping us for all this time. It has proven benefits. Weight gain will be better, but immunological point of view, the immune system will be comparatively way lower compared to mother's own milk. And coming to the second portion of the question, commercially prepared express breast milk have been present. Again, the problems with commercially prepared milk, express milk is in what do they store. So each container, if it is a metal container, is it the plastic container basically, or PEC containers, glass containers, all these things will take away most of the nutrients. So the time storage, time to reach you, and at what temperature were they stored, all these matters, especially in express milk, breast milk in commercial preparations. About the cost is exorbitant. Probably once all units starts using, and if it is locally available in each district, especially in government medical colleges, like how Tamil Nadu has put forward most of the breast milk banks in medical colleges, probably the cost will keep coming down as we use.
How expensive it is, Sarath?
Would we consider it in comparison with sepsis or with formula? Formula it is cheaper.
Yeah.
With sepsis it is costly.
Yeah, it is really expensive. It is a 15 ml cost about
1,200 rupees.
1,200. 650, I think. 15 ml of the commercially available breast milk costs about, I think, 650 rupees or so. So it is quite expensive. But of course, so you need to discuss with the parents and take the proper written consent before we start donor breast milk. It's very, very important to avoid its legal implications. So I think it's very good. And could we mix up the donor breast milk and also formula?
You cannot mix both together. Start feeding one. Once that is done, you can always stop up.
Can we alternate the feeds, sir?
Yes, sir, we can do that.
Okay, thank you. I think it's, I hope it is clear to all. Okay, sir, this question to Sangamitra. Discuss about the local availability of donor breast milk and milk bank facility in particular. Briefly, can you just brief us about human milk bank, cost and how to go about it?
Thank you, sir. As a junior practitioner who has just started my clinical practice just a few years ago, I think all of us have that inner voice in us when we think we want our voice to be heard. So this is one question where I want my voice to be heard. So we were discussing about donor milk, commercially available donor milk. And when we have babies, okay, we are in private practice and babies, they might be affordable and they might buy the commercially available donor breast milk. But like Ramarao sir, when there are patients under Arogyasri at Andhra Hospital, or there are so many other preterm babies at government hospitals or SNCUs, so they can definitely not afford commercially available donor human milk. And very sad to say that, Andhra Pradesh is one of the very few states where we do not have breast milk, human milk bank. And it is high time somebody does and some miracle happens and we get a bank soon. So Ramara sir, my request for you on the stage. So that is my personal remark I wanted to make. And then human milk banks, basically when we want to set up human milk banks, we look at the cost of setting up a bank. But then other than the cost of setting up a bank, you can rope in money, roll in and set up a bank. But I think there are many other factors which come into play when you want to set up. First thing, like there are some guidelines and we can just remember bank, B-A-N-K. So bank, for B, we need a base. So there should be some, people who come forward, play that leadership role and, take forward the project by, not only collecting funds, but motivating others and, bringing about the awareness about usefulness of these human milk banks. And then A is advocacy. So we need to advocate breastfeeding first. Only then it can trickle down to making a very successful human milk bank in the state. And then it is network. So we need to increase the visibility of this project so that we can rope in donors easily. We work hand in hand with all the units available in the state. And then K is for key protocols. So we need to have protocols because just starting a bank will not be, will not be regarded as success, but to run the bank successfully is what is the real measure of success. So we have to have key protocols in running these human milk banks. Thank you.
I hope it is very clear. Thanks, Sangamitra. So mainly in we prepared this project report. It's going to cost about nearly 30 lakhs. In that, pasture is going to cost about nearly 20 lakhs. Yeah, but I think it is doable, but it is relatively expensive. So NNF, we are in talks with Rotary. It's a Rotary Club of Vijayawada, and hopefully I think something would work out soon with support from Andhra hospitals and hopefully from some more hospitals from Vijayawada and in other places. Okay, thank you. Preterm formulas, infants born less than 34 weeks and then less than 2 kilo. So wherever breast milk is not available, so we could, I'm not saying that we could definitely, but so when there is no other alternative, then we need to think about formulas. I think I'll skip this slide. So these are the pros and cons of preterm formulas. It ensures consistent delivery of nutrients, and then preterm formulas improve neurodevelopmental outcomes compared to term formulas and unfortified donor milk. The cons are more. Of course, it increases the risk of NEC. There is some evidence for that, and it increases the rate of sepsis, and they do not produce neurodevelopmental outcomes better than fortified human milk. So consider when there is no other alternative, but obviously breast milk is the best. We'll go to the next question. So what is the mode of feeding? Is it continuous or bolus feeds? what is your current practice? And then can you just tell us about frequency of feeding as well, Seshi?
Regarding the mode of feeding, there is insufficient evidence supporting or refuting continuous feeding. Even there is a Cochrane review on this, which concluded that there is insufficient evidence to supporting continuous feeding. And bolus feeding is more physiological, and bolus feeding helps in better neurodevelopmental stress response from the baby, better growth, better time to achieve full feeds. And there is no difference in tolerability. So I think continuous feeding is only used in special situations, whereas bolus feeding is the way to go. And regarding the frequency of feeding, we usually suggest 1 to 2 hourly feeds in babies who are less than 1250 grams and who are less than 32 weeks. And more than 32 weeks, we would try to switch on to third hourly feeding.
Okay, I think it's very clear. Thanks, Shashi. So bolus feeding may be more physiological, as you said, and the growth may be compromised in continuous feeding, as human milk fat adheres to the tube. So that's important. So yeah, but having said that, sometimes so we should start continuous feeds in selective babies, in babies with really feed intolerance, and babies with problems with gut motility. Sometimes we do put a nasojejunal tube and give continuous feeds. But 9 out of 10 times it would be bolus feeds, and then after that we'll increase the frequency. We'll go to the second hourly and then third hourly, like that. Okay, good. So same baby is now 14 days old. We're talking about 28 week 1 kilo baby. Now it's 2 weeks old, and now when babies on full feeds on tube bolus feeds, weight is still 1 kilo. So these are the expected growth parameters. I'm not going into the details. So usual expectation would be like 10 to 15 grams per kilo per day, and then the length you could see that 1.4 centimeters per week, and the head circumference growth is 0.9 centimeter per week. So this is to Sunil. When do you want to change out to Kachari feeds or no breastfeeds?
Fine. So regarding this, to initiate cautery or spoon feed, basically it depends upon two things. One is the clinical stability of the baby. So baby should be on full feeds and without having respiratory distress. And second thing is gestational age. So generally speaking, actually 32 weeks is the gestation where you can start spoon feed, and 34 weeks is for breastfeeding, direct breastfeeding. So basically your suck, swallow, breathing coordination will be complete by 34 weeks. So having said that, it is not same for all babies, like a baby who is born at 28 weeks or 27 weeks. So the baby can be more mature even before also. Before 32 weeks also, you can start your cautery or spoon feed. So basically whenever you are starting, actually 30 to 32 weeks is the time actually where you can initiate spoon feed, once the baby is hemodynamically and respiratory wise stable and on full feeds. So whenever you are starting, actually it should be a slow transition. You don't start the entire cautery feed on single day. So it should be a slow transition over a period of 5 to 7 days. So whenever you are starting, actually you should look for any signs of fatigue. So is there any desaturation or color change? So what is the time that is being taken? And on day-to-day basis, what is happening to the weight? Is there any weight gain or weight loss? So these are the things which you'll look at. So over a period of 5 to 7 days, you gradually increase. By the time, usually the baby also will be on kangaroo mother care as well as non-nutritive sucking, so that actually it will help in earlier establishment of spoon feed.
Yeah, thanks, Sunil. There is no kind of hard and fast rule. We need to start feeds exactly at 32 weeks on oral feeds. So now we some babies, they do take some oral feeds even 30 week. So basically it depends on the baby to baby, but usually, as Sunil said, that between 32 to 34 weeks, where the babies would develop, would have sucking and swallowing reflexes and coordination. So at that point, we would initiate sort of oral feeds and breastfeeds. Okay, this is to Vamsi. Comment on breast milk fortification. What are the different fortifiers available for use, Vamsi?
Sir, again, in this aspect, the evidence is fast changing. I think in the olden days when I was doing my MD and fellowship, I think we used to have only bovine-based fortifiers, where the most common practice was to start at 100 mils per kg, where we used to start fortification at 100 mils per kg. And again, there are no strong studies to support this practice. It's only as per experience. But now, as the science is moving forward, we had access to human milk fortifiers. And also we have some hands-on experience with partially hydrolyzed bovine milk fortifiers also. With all these things, there is strong evidence to start early fortification if you have access to mothers or human milk-based fortifiers, not the bovine milk-based fortifiers. Again, as Ramarao sir was telling, similar to the human milk bank milk, it is very costly. But the advantage is, as Dr. Sharath was saying, we need to compare between the sepsis, longer ICU stay, and the risk of EUGR. All these things should be very, you can't compare them cost to cost. It's about the cost versus the good outcomes. So if you counsel the parents, definitely they are agreeing in practice. And after the access to this, we started supplementing at 40 to 50 mils per kg. And then based on the baby's weight gain and feed tolerance, we can adjust it. So the take-home message is human milk-based, you can start at 50 mils per kg. Bovine milk-based fortifiers, go at 100 mils per kg and be more cautious. And again, the differences between bovine, in that also again, complete protein versus partially hydrolyzed protein and human milk. I think the outcomes with regard to rate of weight gain, length and head circumference gain, there is no much difference between these three. But the only thing is RCT, which compared certain factors, it showed that the chances of NEC, feed intolerance, late onset sepsis are more towards the bovine milk-based fortifiers. I think the RCT is small, the Cochrane, which I think it's not the Cochrane, it's a meta-analysis which looked into 3 studies. Recently, I think updated in 2020. As of now, the evidence is, I think if accessible, cost is okay, best to go with human milk fortifier. If your cost is a hindrance or accessibility is a hindrance, start slow at 100 mils per kg and make sure you are very cautious and monitor closely for NEC or sepsis or feed intolerance.
Okay, thanks, Vamsi. So you could consider fortification in babies less than 1.8 kilo. And once we reach the feeds, as Vamsi said, between 50 to 100 ml per kilo per day. Vamsi, can you just throw a light on this adjustable fortification?
Sure, sir.
What exactly it is briefly?
Yeah. I think the strategy of fortification, again, most of us follow the first one, the standard fortification. That is most of the commercially available 1 gram sachets. We mix in 25 ml of milk. That is most of the commonly practiced, easy to do. But the ideal one, they say, is individualized human milk fortification. I think there is one RCT done in Turkey. I think it has targeted the weight gain, length and HC. And what they have done is they monitored the baby's utilization of the extra protein which we give. So the utilization is seen by measuring the blood urea nitrogen. They kept a target of 9 to 15. So if the baby's blood urea nitrogen was less than 9, they increased the fortification by 0.5 grams. If it is more than 15, they decrease the protein fortification for that day by 0.5 grams. If it is more than 20, they completely stopped fortifying the baby. I think with this, they have found very good outcomes in the terms of weight, length, and HC gain compared to the control group. But again, it's a single leg RCT. The last thing is targeted. I think targeted, again, you need to measure because all mother's milk are not equal. Some of the mother's milk have higher protein content, higher fat content, and energy content. So you need to measure the mother's milk constituents and then need to fortify accordingly as per the target. It is little cumbersome. You need to have equipment to measure or analyze the mother's milk. So most of us, I think we can start practicing the standard fortification or the second one.
Yeah, definitely, Vamsi. No, it's difficult to aim for targeted fortification. So I think most of the units, almost 99% of the units were using standard fortification only. Okay, thank you. The differences now is already mentioned between bovine-based, milk-based fortification and human milk-based one. It basically affects on immunity and better tolerance, and all these things are better with human milk-based fortifier when compared to bovine milk. And there is also some evidence is there. Not many trials are there, but this is a study conducted in Nilo Hospital. So what they found was the sepsis, feed intolerance, NEC, and duration of hospital stay was less in babies who fed on human milk-based fortification when compared to bovine milk-based fortification. So that is a conclusion from this study, but it is a small study. So whether to whether to change our current practice or not, it's up to us. But no, there is some evidence is there that no, human milk-based fortification is better than bone milk-based fortification. Thank you. This is to Sarath. Can you just comment on buccal colostrum? No, quickly, we're running short of time.
Buccal colostrum is nothing but mother's own colostrum being fed to the baby in small quantity, especially around 0.2, 0.3 ml onto the buccal mucosa. Just rub it across buccal mucosa. There have been many advantages for it. One being as an immune booster decreases NEC and sepsis, but large studies currently hasn't confirmed any of these benefits, but still further studies will be required. There are 2 large meta-analyses that have confirmed that that NEC rate, death rate, and time to full feeds have improved. But Cochrane itself says that currently they did not find any difference between doing this. So would the MEN versus colostrum. Buccal colostrum is easier to apply. You don't have to directly feed the baby. You can directly apply using an earbud onto the buccal mucosa of the baby. So the baby can start suckling on, as well as there will be improvement in the movements of the muscles around the mastoids and everything. So there can be an improvement in the time to reach at least pallida feeds before going to full feeds. Thank you.
So what is your current practice, Sarath, in your unit? Do you, are you going for this buccal colostrum?
No, sir. Currently, what we do, we start off MEN. We start off initially, even at day 0, within 2 hours, we start off MEN. So our buccal application is, currently we don't practice that in our unit.
Okay. Yeah, thank you. Next question. This is to Sangamitra. Sangamitra, can you just comment on role of prebiotics and probiotics in preterm feeding? So now, briefly.
We don't have evidence regarding prebiotics in preterm feeding, sir. Coming to probiotics, probiotics are generally live organisms that we give to improve gut colonization. It is basically the reason behind this is because of the more prevalent intestinal dysbiosis in preterm babies in the NICUs due to various reasons. So to prevent this intestinal dysbiosis, they started giving what is called as probiotics. So the evidence keeps changing pertaining to these probiotics. I think it's been changing at a very fast pace. So we have some recent Cochrane updates in as recent as 2020. So they say they have looked at probiotics use and the reduction in NEC, sepsis, late onset sepsis and mortality. And the problem with these studies is each study they use a different strain. We don't have a uniform strain. Some are using single strain, some are using multi-strains. So there's so much heterogeneity, and moreover, what is glaring is for those babies who actually would benefit more is what we think less than 1 kilo babies, that is ELBW babies. But the evidence pertaining to these ELBW babies is very, it is not very encouraging to the use of probiotics. But recently, NNF came with the position statement with its CPG guidelines in 2020, and they say we can start probiotics in all low birth weight babies up to 36 to 37 weeks post-menstrual age. So in our unit, I am using probiotics, but it is a single strain, and I've been using it for the past 4 years or so, and we continue using it.
So you do use it. Yeah, so basically it's your individual preference, and it varies from unit to unit. It varies from center to center and country to country. In the UK, some units they are using it in probiotics routinely. Prebiotics they're not using it anyway. But here you could conditionally use probiotic, whether it's an lactobacillus or a bifidobacterium or combination, selectively on day one of life. Especially when there is increased risk of NEC, when there is a risk of NEC in your neonatal unit, you could consider using probiotics from day one itself. Thank you. Okay, this is question to Shashi. We know that mother's milk is the best. So can you comment on how to promote breastfeeding in preterms?
Yes, sir. Promoting the breastfeeding in mothers who are starts from the antenatal period itself. The antenatal counselors, lactation counselors help a lot by promoting the mothers and increasing the prolactin levels in the mothers so that they are ready for breastfeeding whenever the baby is born. And not only that, we should encourage continuous expressing of milk right from the day of birth. And mothers, especially when they are is in an inborn setup, we should allow the mothers to see the baby and interact with the baby. And in an outborn setup like ours, what we usually do is a family-centered care. We allow the father to come in and video call with the mothers so that the mothers are stimulated to get more milk. And of course, mother should be adequately hydrated and adequately nourished. And also, once the baby's reached full feed stage, we should encourage non-nutritive sucking and kangaroo mother care for the mother to get more milk, which helps in prolactin secretion.
Yeah, thanks, Shashi. I think every unit should have a lactation counselor. So who could train lactation counselors? One of the staff nurses or ANMs. You could train them, and those counselor could engage with the mother, and then encourage breastfeeding, and they would discuss about the all breastfeeding techniques and how to promote breastfeeding and all. So I think every unit should have lactation counselor. So next one, this is to Sunil. So what is the responsive feeding? What is the exclusive breastfeeding? Advantages. It's a pretty simple one. Can you just do it quickly? Thank you.
Responsive feeding is nothing but like demand feeding. Earlier we used to call demand feeding. So it has got many advantages. So there will be better bonding as compared to your fixed interval feeding. Can you go to next slide? So as a healthcare professional, actually we should promote responsive feeding as compared to feeding at fixed interval, because apart from the advantages of all the breast milk, we know the benefits of breast milk both for the mother as well as baby, and responsive feeding has got extra benefits also, which we'll discuss next. Next, sir. So these are all the advantages for the baby. So there will be better oxygenation as well as temperature regulation, like if you are giving responsive feeding. So here, especially for the late preterms as well as preterms, so there will be better oxygen levels as well as the episodes of apnea will be less if you are practicing responsive feeding. And we know the advantage of skin to skin contact, and there will be like better nutritional as well as immunological properties, better oral development, and more efficient emptying of the breast. This is for the infant. Next. So for the mother, actually, there are many advantages like reduced risk of breast trauma, reduced risk of reduced risk to mother's health, psychological benefits, and many other practical advantages. So these are all the benefits with demand feeding or responsive feeding.
Okay, thanks, Sunil. So it is quite clear. Next one to Vamsi. This is rapid fire questions. We're running short of time. Going to be a bit more quicker.
Think,
being it is a rapid fire.
Straightforward question.
Yeah.
Mostly we have a mixed population of PGs and practitioners. That's the reason sir has included this, I guess. So definitely colostrum is bad for the baby. No. Lactating mothers have to follow a restricted diet. There are so many myths in the society. So definitely a big no. In summer, we need to give water to the newborn. Definitely no. And again, prelactal feeds no, and babies have to feed timely. No. Babies should be fed based on the baby cues or demand feeding.
Excellent. That's perfect timing. This is the one, I think this is important and everybody has to concentrate. We did a study, in fact, survey in our hospitals, Andhra hospitals, regarding, thiamine deficiency of breastfed babies whose mothers on compromised diet. So this was actually published in International Journal of Community Medicine and the Public Health. This is a high prevalence of food taboos and dietary restrictions in lactating mothers from coastal districts of South Indian state. Is a hospital-based study. So what we found in that study was basically the mothers who are on restricted diet, means you all know Pacham. Grandmothers, maternal and grandmothers, they're not giving proper diet to the mothers. So that basically, because of restricted diet, that's leading to thiamine deficiency in the mother, and mummies breastfed baby. So so babies also thiamine deficient, leading to pulmonary hypertension. So we've seen the number of babies in the last 2 to 2.5 years or so. We treated number of babies presented with severe pulmonary hypertension. So when we took the dietary history in the mother, they were all on restricted diet and not taking proper diet at all. So what we did in those children was we started on thiamine. So with the 2 to 3 doses of intravenous thiamine of 100 milligrams, they're all just improving like anything. So the pulmonary pressures have come down, and then we discharge the baby after 3 days. And then so we are advising to continue the thiamine to the babies for about 3 months, and also to the mothers. And then we are, of course, we are counseling on diet as well to mothers. So please do spend some time with lactating mothers and advise on diet. Otherwise, we could lose so many children with just pulmonary hypertension. So just because of thiamine deficiency. So I think that is a take-home message today. So next one, Seth, quickly, what is the supplemental suckling technique? Quick, we have 15 minutes.
So for basically for relactation of babies, the picture depicts most of it. The mother's milk is expressed and put into a bowl, and a feeding tube is attached to the breast close to the nipple, and let baby do a non-nutritive suck onto the breast. So automatically the small quantities of milk, as the baby starts suckling, the milk will be instilled into the baby's mouth, and slowly the baby will start learning lactation. So this is one way to establish relactation into the mother.
Yeah, okay, yeah, thanks, sir. That's very clear. Basically, this is to induce relactation, and so now actually with this technique, they've seen that babies gain weight, and then it's basically improved the lactation as well. So that helps. So you could also try. You could try for 7 to 14 days. If there is no improvement, you could leave it. Okay, Sangamitra, can you just throw light on complementary feeding, quickly? We have 14 minutes.
Yes. So the time of starting complementary feeding is just another phase of transition from the mother is worried about giving exclusive breastfeeding till 6 months, and then suddenly she has to start feeding her baby. So it is just a phase of transition. And here what problems we encounter in our day-to-day practice is either the mother starts complementary feeding early, or she's scared to start and they start it very late, not at the correct time. So both are not right, and we need to help and counsel the entire family and not the mother to start complementary feeding at the right time after giving exclusive breastfeeding for the first 6 months. And the foods that we suggest for complementary feeding are they should be affordable, culturally acceptable feeds, and there should be variety in the feeds. And we need to specifically in this era, we need to tell them that they should avoid junk food. That is, they should avoid food made with maida or biscuits and bread, or easily available and highly marketed foods, which are called as finger foods that are marketed in the market. So we just need to tell them to change the consistency with every 3 months, starting from 6 months of age, to improve the consistency of the food, and imply or stress on preparing the food at home that should be easily preparable. That is, she should be able to make it easily at home. And we suggest them various ways and how to make them energy dense, and see that it is there is variety in the food.
Okay.
Thank you, sir.
You want to announce the announcement?
Chief guest Sri Balineni Srinivas Reddy Garu, Minister for Energies and Forest, will arrive here in 2 minutes. We need to abort the session. We need to arrange the dais.
Right. Okay. Thank you also. No, sorry to the panelists and chairperson, Srikant Garu. Yeah, I'll just have a half-minute key messages. I'm really sorry for that. So I'll just go with key messages. Initiation of breastfeeding as early as possible. So you all know that probably within first hour. Exclusive breastfeeding in the first 6 months of life. Appropriate and adequate complementary feeding after completion of 6 months. So you all know that. Proper hand washing, avoid junk foods, promote and establish human milk banks. If is possible, and then full immunization and vitamin A supplementation and deworming so whenever it's needed. And I'll go to the summary. So the maximum volume classed as a trophic feed is we already discussed is 1 ml per kilo per hour or 24 ml per kilo per day. And so now early trophic feeding we could start within 24 hours. Daily feed volumes, the incremental, we could increase it to 30 to 40 ml per kilo per kilo increments. Bolus feeding may be more physiological. Human milk fortification is associated with a short-term increase in weight gain and linear and height growth as well. Human milk fortification, you could start it once we reach feeds so between 50 to 80 ml or 50 to 100 ml per kilo per day. So there is emerging evidence that the buccal colostrum, you could consider using buccal colostrum that helps in preterms. Prebiotics have no role. Probiotics you could consider selectively, and some units they are trying. And supplemental iron in preterms and IUGR babies, 2 per kilo once we reach full feeds, usually the age of 2 to 4 weeks. And you could consider extensively hydrolyzed formulas or amino acid formulas in children with probable cow's milk protein allergy. So when you suspect milk protein allergy, for example, if a child present with eczema, so the child is on cow's milk formulas and developed eczema. So if you are suspecting cow's milk protein allergy, and you could go to either to extensive hydrolyzed formula or to amino acid formulas. So that's it from our side. And again, sorry for that, and to interrupt in between. So thank you one and all. Thanks for patient listening. Thanks to all the panelists and our chairperson, Dr. Srikant Garu.
It is an honor and privilege to welcome our Minister, Mr. Balineni Srinivas Reddy, Minister of Science and Technology of Andhra Pradesh and member of the Legislative Assembly from Ongole for the 42nd Annual Conference Academy of Pediatrics Andhra Pradesh State Chapter, PEDICON 2021 IAP Ongole.
Good afternoon to our distinguished guests, honored speakers, and dear delegates. I am Abhinaya, and I'll be your host for today's ceremonies. I would like to start off by inviting all our dignitaries onto the dais. First of all, I would like to invite Dr. Nagaya Naidu Garu, organizing chairperson of the conference, Dr. Nagendra Garu, President 2021 of the IAP AP chapter, Dr. Radha Krishna Garu, Vice President Central Zone, Organizing Secretary and President Dr. K. Muralidhar Reddy Garu, Secretary of the Organizing Committee, Dr. Pavan Kalyan Garu, members of the Executive Board, Dr. Rajshekar Garu, 21, Dr. P. Anil Kumar Garu, 21-22, Dr. Kiriti Garu, and Dr. Ramakrishna Paramahamsa Garu, members of the Executive Board of the year 2022. Next, I would like to invite our guest of honor, Dr. Basavaraj Garu, and I would also like to invite the president for the year, President-elect, Dr. Suresh Babu Garu, and our treasurer, Dr. Sai Prasad Garu, as well as, and next, our guest of honor, Dr. Basavaraj Garu, Honorary Secretary General 2021 of the IAP. And our chief guest for today's events, Dr. Balaneni Srinivas Reddy Garu, Minister for Energy, Forest and Environment, Science and Technology, and member of the Legislative Assembly from Ongole.
I request everybody to please take over your seats, please. I request all this audience to please sit on, please occupy the chairs.
I would also invite Dr. Venugopal Reddy Garu, who is the observer for APMC for this conference.
I now request Dr. Nagaya Naidu Garu to say a few words on the occasion.
మొదటిగా జ్యోతి ప్రజ్వలనతో మొదలు పెడదాం.
obstruct ఉందా?
I'll just sponsor. Very good afternoon to the respected dignitaries on the stage. It's an 42nd annual state PEDICON, which is being conducted in the Ongole. This is for the first time we are conducting a PEDICON in the Ongole district under the organizing chairmanship of Dr. Nagai Naidu sir and Dr. Muralidhar Reddy sir. It's been a feast, academic feast, which is being going on. I hope everybody would be enjoying for the next 1.5 days. Now I request Dr. K. Radhakrishna sir, who is the Vice President, Central Zone, to say a few words.
Good afternoon, one and all. Let me at the outset congratulate Muralidhar Reddy, Nagai Naidu, his team for conducting this wonderful conference. It happens that this is the first time a state conference is being conducted at Ongole. 25 years ago, Muralidhar Reddy was my student, and he was a brilliant student then. He was a very dynamic person. I don't see any change of a drop in dynamism in this 25 years. I was telling other people, see his dynamism, he still continues. Now, please remember, it is never harmful to learn things at whatever age it is. It is never harmful to learn. I see so many pediatricians saying, why should I learn? Or clinicians, those in practice saying, why should I learn things? Automatically we'll get good practice. No, it is very important that we keep learning things. At least the minimum thing you should know is, you should know whatever case you're not understanding, you have to send it to somebody, read from books and learn a lot. So with these few words, I invite the chief guest of the day to come over to this mic and give his message.
Good morning. I am honored to open the 42nd Indian Academy of Pediatrics Annual Conference AP Chapter. On behalf of everyone, I would like to welcome our honored speakers and delegates to our beloved town. Before I start my speech proper, I would like to thank each and every member present here today for their exceptional service during the pandemic, that is of COVID. Keeping up with the newest advancements is a must in any field, but it is essential in the medical field. Continuing medical education events such as the conference are an important part of it. I hope you will take advantage of all the scientific sessions being held and the world-class speakers leading them. I have been committed to serving our proud nation for nearly 25 years now. When I first became an MLA, the infant mortality rate in our state was 66 and the under 5 mortality rate in India was 95.3 in 2019. These values are 25 and 35.73 respectively. This is promising, but we must not rest until these numbers are either 0 or as close to it as humanly possible. Next, I would like to recognize the tireless efforts made by the members of the organizing committee and congratulate them on a job well done. On this note, let me end my message today by congratulating Dr. K. Muralidhar Reddy Garu on his election as the President of the Indian Academy of Pediatrics, Andhra Pradesh, and hope that this tenure shall be a fruitful one. Thank you.
So thank you, sir. Thank you for your nice words. Now I'd request Dr. G.V. Baswaraj, sir, to say a few words, our guest of honor.
Good afternoon to all. Respected Chief Guest of the Day, Honorable Minister for Forest and Energy, Dr. Srinivas Garu, and President of Andhra Pradesh, Dr. Muralidhar Reddy, sir, and immediate past President, Dr. Nagendra Prasad, sir, our Central Zone Vice President, Dr. Radhakrishna, sir, and our Chief Organizing Chairperson, Dr. Nagaya Naidu, and President-elect Dr. Suresh Babu, sir, and Executive Board Member Dr. Anil, Dr. Rajshekar, and Dynamic Secretary of Andhra Pradesh, Dr. Pavan Kumar, and Professor Ramkrishna Paramamsa, our Executive Board Member of newly, and Dr. Kiriti, sir, of 2022. Really, the Andhra Pradesh is doing an excellent academic activities over a period of last few years. What I'm seeing is a lot of enthusiasm and academic activities under the guidance of a senior. This is something which is a welcome change from the Andhra Pradesh team of IAP. When we're looking into the scientific program of the 42nd annual conference of AP, excellent scientific program which is focusing on to the practicing pediatrician, postgraduates, and also the medical college teachers. And the 5 workshops, which is the need of the hour, starting from the point of care ultrasound, which is by Andhra Hospital, Dr. P.V. Ramrao and team. Simulation is one of the newer concepts which is emerging. The future of clinical medicine is going to be the simulation. That's by Dr. Dinesh Chirla and Dr. Ram Prasad from Rainbow Hospital. And the procedure, you take out any upskilling up in a medical practice. Procedure is the need. That's also been focused with the procedure in the neonatology and pediatrics by Dr. Nuri Satyanarayan, Sangamitra, Dr. Shashidharan. And all other workshop, which is the really relevant, which is the need of the hour. Wish you all the best for this conference. Thank you. Thank you all.
Thank you, Dr. Baswaraj, sir. Sir was the Honorary Secretary General for the Indian Academy of Pediatrics in 2021. Now, in the august presence of Dr. Mr. Bolinen Srinivas Reddy Garu, there would be medallion change from Dr. Nagendra sir, the President of 2021, would be handed over to Dr. Muralidhar Reddy, the incoming President for the 2022. Sir, I request Dr. Nagendra Prasad, sir, to change the battalion medal to Dr. Muralidhar Reddy, sir. Thank you, sir. With this short and brief introduction, we would end our inaugural session by giving a vote of thanks by the secretary. It's me. I'm Dr. Pawan Kalyan, the pediatric pulmonologist. Thank you, Mr. Bolinen Srinivas Reddy Garu, sir, for accepting the invitation and coming and blessing all the pediatricians here from all over the state. It's been a pleasure, and we will strive to reduce the infant mortality rate. And I would also thank Dr. Nagendra Prasad, sir, the President 2021, and the Organizing Secretary and the President 2022, Dr. Muralidhar Reddy, sir, and Dr. Suresh Babu, sir, the incoming President, who is going to conduct the next conference at Nellore. So we would be seeing again the Minister there, hoping so, to bless us all. Thank you one and all for being an active participation. ఒక 5 minutes ఆగుదాం.
Good afternoon, everyone. I'd like to call the chairperson of the session, Evidence-Based Decision on Vaccination, Dr. Ram Murthy garu, to introduce the speaker, Dr. Sai Sunil Kishore garu.
Good afternoon, one and all. Let me thank first to give me this opportunity to chair the session to Dr. Nagay Naidu garu and Muralidhar Reddy garu. Slide. Dr. Sai Sunil Kishore garu, Chief Neonatologist and Pediatric Intensivist, Clinical Head, Medical Hospitals, Associate Professor, MIMS Medical College, Nellimalla, Vijayanagaram. Yes, next slide. Dr. Sai Sunil Kishore garu had 35 publications, international 16, and national 19. He is a student of Andhra Medical College, Visakhapatnam. He did his MD from PGS Chandigarh and he is DM from PGI in 2009. Over to Speaker, Dr. Sai Sunil Kishore garu.
So thank you, sir, for that kind introduction and very good afternoon to you all. And I thank the organizers for giving me the opportunity to interact with you all. And it's indeed my pleasure to interact. So what I'm going to discuss in next 20 to 25 minutes is I'll discuss evidence-based selection of vaccines. So these are the main focus areas. So these particular vaccine preventable diseases I am discussing mainly because of the specific problem associated with these specific diseases. So for example, pneumococcal, we know that actually it is the #1 cause of under 5 mortality. Pertussis is a serious public health problem. And hepatitis A, actually we know that the severity increase with age. Actually, there is a gradual drift in hepatitis A. So earlier, actually, children less than 10 years they are getting affected. Now, for the last 1 to 2 decades, actually, the children for more than 10 years they are getting affected. And we need polio eradication. Meningococcal because of the risk of rapid progression and high mortality. And rotavirus, we know it's a leading cause of severe gastroenteritis. So we should take evidence-based decision for these different vaccines. So first coming to the pneumonia and the advantage of Synflorix over other vaccines. So India ranks #1 in the pneumococcal disease deaths. So if you look at the serotype coverage of the different vaccines which are available, so if you look at the different vaccines, different serotype coverage of different vaccines which are available. So this one is for PCV13. So the serotype coverage is up to 78%. And for Synflorix, it is up to 76%, which includes your 19A as well as 6A. And for it is other 10 valent PCV, it is 72%. So this also includes Yeah, this also includes actually, if you look at the middle one, the Synflorix, actually the 6A as well as 19A included, actually it is 76%. So basically, what I'm trying to say is like your selection of PCV should be based on efficacy against disease, not only just based on the serotype coverage. It should be based on your efficacy against disease as well as also cross protection and head protection and effectivity in the community. So these are the things which will decide on your decision making. So this is one large study which is done in Finland. So our almost 30,000 odd infants were included, which has shown that actually there is significant reduction in different morbidities. So if you look at laboratory confirmed overall IPD, overall invasive pneumococcal disease, it is 94%. And hospital diagnosed pneumonia reduction by 23%, and the need for tympanostomy for acute arteritis media is by 13%, and antimicrobial treatment also there is significant reduction. So this is the benefit with Synflorix, and it's almost 82% effectiveness against 19A, and it is approved in 94 countries. So this is basically to look at the impact of pneumococcal vaccine against pneumococcal pneumonia, meningitis, as well as invasive pneumococcal disease. The first one, as you can see, this is for IPD, invasive pneumococcal disease. The second one for pneumococcal pneumonia, and third one for pneumococcal meningitis. The black bars are for pre-vaccination era, and this is with Synflorix. As you can see here, actually there is 68% reduction in the incidence of pneumococcal disease, and 85% reduction in pneumococcal pneumonia, and 69% in pneumococcal meningitis. So basically it has shown a significant impact against overall invasive pneumococcal disease, pneumococcal pneumonia, and meningitis if it is given in less than 5 years. So this is regarding the seroprotection versus disease protection. So serotype coverage is always not synonymous with the disease protection. So if you look at the data from different countries like Sweden and Canada, so here in the first, the Sweden, actually this is comparison between Synflorix and PCV13. So which has shown that actually there is 17% extra coverage with PCV13, serotype coverage based on the prevalent serotypes in that particular country. And similarly in Canada also there is 20% extra coverage in the serotypes. But if you look at the data regarding IPD, invasive pneumococcal disease protection, so as you can see here, actually there is with Synflorix, this is comparison between Synflorix and PCV13. So in different countries. So here actually this is Synflorix countries which has shown almost 73% reduction in the pneumococcal disease, whereas with PCV13 it is almost similar, 70%. So what I'm trying to discuss is actually the serotype coverage, even though it is more with PCV13, when it comes to real life scenario, the protection against IPD is almost equivalent. And this is this is similarly actually comparable IPD protection with Synflorix and PCV in Canada also. So 72 and 66% protection. So now another important message actually which we need to discuss here is regarding arteritis media and its protection. So it has got, the Synflorix is the only PCV which has got dual protection against acute arteritis media, and which is caused by Streptococcus pneumonia as well as non-typable H influenza. Basically, like in Synflorix, actually it's an active carrier protein which is being used, so which has got actually it will give extra protection against even arteritis media also. So 8 out of 10 children will suffer at least one episode of arteritis media in first 3 years. So this is the burden, and most common causes are S pneumonia and non-typable H influenza. They constitute almost up to 55 to 95% of the cases. And acute arteritis media is the most common reason for antimicrobial use. And this is basically looking at the comparison in the arteritis media, acute arteritis media in 0 to 4 years age group. As you can see on the right side, so this is with Synflorix and this is with PCV13 countries. So which has shown that actually there is better reduction with Synflorix. So similar data, actually this is basically looking at acute Hepatitis media incidence as well as acute Hepatitis media recurrence. So in different country, this is done in Korea. So what it shows is actually with PC, as compared to PCV 13, the acute Hepatitis media incidence is much lesser with Synflorix, and similarly here also, and the recurrence rates are also less with Synflorix. So basically, the bottom line message is it significantly lowers acute Hepatitis media rates and less acute Hepatitis media recurrence with Synflorix as compared to PCV 13. So now the take-home messages like for any vaccine preventable disease, so the vaccine should have these qualities: better immunogenicity and safety, efficacy and effectiveness. And for PCV, what is desirable is protection against acute Hepatitis media also, and schedule flexibility should be there. And like in special population like preterms also, we should be able to use. And if you look at with Synflorix, it qualifies all those particular qualities, best qualities. And for PCV3, it has also got all those qualities except for this like protection against Hepatitis media, which is lesser than Synflorix coverage. And for the other 10-valent PCV, so the no evidence is available regarding the like efficacy as well as effectiveness in the real life situation. So what is the exact effectiveness? So basically the Synflorix is a uniquely designed PCV offering protection beyond the serotypes. So now coming to the second one, second vaccine, hexavalent vaccine. So what are the benefits with your hexavalent vaccines? Is it only reduction in the number of pricks, or there are some other benefits also? So definitely the number of pricks to the baby will be less with hexavalent vaccine, but there are certain other important messages also like which we need to know. So this we know that actually India is one of the one among these countries actually for the high risk for polio because of the vaccine derived polio virus. So we use OPV. Till now we have used OPV significantly. So the VDPV associated polio is actually the incidence. The India is at risk. So basically, the hexavalent vaccines they help in optimizing polio protection with IPV. And the meta-analysis also shown that actually, like if you use only 2 doses, so these are the protection rates, the zero conversion rates. Like with the second dose against type 1, type 2, and type 3, like almost anywhere between 80 to 90%. Only with 3 IPV doses, nearly 100% zero conversion will occur. So IAP recommends almost 4 to 5 doses of IPV containing vaccine, and no child should be administered only pentavalent vaccine and oral polio vaccine in infancy without IPV. And single dose of IPV at 14 weeks actually doesn't give an adequate zero conversion rates. So this is again comparison of the immunogenicity against 6 antigens which are being used in hexavalent vaccine. So this is comparison between Infanrix Hexa and the other wholesale Pertussis hexavalent vaccine. So this is for diphtheria, tetanus, and hepatitis B, which are comparable. And if you look at the polio as compared to this wholesale Pertussis hexavalent vaccine, so which is between 88 to 90%. So Infanrix Hexa scores better, so almost 100%. And more importantly for Pertussis, so these are the different antigens actually, protection against these antigens. So PRP, it is similar, and Pertussis toxin, actually it is better, Infanrix Hexa is better as compared to this one. So 100% versus 68%. And here actually the data is not available for these other antigens. And this is regarding the follow-up studies. So regarding Pertussis efficacy as well as the follow-up studies. With Infanrix Hexa, actually the Pertussis efficacy is up to 85 to 90%. And the follow-up data is available almost up to 5 years. And for all other antigens, all other 6 antigens, the follow-up data is available till 7 years. Whereas for other vaccines, actually you don't have that significant follow-up data. So here actually only 5 years data is available with other SLR Pertussis vaccine. I mean hexavalent SLR Pertussis vaccine. And another important thing actually which is close to me is like for premature babies. So we know that prematurity is a common problem. Almost 10% of all babies are born preterm. And if at all actually the baby gets pertussis, premature baby gets pertussis, the severity of pertussis is almost 5 times higher in preterm baby, and pertussis related hospitalizations are also almost 2 times higher. And this is the only vaccine which is recommended for preterm babies, whereas other wholesale pertussis as well as other SLR pertussis are not promoted for preterm babies. So these are all the take-home messages. So Infanrix Hexide provides high immunogenicity against all antigens and also up to 100% seroconversion against polio. And it is the only hexavalent vaccine with pertussis efficacy of almost 85 to 90%. And the persistence is observed up to 7 years against all antigens. And this is the only hexavalent vaccine recommended for use in preterm babies. And it is the only hexavalent vaccine with more than which is being used for more than 20 years in clinical practice. So this is regarding the hexavalent vaccine, SLR pertussis vaccine. So now we'll move on to the next one. So regarding hepatitis A. So the goal of whenever you are giving a vaccine for hepatitis A, actually the goal should be based on the long-term protection. It's not only regarding short-term protection. And as I was mentioning in the beginning, there is a gradual drift in the hepatitis A incidence in India as well as in other parts of the world. So as you can see here, actually this is seropositivity in children in less than 10 years. So this was in 1980s and this is in 2012, which is showing that actually the anti-HCV seropositivity is significantly declining. So the children are getting affected lesser and lesser in less than 10 years. But what literature shows is there is increased number of adolescents and young adults getting hepatitis A and complications. And also there is increased number of hepatitis A outbreaks. So what is the suitable vaccine for this? So if this is comparison between Havrix and live hepatitis A vaccine. So Havrix actually it has got if you give Havrix, actually the 10% almost 100% seroconversion in 19 days. So actually the sero protection comes quite early after giving vaccination at the first dose itself. And the second thing is if you compare with the live hepatitis A vaccine, actually the antibody titers are more than 2 times higher. So Havrix is recommended in outbreak control as well as in immunocompromised patients because it is inactive. You can use in immunocompromised patients. Second thing is it gives protection within 19 days. So that's why actually it can use in outbreaks also. Whereas with live hepatitis A vaccine, other one, there is almost like 9% primary vaccine failure as well as the seroconversion occurs in 6 months. So, and it is also not recommended in immunocompromised patients because it is live vaccine. And with this live hepatitis A vaccine, actually the seropositivity is also decreasing with time. So the same cohort of children are followed at first month, first year, third year, and 8th year, as you can see here. So while using hepatitis A live vaccine, the seropositivity is decreasing. This is comparison between now I discussed actually the comparison of Havrix with the other live hepatitis A vaccine. So this is comparison of Havrix with the inactivated hepatitis A, which is Chinese derived. So as you can see here, actually if you are giving Havrix, so here to begin with, they are seronegative subjects, and almost there is more than 1800-fold increase in the antibody titers. Whereas with other vaccine, it is around 200-fold rise, and many of them are also seropositive to begin with. That means already they are seroprotected, and there is around 200-fold increase. So here actually Havrix will score better as compared to the other inactivated hepatitis A vaccine. So this is looking at the long-term protection. So what is happening to the long-term protection? Till 20 years, till 50 years. So this is based on the mathematical model. So if you look at this Chinese origin inactivated hepatitis A vaccine, so after 5 years, there is a significant drop in the antibody titers. Whereas here, so the antibody levels will persist even up to 20 years, and mathematical model says that actually even up to 50 years also, the protective antibody titers will be there. So this is the first hepatitis A vaccine, and it was done in like more than 50,000 subjects. It is registered in more than 90 countries, and it's globally trusted. So coming to the last part of my presentation, so this is regarding the meningococcal vaccine. So we know that actually meningococcal disease can progress very rapidly, causing life-threatening effects, and it can be devastating, and mortality is quite high if it is undiagnosed. But there are many challenges in the diagnosis because to begin with, actually it will follow routine viral illness only. So routine viral symptoms will be there, and actually the time from the onset of disease till the mortality actually is very less. So unless you diagnose quite early, so here you may miss the so you may miss the case of meningococcal disease, and the child may die, and there is higher risk of mortality. Can you reduce the screen size? So in India, actually, it is still prevalent, but it is very much underreported as compared to other diseases, because actually the meningococcal disease, the time period from the onset to lethality is very less, and actually the diagnostic techniques are still not completely evolved. So the best option is to give vaccine for meningococcal. So there is limited data surveillance in India, and insufficient laboratory capacity, and there is prevalence of extensive antibiotic use. That's why actually many times you will get negative cultures also. So vaccination against meningococcal disease is one of the best defense for that. So the Menvio vaccine, actually it has got robust immunogenicity, and it has got proven real world evidence. So this is basically looking at the immunogenicity in 2 to 10-year-old Indian children. So as you can see here, this is the antibody titers, and with the different serogroups like serogroup A, C, and W and Y of meningococcal disease. So if you give vaccination, actually the post-vaccination titers are almost elevated by 6 to 23 times. So whenever you are giving Menvio. And in the real life scenario also, like there is significant reduction in the meningococcal disease, like invasive meningococcal disease, whenever we are giving Menvio. So it has demonstrated almost 88% real world difference. So from the baseline rate of 0.52, it has there is 88% reduction, and there is a decreased incidence of invasive meningococcal disease. So we know that actually it is like the experience is more than 10 years, and 6 crores doses were distributed. So it is the meningococcal disease is prevalent in India, but remains grossly underestimated and underreported. And immunization against invasive meningococcal disease is one of the best defense to protect kids. And over a decade of clinical experience and strong evidence of robust immunogenicity, safety, and effectiveness, and proactive prevention with meningococcal vaccination can save lives. So thank you very much. So I have discussed like the role of pneumococcal vaccine, hexavalent vaccine, and your meningococcal vaccine, and hepatitis A. So thank you very much.
Thank you, Dr. Sai Sunil Kishore Garu, for your clear and elaborate presentation. Any queries from delegates?
Any queries, please? Then I would like to request Dr. Rammurthy Garu to felicitate Dr. Sai Sunil Kishore Garu. Sir, please. Now, I would like to call the chairperson of the session, Pediatric Obesity, the Pandemic Unfolding, Dr. PSN Murthy Garu, past Secretary and President of Krishna District, and Dr. Y. Sai Kishore Garu, current President of Krishna District, to introduce the speaker, Dr. Hemachandra K. Prasad Garu.
Good afternoon, everybody. On behalf of organizing committee, I thank you all for giving me this opportunity. Now we are going to have a topic which is a burning problem in the present days, that is obesity in children. For this topic, we have a speaker, Dr. Hemchandra K. Prasad. I'm happy to introduce him. He got his pediatric endocrinology training, PDCC, at Pune in Bharati Vidyapith Medical College, and ESPE Clinical Fellowship, Birmingham Children's Hospital, ISPAD Clinical Fellowship in Washington University. And current position is consultant pediatric endocrinologist and diabetologist at Mehta Hospital, Chennai. And regarding his other achievements, South Zone convener of IAP 2015 Growth Charts TOT, has 20 peer-reviewed publications in pediatric endocrinology, co-editor of second IAP textbook in pediatric endocrinology, and delivered the keynote address in APPE's meet in Darwin 2014, and developed the diabetes carb app and diabetes ketoacidosis app for practitioners, and innovative teacher award from ANBAI 2019 and Active Pediatrician Award 2017 IAP, TNSC. Organized many pediatric endocrine meetings in Chennai for pediatricians. And his areas of interest are growth charts, growth hormone therapy, type 1 diabetes. Now I request Dr. Hemchandra K. Prasad to proceed his talk. Thank you.
Can we have the slides? Yeah. See, over the next half an hour that has been allotted to me, we'll just try to find simple answers for these questions. So, yeah, I'm beginning with this story of a child who came in 2016 with a high BMI, as you can see on the chart. And before the pandemic, the BMI shot up. And when they came back with a weight loss, this child was evaluated. Child was found to have type 2 diabetes with dyslipidemia, retinopathy, and nephropathy. What was missed? Look at the story. A pet child pampered. Through the course, child has lost his kidneys and eyes. So the message is obesity is not a cosmetic problem. Obesity is a metabolic problem that has to be looked into more seriously. There is enough data from across the world that obesity is fueled by the pandemic. And whether what is the reason, whether it's because of stress, deprivation of sleep, more sedentary activities, more gadget exposure, more screen time, rise in sugar consumption, all of them are postulated, but definitely there is a surge in obesity, and it is definitely a pandemic unfolding. So we will have a simple 6-step approach to obesity, and as pediatricians, how we should guide children with obesity in our day-to-day practice. That will be the theme of the talk. So diagnosis of obesity begins with growth chart plotting. All of us know very well that below 5 years, we have to use the IAP modified WHO chart, and above 5 years, the new IAP charts. Plotting them, calculation of BMI or plotting the weight for height. And when you find it above the red line, you make a diagnosis of obesity. So the blue chart for boys and the pink chart for girls. And this is a very simple pictorial way of making a diagnosis of obesity. And the purpose of a growth chart, you show it to the parent and you pick up and you reinforce them that they have obesity. There is enough understanding that WHO charts help us as pediatricians to pick up obese children early. And the IAP charts also help us pick up many obese children early. The Indian Academy of Pediatrics has come up with this new novel BMI lookup tool, which obviates the need for calculation of BMI. This is very useful in children above 8 years, where the weight and it's a simple plotting of the point of intersection of weight on the y-axis and height on the x-axis. And if you find that the child has the point of intersection above the red line, you make a diagnosis of obesity. So thus the novel BMI lookup tool is a very useful tool for pediatricians to make a diagnosis of obesity in children above 8 years. So step 1, to identify obesity, please use the WHO charts in children less than 5 years, IAP charts above 5 years, and the new BMI lookup tool. And when you find that the weight for height or BMI is above the red line, you make a diagnosis of obesity. The second step is to ascertain whether there are risk factors. You know the 4 major risk factors: diet, lack of exercise, lack of significant screen time, and lack of sleep. The intake of diet, vegetables and fruits, skipping of breakfast, high fat, high salt, and high sugary content should be inquired into. The snacking pattern should be inquired into. Physical activity, the routine, the activity during school and non-school days, the time spent on tuitions should be inquired into. The number of hours spent on gadgets during weekdays and weekends should be inquired into. And the quality and duration of sleep has to be definitely inquired into. These are the 4 pivotal histories that every pediatrician should inquire in a child with obesity. So step number 2, are there any risk factors for nutritional obesity in the family in terms of diet, physical activity, screen time, and sleep deprivation? Step 3 would be ascertaining for metabolic risk factors. All of us are very well aware that as Indians, at a lower BMI, we have a lot of fat. This is the comparison of BMI of a Westerner, Professor Yudkin, and an Indian professor, Dr. Yajnik. And you find that at the same BMI, Dr. Yajnik has a much higher body fat compared to Professor Yudkin. So all of us as such have a higher body fat at a lower BMI. So we are all at the risk of metabolic complication, more so children. So this is a YY paradox. And to pick that up, waist circumference is a very, very, very valuable tool. It is measured with the child standing with a stretch resistant tape just above the lateral border of the right ilium. So please measure the waist circumference and plot it on the Indian charts. And if you find that the waist circumference is above the 70th percentile, you know that this child is at a significant risk of metabolic complications. Measurement of blood pressure. Every obese child should have a blood pressure measured. And this is a simple screening tool recommended by the American Academy of Pediatrics to identify children with hypertension. So this tool is very, very interesting because it is like increasing the pass percentage. You make the question paper easy, you set easy questions, and you give a very low pass mark. Similarly, these charts, this table has been constructed from children who are not obese, at the very lower percentile of height, and at the 90th percentile of blood pressure. So you identify hypertension in obese children very early. So this is a simple screening tool which should be used to interpret the measured blood pressure. And if you find that the BP is above this, please look into the child and ascertain that the child has metabolic risk factors. Clinical evidence of metabolic risk: presence of acanthosis nigricans, presence of skin tags. So 3 important clinical tools: high blood pressure, high waist circumference, and features of insulin resistance. So this would be the 3rd step. First step, we used the growth charts and identified obese children. Second step, we took a history and identified if they have any risk factors like diet, physical activities, and screen time and sleep deprivation. Third step, we did a physical examination, found out whether they have metabolic risk. What are the physical examinations to perform? 3: waist circumference, blood pressure, and a clinical examination for insulin resistance. The 4th step would be clues from the growth chart. Whenever you have a child who is nutritionally driven, but towards overgrowth, you find both the height and the weight pushed up. So obese children, because of nutritional obesity, are always tall. On the contrast, obese children, because of non-nutritional obesity, are not driven by insulin, so they are short. A tall and obese child has nutritional obesity. A short and an obese child has non-nutritional obesity. A child with poor growth velocity, you find that the height is crossing two major percentile lines in this growth chart. Poor growth velocity is an important clinical clue from the growth chart to look for a non-nutritional cause. This child had a very grave condition, craniopharyngioma. Obesity because of a neurological cause. The clue was there in the growth chart. Poor growth velocity and short stature. So I think the fourth step, do a proper growth chart plotting. Look for clues. Short stature and poor growth velocity are simple clues from the growth chart to pick up non-nutritional obesity. The fifth step, to look for non-nutritional causes as well as complications because of obesity. Simple head to foot examination. If you find the child who has significant anxiety, school avoidance, isolation, social isolation, are you looking at a child who has childhood depression? If you look at the child complaining of recurrent headaches, physical examination of the fundus showing blurred margins of the fundus, are you looking at a pseudotumor cerebri? If you find that the child is significantly snoring, child has significant daytime somnolence, there is tonsillar enlargement, are you looking at a child who has obstructive sleep apnea syndrome? If you look at a child who has significant abdominal pain and a large liver, are you looking at a fatty liver? If you find the adolescent girls has significant irregular periods and hirsutism, is it evolving PCOS? If you find that the child has significant orthopedic complaints, hip pain, knee pain, difficulty in walking, are you looking at a child with slipped capital femoral epiphysis? If you find that the child has significant polydipsia, polyuria, weight loss, unexplained weight loss in an obese child, are you looking at an evolution of type 2 diabetes mellitus? Ponder. If you see that the child has significant striae, significant hirsutism, hump in the back, are you looking at a non-nutritional obesity cause like Cushing syndrome? If you see that the obese child has a significant goiter, are you looking at a child with hypothyroidism presenting as obesity? Ponder. If you see that the child has a short fourth and fifth metacarpals and metatarsals, is this obesity related to pseudo-hypoparathyroidism? Please ponder. If you see that the obese child has an extra digit, are you looking at a child with syndromic obesity like Bardet-Biedl syndrome? If you see that the child has a significant strabismus, a significant neurological deficit, are you looking at a child with a neurological cause for obesity? Please ponder. And if you see that the fundus examination shows pigmentary retinopathy, they complain of difficulty of vision in the night. When the current is switched off, the child is not able to reach out to the switch and put off the light. Child gets very scared, tunnel vision. Think in terms of syndromic obesity like Alström syndrome or Bardet-Biedl syndrome. If you see that the child has almond-shaped eyes, hypotonia, learning difficulty, feeding difficulty, short feet and hand, are you looking at a child who has Prader-Willi syndrome? Please ponder. So the important fifth step in a child with, and of course, don't forget, in any obese child who has delayed puberty, there is no sexual maturation by 14 years in boys, no sexual maturation by 13 years in girls. If you see that the obese child has gynecomastia, are you looking at a syndromic obesity or an intracranial pathology? Please ponder. And lastly, if you see that the obese child is maturing early, you have early pubic hair, early breast budding, early testicular enlargement, please look into this child very carefully. This child may have something else that is sitting in and causing obesity and driving the overgrowth. It may not be simply nutritional. So these are the simple clues that a proper physical examination, which will be provided by physical examination. So the important red flag signs which should never be missed is height, obesity with short stature, obesity with poor growth velocity, obesity with early maturation, obesity with delayed maturation, obesity in the presence of a focal neurological deficit, early onset obesity with hyperphagia and dysmorphism, and presence of visual symptoms. So these are the important clues that help a pediatrician to identify children who have non-nutritional obesity or obesity-related complication. So the fifth step, perform a meticulous physical examination and see if the child has any complications related to obesity or clues for the presence of non-nutritional obesity. And the last step, in the assessment of an obese child would be seeing if the child requires any investigation. Ascertain cardiometabolic risk. Simple test, a blood sugar and a lipid profile will be very helpful. If you have a clinical suspicion of a comorbidity like non-alcoholic fatty liver disease, polycystic ovary, obstructive sleep apnea, slipped capital femoral epiphysis, hypertension, investigate the child further. Otherwise, don't unnecessarily perform too much of investigations. And secondary causes like hypothyroidism, prolactinoma, Cushing's should be thought of only if the growth velocity is poor or if the child is short. Every obese child need not be extensively evaluated for all endocrine causes. That is the current recommendation of the Endocrine Society. Unless you have a clinical clue like short stature or you have a clinical clue like poor growth velocity, don't unnecessarily perform too much tests. So if you find that the blood sugar is more than 125 or the HbA1c is above 6.5, you are looking at a child with type 2 diabetes. If you find that the LDL is significantly high, more than 130, HDL is significantly low, below 40, triglycerides is above 100 to 130, you are worried. So the golden number is 130 of LDL, 40 of HDL, and 100 to 130 of triglycerides. Basic simple test, a sugar and a fasting lipid profile would be sufficient. So this would be the simple 6-step approach to obesity in day-to-day practice. First, identify obesity. Accurate measurement of height, weight, either use the WHO chart in young children or the IAP chart in older children, or use the BMI lookup tool of the Indian Academy of Pediatrics. Identify that the child has obesity. Number 2, take a history and see if there are any risk factors like a diet, physical activity, screen time, and sleep time. Step number 3, see if there are any pointers to metabolic dysfunction. 3 important clues: waist, BP, and insulin resistance. Please measure the waist circumference, plot it on the chart above 70th percentile, be careful. Measure the BP above the value depicted in the AAP tables, be careful. Features of insulin resistance like acanthosis nigricans and skin tags, be careful. Step number 4, any clues from the growth chart: short stature, poor growth velocity, be careful. A proper physical examination to identify endocrine causes, hypothalamic causes, and monogenic causes. And step number 6, basic metabolic screening to look for sugar, lipid profile, and identify if there are any overt metabolic abnormalities. So this would be the simple 6-step approach to approaching an obese child in a day-to-day practice. At the end of these 6 steps, you arrive at either a child who has overweight or obesity with no metabolic complications, or you arrive at a child who has early metabolic complications, or you arrive at a child who has established metabolic complications like diabetes, obstructive sleep apnea, fatty liver, etc., polycystic ovaries, or you arrive at a child who has non-nutritional obesity. Either of these 4, one would zero into. If you are looking at a child with early metabolic complications or no metabolic complication, aggressive lifestyle measures, I think that would be the focus. Preventing from going on to the stage number 3. Preventing from going on to stage number 4 would be pivotal. Spend time with them. What would you do? Intense, age-appropriate, culturally sensitive, family-centric initiatives pertaining to diet, screen time, sleep, and physical activity. So let us go through this. I think all of us know what to do, what to advise on diet, what to advise on screen time, sleep, and physical activity. The Indian Academy of Pediatrics has given very beautiful guidelines regarding screen time recently. There are guidelines from the Endocrine Society. I have put it all together. So this is a very, very, very sad statement. This is probably first generation of children who may die before their parents. And I think that's a very, very sad statement. What can we do as pediatricians to prevent this? Diet. So I thought we follow this A to Z approach. There is no diet chart. Age appropriate meal and portion size. A for age appropriate meal and portion size. Less than 2 years, exclusive breastfeeding for 6 months, complementary feeding from 6 months, no sweetened beverages, no fruit juice. Above 2 years, 3 meals, 1 to 2 snacks, portion size as per age. Simple recommendations of World Health Organization is exactly what is recommended for them. There is no weight loss measure unless they have established metabolic complications. There's a tendency for a lot of nutritionists to put them on a diet chart, give them a diet plan with a significant low calories. I think the recommendation is subtract 500 calories if they have an established metabolic complication that is above 9 years. Up till 8 years, just maintain them. Give them age-appropriate calories, age-appropriate intake, which should meet their requirement of carbohydrate of 45 to 50%, protein of 10%, fat, free sugar below 10%, and low saturated fat. Ad lib intake of protein, dairy, fruit, and vegetables. B, breakfast should never be skipped. Never skip a breakfast. C, colorful food variety and presentation. The food plate should be made very interesting. It should be made very, very enthusiastic for the child to participate in the eating process, both what is sent to school and also what is had at home. D, a diet chart may not be the right approach to a growing child. Let the child have normal food and of course with moderation. E, eat on time. Please eat on time. Not getting a plate at 11 o'clock, eating the breakfast at 12 o'clock, having lunch at 4 o'clock, never. F, fiber content should be encouraged. The recommended fiber content is age plus 5 in grams per day. A significant intake of whole grains, lentils, fruits, nuts, which are rich in fibers. G, grazing should be avoided. Going on eating, 9 o'clock, 10 o'clock, 11 o'clock, 12 o'clock, going on eating, G, grazing should be avoided. Then heavy breakfast is always encouraged. Involve the child in the meal plan. Ask what the child wants to eat for breakfast. Ask what the child would prefer today for lunch, what the child's friend is bringing. Involve the child in planning the meal for the child. Junks should be avoided to less than 1 serving per week. So all of us know what junk is all about. Junk food, ultra processed food, non-nutritional utility food, and you have the foodstuffs which are rich in salts and sugar. So these caffeine containing foods should be restricted to less than 1 serving per week. Keep a portion of salads on the plate. It can go up to even 50%. Log-based, app-based tracing should be encouraged. Encourage the family to write a log of what they're eating. A lot of apps are available which can help them. Link the activity and the food. If you walk for 30 minutes, it's equal to having half piece of samosa. If you cycle for 45 minutes, it's equal to having 1 slice of pizza. When you link the activity and the food, the results are much better. M, minimum light early dinner. Minimum light early dinner. No caffeine below 5 years, no fruit juice below 2 years. I repeat, no caffeine below 5 years, no fruit juice below 2 years. These are IAP recommendations. Outside food, best avoided. Parental role modeling. As parents, we have to set an example for them and control the portion. Portion control is very useful. Quit processed food. Quit binge eating on festivals. Quit distractions on eating. India is a land of festivals. We have a festival almost every week. Avoid binge eating on festivals. Avoid distractions while eating. What are the distractions? Eating and watching TV. Eating and reading a book should be avoided. You should concentrate on the food and spend time. Or reward and punishment should never be food related. Stimulus control, slow eating. I think locking the kitchen up at times, avoiding keeping tempting foods in the kitchen should be avoided, and slow eating over a period of time, chewing and eating. Traffic light approach to diet. A red signal would be high fat, high salt, high sugar food. Whole grains should be eaten in moderation, like a yellow signal. Fruits, vegetables, and fiber-containing foods would be a green signal. Unite and eat as a family. Let all the family members sit together and eat. Variety of food for snack and lunch. Not the same meal every day. A mixture of whole grains, seasonal vegetables, and dal for lunch to provide a good variety. Water, water for at least 2 to 3 liters per day. Never force feed. Yearly seasonal fruits and vegetables is strongly encouraged by the guidelines. And zeal of maintaining a good diet should be encouraged through the maintenance as well as the active phase of weight loss. This would be a simple A to Z approach to tackling diet, not giving a diet chart and forgetting. Everyday consistent following these principles would be a sure success way to have a good weight loss. Screen time. The Indian Academy of Pediatrics has come up with new screen time guidelines as per the requirements of the pandemic. Remember, screen time increases sedentary time, more exposure to junk, more exposure to sweetened beverages, more snacking, reduced sleep. Less than 2 years, no screen time, not even for recreation, occasional video chats. 2 to 5 years, less than an hour, with a break in between. 5 to 10 years, up to 2 hours, and older children, 30 to 45 minutes for 4 sessions. Screen time, remember, no TV in the bedroom, no TV while eating. Follow the rule of 20. At every 20 minutes, look at an object that is 20 feet away for 20 seconds. Even while watching TV for a necessary purpose, do simple activities like push-ups, jumping, aerobics, etc. And co-viewing with the parent always helps to strengthen the parent-child bond. And this all of us know, obesity does not run in families. It occurs in families who do not run. Physical activity. See, these are simple recommended physical activities for different ages. And these activities are recommended for children above 5 years. You start off with moderate activities, then go on to vigorous activities. Moderate activities are one where during the activity, you can both talk and sing, like walking, cycling, etc. Vigorous activity is one where you can talk but not sing, like running, basketball, etc. If the family is a fitness freak, family activities like cycling, walking, swimming, etc. is recommended. And in times of lockdown, simple pandemic related like activity like skipping, dancing, push-ups, martial arts, yoga is recommended. These are recommended for 20 to 60 minutes per day for at least 5 days a week. I repeat, 20 to 60 minutes per day for at least 5 days a week. And remember, this activity, less than 5 years, there is no structured activity. It should be a fun way. Playful activities like cycling, park, skipping, etc. Activity log is very important. Take the help of apps and trackers. Group counseling activity help. Always have a routine, fixed time of the day along with the company will always help. Lot of parents ask, can we send the child to a gym? The recommendation is above 16 years. In severely sedentary children, start off with 20 minutes per day and slowly scale it up to 60 minutes per day. Pedometer, if the child has an access, very useful. Encourage day-to-day household chores and linking up with simple day-to-day activities like walking to school, taking stairs, etc. Lastly, but most importantly, sleep recommendations. These are again guidelines from the IAP. 2 to 5 years, it is 10 to 14 hours. 5 to 9 years, it is 9 to 12 hours. And above 9 years, it is 5 to 9 hours. So these are the 4 important principles: good physical activity, healthy diet, regular reduced screen time, and good sleep. So with this, you are able to tackle children who have no metabolic complications or early metabolic complications. Children who have established metabolic complications like non-alcoholic fatty liver disease would require metformin therapy. Children who have polycystic ovaries, remember, physiologically children may have polycystic ovaries. In the first phase, always the main treatment for polycystic ovaries remains weight loss, diet and exercise. Supportive treatment like OC pills, anti-androgens and metformins can be offered to them. These are the screening tools for BP monitoring for children with obesity. If you see that, these tables help the parents to help us to identify children who have obesity early, and it has to be confirmed by doing an ambulatory blood pressure monitoring. This ambulatory blood pressure monitoring helps us to confirm hypertension and decide on initiation of treatment. So ambulatory blood pressure is very useful. It helps to confirm and reinforce the fact that they require medication. And it also helps us avoid unnecessary medications like white coat hypertension. The indication for medication is LVH, symptomatic child, or persistent hypertension. And these are the lipid cutoffs to initiate on hypolipidemic therapy. For want of time, I'm just going to the important, the specialist support. When would they require specialist support? Only if they have established metabolic complications or non-nutritional obesity. This is a child you are going to see increasingly in future, 180 kilos with such a high BMI, and they want one magic pill to fight this out. And that magic pill, you have a cafeteria of drugs that are available, but pediatric indication is there only for 3 drugs: metformin, liraglutide, and orlistat. But the response is very, very, very poor to these drugs. Bariatric surgery, again, it's not a pediatrician's cup of tea. It is recommended only if the child crosses adolescence and becomes an adult. So to just sum up, at the end of 6th step, you also, if you find that the child has non-nutritional obesity, recommend growth hormone therapy for Prader-Willi syndrome, You set melanocyte therapy for Bardet-Biedl syndrome, thyroxine for hypothyroidism, neurosurgical referral for Cushing's syndrome. So this is our Prader-Willi support group. So this is how you would tackle obesity as per the stage and the severity. So common mistakes, all high TSH is not hypothyroidism. Be careful before starting thyroxine. All lipomastia is not gynecomastia. Be careful. All raised BP is not hypertension. Don't medicate. All irregular menses is not PCOS. Be careful. All genu valgum is not rickets. And all small phallic size is not micropenis. It may be a simple buried penis. So these are some IAP material which is available on the website. This is a parental guideline. This is a standard treatment guideline. This is a small slim book that we have at our unit. We can share all of them with you. Yeah, so just take home messages. Please measure weight and height. Plot them on the WHO charts, IAP charts, or the BMI lookup tool. If you find the BMI is elevated or weight for height is above the red line on the BMI lookup tool, you pick up obesity. Take a history and look for nutritional risk factors: diet, physical activity, screen time, and sleep time. Are there any pointers to metabolic dysfunction? 3 important tools: waist, blood pressure, and features of insulin resistance. Step 4. See the growth chart. Any clues? Short stature and poor growth velocity are important clues which the growth chart provides. Any complications? I perform a meticulous physical examination, identify complications of obesity, syndromic obesity, endocrine obesity, and monogenic obesity. Basic metabolic screening is sufficient. Sugar lipid profile is sufficient. If there are indications of complications, perform more complex tests. Stratify the child into which of the 4 types he has: no complications, early complications, established complications, or non-nutritional obesity. Aggressive lifestyle measures is the basic thing. In non-nutritional obesity, probably one has to involve a specialist. Established metabolic complications, rational drug therapy would be the key to fighting this, this unraveling pandemic of obesity. Thank you very much for your patient hearing.
Thank you, Hemant. Any questions, please?
I'll be happy to share this. Nothing is mine, actually. Everything is IAP material only. I'll send a copy of the presentation to the organizers. If you want, you can take it.
It's a nice presentation, sir. Because as a general practitioners, we take obesity lightly also, because it is not in our hands. Most of the time, it is the hands of the school, parents, and curriculum of the school. And I think policymakers should wake up and ask for 1 hour game spirit in every day in the school. This should be mandatory, and every school should have a playground. Then only we can control this obesity. It's not with only doctors. So as we control the marketing of baby milk foods, I think IAP also has come up to tackle this obesity with the policymakers. I think IAP central zone should make it. National body should make this point also and see that policymakers should identify and answer for this obesity problem. So any more question?
Well, one question. What is the appropriate age for introducing natural fruit juices in children?
See, the
2 years, you said 2 years or 1 year?
2 years, 2 years.
For what about avoiding salt and sugar? Is it for 2 years?
See, avoiding high fat, high salt, that recommendation is from 5 years of age.
Okay. Okay, thank you.
Any more questions?
A very nice presentation from your side. You mentioned not nutritional obesity and nutritional obesity. We come across most of the time, I think nutritional obesity is the most common one we are coming across. And you have mentioned some points regarding the dietary management part. How is it possible to calculate the amount of calories, especially in a nutritional obese child? As you said, you cannot cut down the diet what they are regularly consuming as according to the age what you have mentioned, less than 2 years, 2 years and 5 years and above 1. Is it possible to mention how many calories a nutritionally obese child is supposed to take. If you happen to cut down the calories of nutritionally obese child to what he is taking, what is recommended, I think we are bringing down to lowest possible thing. Is it advisable or how is it possible?
See, thank you, sir, for raising that. I think that is exactly the reason why the concept of diet chart is not advised and not recommended by any of the authorities in management of obesity. What would be wiser is to encourage the families to take age-appropriate diet, appropriate for the family and their necessary circumstances, to include 3 meals in a day and 2 snacks in between, what is recommended for that particular age. Regarding restriction of calories, that is recommended only in the presence of established metabolic complications, and that too above 9 years of age. So at the younger ages, it is not recommended.
My question is, do we have to mention so many calories have to be taken beyond that particular age? Say, for instance, a child is consuming 4,000 calories, where your recommendation 2,500 calories. How do you come down from 4,000 to 2,500 in just in a day or two? It's not impossible.
Yeah,
if we did bring it down, I think it affects largely on the child as well as the family.
True. See, that is why the recommendation is not to enforce a very rapid weight loss in a very short while, because it's going to come back with a vengeance. So the current recommendation is 0.5 to 1 kg per week, not more than 1.5 kgs within a very short period of time. So I think portion control would be the wiser approach in such children who are consuming very monstrous amount of calories, to restrict it by a small portion, reduce the portion. So that will slowly bring down the families in the targeted weight loss. And it's also recommended that they have periodic contact to ensure that they don't lose weight very rapidly and land up with other complications.
Thank you, sir. Time is up.
See, as long as children are concerned, there is no recommended that you do them on a fasting profile. Fasting lipid profile is not mandatory in children. But suppose you're considering initiation of therapy, or if you find that to be significantly high, then it should be repeated by doing a 12-hour overnight fasting. For screening purposes for metabolic complications, a fasting is not mandatory. Sir? See, usually lipid profile can be done in children because you have normative data above 2 years. So it can be done in children above 2 years. Screening for dyslipidemia is recommended above 9 years of age. Yeah, 2 snacks. Yeah. Yeah, taken it from a reference, 3 meals with 2 snacks in between to meet the recommended daily allowance for the family. Definitely. So that is why IAP has come up with very, very strict guidelines on screen, not to exceed beyond 1, 2, and 3 hours.
Thank you, Ananda.
Thank you. Thank you.
Let us conclude.
Thank you for your wonderful and valuable presentation, sir. Now I'd like to request Dr. PSN Murthy and Dr. Y. Sai Kishore to felicitate Dr. Hemachand K. Prasad. Thank you, sir. Now I request Dr. Nagaya Naidu Garu to present the medals for the undergraduate quiz winners. First prize gold medal goes to Abdullah and Samba Sivarao. Katuri College. Samba Sivarao. Silver medal goes to B. Gayatri, C.H. Rahul, Ashra Medical College. Thank you, sir. Now I'd like to call the chairperson of the session, Equipping and Maintaining in Intensive Care Units, Dr. Durga Prasad, sir, to introduce the speaker, Dr. Dinesh Shirla.
Ladies and gentlemen, good afternoon. It is an honor to call upon Dr. Dinesh Shirla, a well-known personality, not only in Telugu-speaking states, Andhra and Telangana, but he has a pan-Indian presence, and he has a lot of students spread all over India. He is known pediatric intensivist and a neonatologist also. He was trained not in India, in Mumbai, and after that he has gone to Australia and had further highest training over there. And after coming over to India, he started his career in Rainbow Children's Hospital, Hyderabad. From there, with his academic, authority, he has started so many branches all over India, and he is the one who started the student training programs across India in various branches of Rainbow Hospital. And he has many fans all over India. I am one of them. There is much more to say, but with this brief introduction, I request Dr. Dinesh sir to start his lecture.
Thank you, Dr. Durga Prasad Garu, for your kind introduction. And this is one topic sir has been asking me for long to talk about: equipping and maintaining an intensive care unit. And when I looked at, there are a lot of hospitals which have been coming up. And there are hospitals which are already established, and there are hospitals which are sort of new, which are coming up. When you look at an intensive care unit like this, and this is my intensive care, newborn intensive care unit. On the left side, this is a child who's on high frequency oscillator, who's being cooled, who's on inhaled nitric oxide, and completely sort of, treatment. On the left side, you have a child who's having ECMO, ventilated, continuous renal replacement therapy. And you say, how do I plan an equipment for this child? So when you're planning an equipment, the first question comes to you is, are you establishing a new unit? Or you buying a new machine or upgrading a new machine in your unit? Like you have already established hospital and you want to buy a new machine. So when you're preparing to buy an equipment, the first question you have to ask yourself is it a level 2 unit or a level 3 unit or level 4 unit? Because that is where you list off the equipment which you have to buy. How many beds you want to have? You have a central air and oxygen versus, because that's what determines whether your ventilators will have a compressor or it have a central air and oxygen. what type of ventilation. You just want a level 2 unit which will deliver only a CPAP and HFNC, versus you want an invasive ventilation or you want high frequency ventilation, because that is what determines the equipment. And what type of monitoring? When I say you will have a centralized monitoring system or you just have a bedside monitoring system. Two, what are the other assets when you're buying is having a good biomedical engineer makes a big difference to you when you're buying an equipment, because that reduces actually a lot of your expenses, because they will be good, because our knowledge about an equipment will be really limited. Also checking what are the after sales services of equipment is very important. And speaking to some of the people who already are using like calling up some of the hospitals to check up how this particular machine is working with them, how is this particular company giving a services is going to be important when you are sort of, trying to do that. And the most important thing I think is the budget, because how much money you have with you. So how are you going to spend that money? Now this I'm talking about public sector or a private sector. Recently I had call from, because I think the recent allocation post-COVID, when people were talking about third wave, when people expected in the third wave, a lot of children are going to be affected. So there's a lot of budget allocation even in public sector for children's hospitals. So the government was allocating, say, 100 crores or 50 crores and say, buy. So what are you going to do with that money? So you need to know what to do with that money. What are the different equipments you're going to buy? So you can prepare a list by saying, okay, in an ICU for thermoregulation, how many warmers, incubators, what sort of monitoring I should have, for the phototherapy, ventilation, I need a CPAP and NIV, what sort of modes I have, should I need a high frequency or not? 2, for medication purpose, do I need a syringe pump or infusion pump? In an ICU, should I need a laminar flow for TPN preparations? Humidifications, disposable versus reusable. Do I need pneumothorax for cold light? Imaging, like you will need an X-ray machine, a portable, and of course nowadays ultrasound has become a necessity. When it comes to PIC, you would talk about beds. You need an sort of beds which are sort of monitored with warm blankets are there, or sort of auto-adjustable are there, and similarly all the list. But nowadays we have dialysis machine, monitoring, and ECMO. So the first thing is prepare your list. Then normally, like for a unit like us, then I have sort of some of my colleagues in there, I do commonly get a request, I want this machine. Because sometimes you have someone bought a cooling machine and there is a request coming, we also should buy a cooling machine. Or someone is doing a high frequency, let us also buy a high frequency. Or someone is nitric. So how do you do? Do you buy a machine? So you should first see what is the patient load. So how many patients of hypoxic ischemic encephalopathy do I see in a year? Or how many patients of PPHN do I see in a year? So then you say, what is the cost of this machine? What is the cost? So you see about cost effectiveness. And that is when you talk about whether you're going to buy and whether you have a necessary medical and nursing expertise to run this before you start buying. So this is the basics you do before you buying the equipment. Then how many numbers you need is the next. That is when you are saying, when you talk about a level 2, level 3, level 4, you have to say whether you are doing a 12-bedded NICU, you are doing a 18-bedded NICU, you are doing a 6-bedded PICU. Based on that, you have a delivery room, you say about airway, breathing, circulation, delivery room. You need a transporter in ER, you prepare a list like that. Always it is useful to compare or ask someone with a similar size of hospital with similar workload and ask. Because even our own setup, when I'm doing number of hospitals, suppose I'm doing an expansion within, suppose we are establishing the Vizag unit. Then I say, okay, what is the one which is comparable? So how much is my Vikrampuri sort of bed strength? That is comparable. So how many ventilators I have? How many equipment monitors I have? How many? So we try to compare based on the workload and other things. So if you're doing something, a big unit in Bangalore and doing one in Hyderabad. So like that, you do a comparison, because like that, what happens, you don't overshoot your budget or you don't undershoot also. So comparison does help in your, then the next set is processes. So different components and models are available. So you need to enlist all of them. You need to have a different specification completely written up. cost, what type of disposables are required for the running the machine, and the very, very important for all of you is after sales services. Because most of the time, most of the companies are good in selling, but they don't give after sales. Because there might be someone sitting in Bangalore, you bought some machine in Guntur, that guy doesn't come till 1 month to fix it. When your machine is not working, it doesn't work. So you need to know who is the local player who is going to do your after sales service when you're buying a machine, and always do a reference check. So let us look at some of the normal machines which we normally use in our pediatrics and neonatology. So one of the common thing for resuscitation is TP's resuscitator. So most of us have, apart from ambu bag, we have come now that we need a TP's resuscitator. We know that with ambu bag is not enough, because we need to control a PIP, and we should also give peak anticipated pressure. So what, and we also need a blender. Either you have a centralized air and oxygen, or you might need a blender. That is what is the latest. So what are those available now? You have a NeoPip by FlexiCare, or you have Resus Plus by GE, Phantom is giving, Neoforce is giving, and Fisher and Paykel. Then what are the, you have a TP's, you have a universal kit from TP's resuscitator, which costs around 1,500, which is a disposable one. So you need, you can have one sort of comparables with the specification, what sort of flow you require. And important is blender. See, out of all this, G is the only one which comes with an inbuilt blender. The others are what? Which means unless you have a central air and oxygen, you can't buy a G. For others, you can have an outside blender, or you can run with normal only oxygen, but you'll be giving 100% oxygen. Second thing is, do you want to carry your TPs from while shifting the child from NICU to the ward, or from the labor room to the NICU? So what is the weight of the, is also another thing which you'll have to look into. And of course, the last column is your cost. So these are the factors which will determine when you are buying the equipment. So I need not stress more that there is a good evidence in ELCOR guidelines. This TPs gives you peak anticipated pressure, better lung recruitment, and the respiratory distress is much less in children, and especially preterm baby who have been resuscitated with TPs. The PIP is also better controlled. So you also have to look at the different mass size. Now coming to resuscitation warmer. So you have different, see, I've just kept some of the machines which I commonly deal with. I've not kept all the machines. I'm sure you would have come across differently. So there are some local company machines also. So very important is accuracy of the water you're giving. Is it accurate? And durability. These are two things we should check apart from the cost. So GLLB is there. Phoenix C1C101 is there. So when they try to tell you, they tell you lost. Sir, temperature is there, Apgar timer is there. Maybe this is fine. But say, sir, it has a built-in monitor is there. It has a built-in TP's resuscitator is there. It also has got a weighing scale. You also have an X-ray plate in that. So what you have to think is, this is G Panda Resus, which has all these features. So now when you try to compare this by making a chart like this with the specification that some have weighing scale, like G Panda's place has a weighing scale. It has the X-ray cassette holder. It has a height adjustment. So this resistor can be in the delivery suite or can be as a part of your first bed in when a patient gets admitted to your unit. You have to make, is it worth that big cost it comes with? So how do I make that call? How many deliveries you have or how many admissions you have per month? What is the type of patients you deal with? What is the cost they pay? So if it is most of them are sort of a lower middle class, lower class people, buying some equipment which is very expensive doesn't make, it is not a cost effective way of buying those equipments. How many very preterm babies you take care of them? And is the staff equipped to take care of all the advances? Otherwise, a machine which can keep the baby warm and can give you Apgar timer is good enough for your resuscitation. So this is what we do. The next thing comes in your transport. When you're looking at transport, if you're mainly dealing with big term babies or late preterm babies and not dealing with other small preterm babies, ectothermic mattresses is good enough. But if you're shifting babies, either where do you use transport system? You might go for some warm. There are different types of transport incubators which are available. Some Globetrotter TI500. Recently, we developed one. We have done our own where we are doing oscillation while doing transport. This is India's first high frequency oscillation during transport and nitric oxide. We transported one baby like that who had a nitric oxide. You can see on the second one, there's a nitric oxide system on the top, and then there is a oscillator, which was an electronic, which was fitted on our this thing. This we have designed by ourselves. Or you have Phantom, then there is a Phoenix also. So how do you determine which one to buy? You prepare a sheet. What type of transport you want? What is the battery backup? How many hours? So this is based on how long you want to shift the patient. And of course, and how many oxygen cylinder carrying capacity. And the noise level is very important when you are shifting the new babies, because if the transport incubator makes a lot of sounds, then it doesn't make much sense. The Globetrotter is a beautiful machine, but it's very expensive machine. So do you really need that if you are not doing too many transports? But it's very durable. It lasts for nearly 10 years. So I think cost versus durability are also other factors which we take into consideration when we are equipping any intensive care unit when it comes to transport system. So when I'm buying a transport incubator, I say, when I'm doing long distance transport or short distance transport. If I'm doing short distance transport, I probably don't go for an expensive transport ventilator. Only within hospital, OT and lower room, you can go for something simpler machine. And if you plan to ventilate, then only go for something like Globetrotter. Otherwise, you can buy just a transport ventilator incubator, and you can buy a transport ventilator separately. And I can show you that. And also, how big is your ambulance? Radiant warmer is another thing which we commonly sort of put in. And there are different types of which one were available. And what do you see when they are doing? What time they take to warm up? Do you have adjustable height? Do they have something to fix the sort of, you take the X-ray. So you should have an X-ray plate to be adjusted to there. So these are some of the things which we need to take when we are taking and whether they have proper wheels when you are moving them. And of course, whether, the cost factor is the other thing which we see. So X-ray cassette holder is available. Weighing scale sometimes do find that they may or may not be very accurate when it comes to some of. Same thing is with the incubator. We have different types of incubators, some of them which can go up to become sort of, warmers, hybrid, but your Draeger, Phoenix, Giraffe, Atom, different companies are available. Even Phoenix have come up with the transport sort of this thing. And usually we use for children who are less than 1 kg. And this, when you are buying them, this is what you have to see. How do they humidify? Because one of the biggest concern with the transport with incubator was about infection risk. So how do they circulate? Is there a risk of infection in that? How can we clean it? How is it double walled or not? These are the factors which you should be asking when you are buying any transport incubator. So in the bottom line, I gave you the approximate cost. One of the biggest thing is all of us is we are very, very excited when we buy ventilators. Most of our consultants also, because anything new comes into the market, we say the new mode has come in, let us buy it. So we do not know whether that mode is going to be useful or not. And that is the most common way when any sort of this guy's salesperson tries to sell it. So this mode is there. It will tell you about, resistance. It will tell you about compliance. It has this volume mode. It has a PRVC mode. So you need to first decide what are the modes which you are going to use and whether your unit is capable of using that or not. Of course, the newer modes which are like volume guarantee is a mode which is being used very much in newborns now. And if you can afford that, of course you should buy it. But don't go for fancy modes just by putting in too much cost. See, there is one ventilator which costs 28 lakhs, 30 lakhs. But if you're not going to take care of very small preterm babies, 500, 600 gram regularly in the unit, I would say it's a waste of money. But if you're going to take care of those babies routinely in your unit, then it is worth the money because it measures tidal volume as small as 0.2 ml. So it's like when you buy our phone, isn't it? iPhone 12 comes, iPhone 13 comes, you go on buying them. It is different. That is your personal things. But when you're buying equipments, we need to be very clear about what is the function of it. And we also look at cost effectiveness. like pulmonary graphics are there. And the most important thing is what type of disposables we use. So this is like, Dragas, SLE 5000, Sensor Medics. This is Babylag 8000 with volume guarantee mode, VN 500 with VG modes. These are pulmonary graphics which are available. The flow sensors, because the flow sensors, sometimes they can get blocked. So how easy to clean them? So these are the questions you should be asking the sales guy when you're buying this equipment. And knowledge of that will make a big difference for you when you're buying, because otherwise you end up sort of buying this equipment, which becomes like a white elephant in your unit, and you don't know what to do with it. Now, there are some machines which does a dual purpose, which means they can do conventional mode and high frequency mode. SLE is the machine which does not do high conventional mode, it only does high frequency. Similarly, MAC-A and GE are the machines which is Servo I, Servo S, and the K station. They don't do high frequency, they only do conventional ventilation. So based on the type of population you are doing, whether you're buying for NICU or PICU, a list of these machines would help us determine what type of machines you need to buy for your. Similarly, when you are buying an oscillator, you want a pure oscillator, you buy that, but you're going to occasionally oscillate once or twice in a year, or maybe 4 or 5 times. I would still buy a hybrid one, like something like SLE or Acutronix or a Drager, which will help me sort of be cost effective, because I can use that machine sort of at least throughout the year. So I know there are different types of INO. What we use is more of SLE INO system 3600, but there are newer nitric oxide system which are available. Now, what your questions you have to ask is whether they are compatible with which ventilators. Are they compatible with all the ventilators or not? Like SLE is compatible with SLE, Sensimidis, Drager, and MAC-A. So because there's no point if they say, oh, my nitric oxide is compatible with only this. Second is what type of circuit they require. And the one thing I came to know after buying the machine is that we need to change the sensor for the nitric oxide calibration every yearly, which costs you 1,20,000. So there's a recurring cost when you buy them. So these are some of the questions which you need to ask when you're buying the machine. And since these are some of the consumables which we sort of buy, see, Fisher and Bickel will comes with which can you use for Babylog 8000, and there's a universal circuit if you can, and that will be very useful information for people. RT268, which is a universal circuit which can be used for all the ventilators, because sometimes you have to use some of the circuits which is like intersurgical can be used only for SLE 5000 and 6000. Similarly, the VentStar can be used only for the more for Dragers and the MAC-A. So having some knowledge about what disposables will be used and what you should be asking when you're buying the machines, especially the ventilators, is what sort of, you have some reusable circuits which they provide. So how many reusable circuits he can give it to you? That is one thing you can ask. And also they give you a sort of warranty, whether you can extend the warranty for 2 years or something. Some of these things should be very important when you are buying equipments. Bubble CPAP is another thing which is sort of most of the units are having now. It's a relatively simple machine, and I think they're not too much of sort of mechanics into it. So you can choose any one of them. The cost is very much similar as far as bubble CPAP is concerned. Whoever gives you good service, you can pick them up. Monitoring is one thing I think we should not compromise. That is how you would pick up how the child is. Sometimes you end up buying cheaper monitors. They don't pick up. See, what picks up your saturations when the perfusion is poor is very important. You have a child with saturations are you put in and it doesn't pick up when the child's perfusion is poor, it doesn't help you. So buying good companies is going to be very important. And with touch screen, what type of screen you want, how many channels you want, and it should be able to be upgradable or not. These are the questions which we sort of ask them when we are trying. Philips is there, G is there, Neon is there. You have Mindray is there. These are the different companies which can which can be useful when you're talking about buying the monitors. Now, most of you, I think, who are using sort of transfibrillation either for pneumothorax or sometimes even finding the veins in the small preterm babies. These are the different things which we use sort of as a vein detectors or for this ABG machines or other things which we should be keeping in all our unit. Now, what we found that used iStat is one machine which we sort of kept, and I would say many of you can keep this. Now, there are different ways when you buy a machine like this. They can give you for rentals, so you don't have to buy the machine. They give you for rentals, and then you negotiate for cartridges. So, okay, so they talk about, okay, we give you machine for rentals, but we talk about 100 cartridges per whatever you talk. So that is the way ABG machine, that's how you can cut down your costs on. So when you're equipping your machine, your ICUs, these are the different things you have to have a knowledge about where to spend your money on. So ABG machine otherwise can be pretty, the earlier ABG machine, they come 24 lakhs, 28 lakhs. So there's too much of cost involved in sort of equipping your, but if you say I'm ventilating, but I don't have ABG machine, we just had a, panel on medical legal. That's not acceptable. You can't say I don't have an ABG machine, but I want to do that. So you have to do that, isn't it? When you're taking a legal responsibility of ventilating a child, how can you not have an ABG? So have something simple like this, and you have some cartridges, and they come with different packages. Do that; it gives you pretty much decent ABG about this child, and that should be fine. So I think trying to make yourself safe, medical legally, is also very important whenever you are equipping your ICU. Now, not only this, there are a lot of point of care testing which is coming up, and this is a new thing which is going to come very soon, where in fact you don't have to send samples to lab also. You have few distinct cartridges, keep it by bedside. Most of your blood tests might come back just by bedside. This is something which we might come up in future, and we may not have to sort of send a lot of sample to our lab. Most of the blood reports might come just in your ICU itself. Now, as time progresses, then we are coming up with newer modalities. Like suppose now, a lot of us are seeing children with hypoxic ischemic encephalopathies, and whether it's based on the type of population you're seeing. So whether you should do something like Mira Cradle, there's a huge debate about whether you should cool in a developing country or not. But I think, so heard me and these things, I think there's a good evidence that cooling does help the brain. So I don't want to go in detail, but we should cool. And if you're cooling, there are different things which are available. So, because what will happen unless we get a clear guidelines about whether we should cool or not, someone will come up and say, why you do not cool? And it is definitely neuroprotective. If you cool and you don't do other things, that's when you say it's not effective. So now either we say you send off to people who do cooling, or you should have some mechanism of cooling them, taking care of the intensive care aspect. So either there is a tacotherm, or there is something called critical, which are there available. You can see, and both of them are fantastic way of this is a servo controlled way of cooling, which you can sort of see. It is based on, this is a tacotherm, the earlier one was critical, and that controls, gradually cools the child, keeps them in a particular temperature, and gradually sort of warms them up at 0.5 degrees centigrade per hour after 72 hours when you want to really sort of warm them up. So this is something, when you're doing cooling, having sort of EEG monitoring is other things, again quite expensive, but we need to see whether you need to want that or not in the machine. X-ray machine is very important aspect whenever you are having anyone in ICU, because you can't say I have an ICU, I can't have X-ray machine. How are you going to pick up a pneumothorax? You don't know. If you're ventilating a child blows up a pneumothorax, you can't say I'm calling a radiographer or something or this thing. So we need to have an X-ray machine. And so Siemens and GE Healthcare are some of the ones which are, Scanray is also another companies which are there who come up with, these are different types of X-ray machines. And we have a sort of GE. We need to have some essential things like defibrillators. These are basic machines. I'm not saying, so have any decent machines which are, the Neon is there, Philips is there, which we sort of can keep. We should be there in the anywhere who is providing any intensive care stuff, because they are useful. Transport ventilator, if you're not having incubator. So these are something which might be useful for people who do not have a transport ventilator with in the incubator. Like we use the Smith baby pack, and for the pediatric, we use the RestMed, and they can ventilate. So for those who want to establish a transport, this is something which can be looked into. And of course, the list goes on. See, now I would say, I thought whether we had exhausted the list, but now we're doing ECMO, then we're doing the dialysis. There are different types of dialysis machine which can do continuous renal replacement therapy. You have Fresenius, where the circuits are cheaper. That's why we take that. But then we have Prismaflex, which can do at much smaller tidal volume in the smaller babies. Like we recently did the dialysis in the smallest baby, like, in a newborn. That could be possible only in Prismaflex. So now how do you maintain them? When you're maintaining equipment, there are two types of maintenance. One is a scheduled maintenance and non-scheduled maintenance. So scheduled maintenance is doing some preventive maintenance or annual maintenance contract and calibrating that regularly. Or non is suddenly the equipment breaks down, what you do and condemn. Or condemn the equipment which are not functioning. So what you should do is you should have a biomedical engineer who could take care of this. So the objective of preventive medical is to minimize breakdown and increase lifespan of the equipment. And this we should do periodic checking and service of equipment as per the PMS schedule. Similarly, all of us who have equipment, I'm sure those who are having industry will realize, if you don't have an annual maintenance contract or CMCs, what happens is the cost of repairing that becomes too huge. So having an annual maintenance contract with them, or having sort of in that sort of adding the, whether you like to add sort of warranties into it or extend the warranty is very important component when you are maintaining equipment. That is what saves you lots of money in long term. Otherwise, that increases your cost. You should have your biomedical engineer who regularly calibrate your equipment to ensure that the accuracy of the equipment, even things like your, say, phototherapy or your ventilators, everything has to be calibrated periodically, which is part of, and for every equipment, we have one booklet which talks about breakdowns. So if the machine fails, what is to be done? So like there is a list about all this machine, how frequently they have to do daily checks, which are the machine which have to do once in 6 months check, which are the machines which have to do a monthly check. Prepare a list like this, which will help the overall maintaining the equipment and prevent sort of unnecessary breakdown of these things. So I think, see, when you have something like equipping and maintaining ICU, it's a very, very variable topic and very individual based on what you want to do in your unit. So I think it's very important for you, whoever is planning to set up a new unit, want to upgrade a unit, is to have a chat with the person who's already doing it. Because the guidance which you get when you do that is immense. Because reinventing the wheel, you'll always burn your fingers. So there's so many people, even from government or something, when they are trying to do, they have a chat. And that helps with you, when you're talking to the guys, like the marketing guys, when they're selling them, to say what are the things you need to negotiate. And also having a local feel about what sort of after-sales service you will have, what type of disposables you need is also very important when you are starting to invest in a good biomedical engineer. If you're having a decent sort of, or anyone who has a good knowledge about equipment is very important when you are managing a decent ICU. With this sort of, I thank you, the organizers, for giving this opportunity to sharing this. Thank you very much.
Thank you very much, sir. There is a branch of engineering known as financial engineering in some of the universities, but I never know that there is something like financial medical engineering, which you have, sensitized all of the pediatricians regarding various aspects of financial aspects of buying the equipment, contract maintenance, and all those things. It is really useful for younger ones who are going to start their life by investing in all these equipments and start a new branch. So thank you very much, sir, for the sensitizing all of us.
Thank you. Thank you very much.
Thank you for your informative presentation, sir. Now, I would like to request Dr. Durga Prasad Garu to felicitate Dr. Murli Chirla Garu. Thank you, sir. Now I'd like to call the chairperson of the session, an update on dengue, Dr. Tattaman Naidu, practitioner at Ongole, on the stage to introduce the speaker, Dr. T. Chandrasekhar.
Good afternoon. Dr. Chandrasekhar sir, in AP, there is no need for introduction for him. I'll tell a few words. Some people are extremely good because of their inheritance, and some people are extremely good because of their institutes. But he is the person having both. Some people are extremely good in their clinics, and some people are extremely good in their academics. He's the person extremely good at both. And sir, I want to tell one thing. Before joining into my PG, I have a dilemma, which branch to join. Once I met him and I joined pediatrics. Dr. Chandrasekhar sir did he MD from PGH Chandigarh. Every hospital known by the hospital name, but his hospital mostly known by his name rather than his hospital name. So, carry on, sir.
Thanks for the kind words. I could convince you to join pediatrics. I couldn't do the same. I'm not able to do the same with my children. Okay. So, okay. At the outset, I thank the organizers for giving me this opportunity. I was asked to speak on updates on dengue, but we know nothing really changed over the last 10 years. So I would like to label it as a recap on dengue. So what all we will discuss today is we'll discuss the classification, do's and most importantly, don'ts in dengue, the routine scenarios we see in day in day out practice, and other miscellaneous issues which needs some address. Yeah, with respect to the classification, we are all well versed with the classification. This is the 1997 classification of dengue. One is undifferentiated dengue, classical dengue, wherein two or more of the features are seen: dengue hemorrhagic fever and dengue shock syndrome. We all know it. So just for the sake of reminding everyone, just I have put up this slide. In 2009, WHO came up with a different classification, which has three aspects. One is dengue without warning signs. It's just rephrasing what has been described in 1997. Here also two of the fever and two of the features, with the child having the ability to take feeds well, fluids well, and passing urine well. So this is a child with dengue with no warning signs. Obviously, the next one should be dengue with warning signs. We know this is the most important aspect we all should understand in our daily practice. If this is the stage, one needs to be careful. One needs to pick up these cases. So, abdominal pain, tenderness, clinical fluid accumulation, mucosal bleed, lethargy, hepatomegaly, and evolving thrombocytopenia. Because this is where the counseling of the patients becomes a huge headache for all of us. We talk about platelet count every day, but with respect to the treatment, we don't do anything for the platelet count. So parents are really annoyed. Platelet count keeps on falling, and we just tell them wait for 1 more day, 2 days, or 3 days. So these are the warning signs. So what should you do with the low platelets? We'll discuss in due course. And infancy, as far as our profession is concerned, is also a evidence of dengue with warning sign. Say a child lives somewhere far away, is inaccessible to the medical care. So those children also fall on this category. Of course, dengue shock syndrome or severe dengue fever, we know it. Yeah, this is the other way of putting this is a famous, is the most very famous picture we all know. However, therapeutically, this classification is more useful for all of us. This is a 1997 classification only. DH3 and DHF4 are the dengue shock syndrome or severe dengue manifestations. So there are two revisions proposed by WHO. One is decompensation of chronic disease and minor bleeding, both of them falling into the expanded dengue syndrome. Yeah, nature is so great. If I tell you of 100 dengue viral infections, 75 are asymptomatic, they don't see the doctor at all. Only 25% land up with us, of which only 1 in 20 will go into the dengue shock syndrome. So nature has a wonderful way of protecting the mankind, and we have treated so many cases of dengue shock syndrome. I have done this, I have done that, but we should all be thankful to what the nature is doing for all of us. So dengue shock is the expanded dengue syndrome. WHO has coined this term to describe cases which don't fall into either DHF or DSS. So these are the different organ affections that are put up under expanded dengue syndrome. We'll go for scenarios. This is the commonest scenario we see in our OPD practice. Fever for 3 days. Otherwise, child is okay, has mild headache, has good oral intake and good urine output. Should we really suspect dengue? In the present scenario, yes. Yes. This is the picture showing what all may be the cause for fever. And please do remember, dengue can coexist with other illnesses. That is my only point of information I want to give. It can coexist with other infections, especially the most important one is COVID, which we are going through, we have gone through. Hopefully, we have gone through. We don't go through it again. So the message is dengue is a DD in all fevers. Of course, we need some information how to differentiate between MIS-C, dengue, and strep typhus, because these things are closely linked to each other. It is all three are common, and we should have a open-minded approach to really consider all these differentials. I don't want to go into details. It is available in all standard textbooks. So we know this is how the rash looks. The earlier maculopapular rash, how there are pressure marks. This is the tourniquet test showing petechia. This is the classical Isles of white in sea of red. So of course, the diagnosis of the initial scenario is dengue without warning signs. What are you? Okay, before we go on to what we should do, I just briefly address primary and secondary infection. Why I will tell you. We know there are 4 subtypes. Infection with one virus, one then one or something, will grant lifelong protection to that serotype and a limited protection to other serotypes. That limited period is somewhere between 1 and 2 years. If we all know, we were all seeing dengue for the last 12 years, dengue epidemics alternate. If we have a dengue epidemic from a certain place in this year, we will not get cases the next year. We will have a dengue epidemic the year later. So this is the reason, because secondary dengue can have antibody dependent enhancement, which can lead to very severe manifestations. So how do you really differentiate between dengue, primary dengue and secondary dengue is your antibodies. This is how the viremia and the antigens and antibodies develop. This is a very interesting, important pictographic description of this thing. If NS1 and IgM are positive together, it is mostly primary dengue. If NS1 and IgG are positive, we should be more cautious. You can always tell the patient to be more careful. That is secondary dengue. If NS1, IgM and IgG, all three are together, then the titers matter. If IgG is more than IgM, it is secondary. If IgM is more than IgG, it is primary dengue. But we can reasonably caution the patient about a upcoming DSS or severe dengue. Of course, without warning signs, we advise OPD management. We should inform them about natural course, especially about the development of dengue shock syndrome or severe dengue. Use only paracetamol for fever. Do not use other NSAIDs. No steroids. Advise plenty of fluids. Plenty of fluids means you can advise WHO recommended ORS. Please tell the patients not to use the routine health drinks that are marketed, because the osmolality of the health drinks that are marketed is somewhere around about 580 up to 600, whereas the recommended osmolality is 245. They are likely to cause more harm than good. You can ask them to take coconut water and rice gruel if someone has the ability to make at home. Please tell them to be careful at the time of defervescence. So monitoring is very important. Please monitor them with respect to all these parameters. When should they be cautious? When there is clinical deterioration, especially around the time of defervescence, inability to take orally well, fever comes down and the child is not looking well, abdominal pain and all the signs of warning signs if you are seeing. So all these things should caution you and make them ready for admission or at least a closer look. So one point we should remember is till the last stage of shock, they can appear very conscious and they can appear very alert. So that's the reason the close monitoring is mandatory, because this is where every one of us would have missed at least a couple of cases or a reasonable number of cases, because when the child is looking well, we tend to, okay, this child is okay, let us reassure the patient. So admission is warranted when there is platelets less than 10,000. And warning signs are indication for admission. Infants and obese patients, associated comorbidities, and adverse social circumstances when they are living far away from medical facility. Even when they are looking well, please err on the side of safety by admitting them. So next scenario, where what we see in our practice is the same child presents on day 4. That is, the first child presents on day 3. Let us imagine this child presents on day 4, has abdominal pain, looking dull, lethargic, has maintained blood pressure, has evidence of petechiae and hepatomegaly, and there is epigastric tenderness. Of course, we can definitely say this child has clear-cut warning signs. So these are the investigations which showed evidence of NS1 positivity, there is evidence of transaminitis and elevated APTT also. So we are dealing with definitely a child who is having dengue with warning signs. This is one of the very important picture we all know and we all should memorize again and again. All the issues start round about the time of defervescence. When child has fever, usually nothing happens. But at the time of defervescence, the dehydration goes up, hematocrit goes up, platelets drop, and evidence of all adverse things are seen. Of course, so dengue with warning signs. So what are you going to do? Child is able to take orally, even at this juncture, you can definitely encourage oral intake. Goal is to maintain good urine output. You can ask them to empty the bladder in a bottle and measure the urine output every 4 hourly. And if there is evidence of worsening, or the child is not taking well, orally well, go for IV fluids. What to start, when to start, how much to start is a big issue. You can't start just like that. This is a rough guideline as to how much of fluid should be given during the critical phase. So this is only a rough guideline. There's not a picture that needs to be followed tooth and nail, but this can definitely guide you. A rough guideline to decide on the amount of fluid that needs to be given during the phase of warning signs is this picture, as well as sorry, back. Okay. The hematocrit will decide, which I think I will discuss in due course. This is the golden triad that is described. Most important point in the management of dengue is this slide. Most important. The major cause for mortality and morbidity in dengue is overhydration. We dump fluids. Say if the critical phase lasts for 48 hours, in a 10 kg child, maintenance for 1 day is 1000 plus 5% dehydration, 50 into 1000, so 50 into 10, 1500 ml is the fluid that is suggested during the entire critical phase. Because fluid overload kills the patient. Earlier, we used to listen to stories about a child being on ventilator, blood gushing out of the lungs, entering the circuit into the ventilator. All these stories we used to listen in the past. Now, things have changed a lot. We are now reasonably good in managing. Dengue cases going on to ventilator itself has become a rarity, and outcomes have tremendously improved with the judicious IV fluid management. What are the fluids that can be given? NS and 5% dextrose if hypoglycemia is an issue. For small children less than 6 months, half normal saline and 5% dextrose is also a accepted IV fluids. But even in these children, NS and 5% dextrose is a better choice. Irrespective of the weight of the child is above 50 kgs, accept the maximum weight for which fluid needs to be calculated as 50 kgs. If the child is 70 kgs, 80 kgs, I take the working weight as only 50 kgs. And ideal weight or actual body weight, say a 10-year-old child is 44 kgs against the expected of 33 kgs, calculate your fluids as per 33 kgs only. Say if the 10 kg child is 20 kgs, instead of 33, calculate fluids for 20 kgs. So whichever weight is low, smaller, accept that weight for calculating IV fluids. By this methodology, you will almost never have a scenario for fluid overload. So the earlier slide and this slide are the most important slides in the management. Yeah, this is what I was saying. Basing on the hematocrit, if hematocrit rises by less than 10%, the initial fluid that needs to be started is 1 to 1.5 ml per kg per hour. This is in the dengue with warning signs group. DHF 3 and 4 we'll discuss later. 10 to 19%, 1.5 ml per kg per hour. More than 20%, 3 to 7 ml per kg per hour. And the rough guideline is by the earlier inverted pyramid slide, which I have shown. So basing on this, with meticulous hourly following, hourly output, urine output measurement, you will almost never lose a patient. This season, we had a very bad dengue outbreak. We had almost more than 400 admissions. I can proudly say we have, the mortality was less than 1%. So the fluid management is the more, and not even a single child went for ventilation, had to be ventilated. So how do we taper off? This also I will explain in the further slides. After your initial fluids, after 4 hours, if your PCV is increasing and the child goes to shock, that means you have to give something which has the capacity to stay in the intravascular compartment. Of course, that is colloids. What colloids we'll discuss. If the child is stable, urine output is good, you can consider coming down on the IV fluids. If PCV is the same, patient is in shock, and there is normal same PCV or the PCV has come down, that's the time to transfuse the patient. PRBC, packed RBC 5 ml per kg, or whole RBC, the whole blood, or 10 ml per kg. Recovery phase, just shut down IV fluids. Urine output is the single most important parameter. Accept a urine output to 0.5 to 1 ml per kg per hour. Anything more than 1 ml per kg per hour, you can confidently consider coming down on IV fluids. Okay. Anything between 0.5 to 1 ml per kg per hour, yes, you try to continue the same IV fluids. If the IV fluids, if the urine output is less than 0.5 ml per kg, reconsider with PCV. So that concludes dengue with warning signs. So this is the third scenario. The same child presents on day 5 with feeble pulses, hypotension, narrow pulse pressure, and a very sick condition. So what are you going to do? Here PCV is increased, BP is on the lower side. So of course, this is the DHF grade 3. So since the BP is low, we have to give a bolus. Crystalloid bolus is the drug of choice, is the fluid of choice. Isotonic crystalloid NS, 10 ml per kg over 1 hour. In routine management of shock, we use the push and pull technique. However, here you have to give the crystalloid over 1 hour. See the response. If response is good, blood pressure comes up, your PCV comes down, urine output increases, you can come down the IV fluids as per this. Slowly over the next 24 hours, you can come down on the IV fluids from 10 ml per kg per hour to 7, 7 to 5, 5 to 3, keeping an eye closely on the urine output. Urine output is the single most parameter. Monitor urine output hourly. It is going to help you a lot. Okay, same child has not improved after a bolus. The picture on the left shows you a raised PCV despite the bolus. BP continues to be on the lower side. So obviously, whatever fluid as you have given has gone into the extravascular compartment. So what is the fluid of choice here? Yes, colloids are the drug of choice. On the right side, your PCV has come down. Your blood pressure is on the lower side. CFT is high, peripheries are cold. So their blood transfusion is the drug, is the intervention of choice. So what are the colloids you can use? Hexaethyl starch, dextrans. They have a limitation of the upper limit in the volume. If you use gelatins, there is no upper limit. Of course, at a personal level, I am not a strong supporter of use of colloids. Only rarely we have used. Usually they are not needed in our daily routine practice. Albumin can also be used. The biggest concern we all know is the impact on the coagulation. So these are the description. Yeah, albumin in a study at Tamil Nadu, they have shown evidence of positive fluid balance. Of course, they didn't have, it did not have any much effect on the mortality. So this is the last one, child presents with shock, no pulses. So this is diagnosis DHF4. The management of DHF4 and DHF3 are the same. What are you going to do? Here, there are no pulses felt. BP is not recordable. So you have no other option other than to give a bolus of 20 ml per kg per hour by push and pull technique over 15 hours. And follow it up with the same protocol that has been followed in DHF3 if the child shows improvement. Yeah, the child shows improvement. Yes, same protocol which you have followed in the DHF3. If there is no improvement, if PCV is high, go for colloids. If PCV is low, go for blood transfusion. If despite all your measures, there is no improvement, you have no other option other than going for peritoneal dialysis, hemodialysis, or plasmapheresis, which are beyond the scope of majority of hospitals. If the child shows improvement, this M+5% formula has to be strictly adhered to. So this is the scenario. Routine thing, referral hospitals have this problem. Fluid overload patient is the commonest referral we receive from outside. If patient is in shock, has a high hematocrit, colloid with furosemide midway. Has a low hematocrit, blood transfusion with furosemide midway. Hemodynamically stable, keep quiet, don't do anything, wait for some time. Time and masterly inactivity are the two most important measures which can help these patients. See here, this is the child we have received last week. So much of fluid overload, we didn't do anything. See, over the next 48 hours, we stopped IV fluids. Patients were furious, they were very upset, but we somehow convinced them. Child improved, went home, they also were very happy. So other issues, role of platelets, we all know there is no role unless platelets fall below less than 10,000, and or if there is any evidence of bleed, irrespective of the platelet numbers. FFP cryoprecipitates seldom used, may cause more harm than good. Of course, when there is gross liver dysfunction, may consider, otherwise routine practice, no need. Nasal epistaxis, there are some bedside things available. This can be used to stop the bleed. Abdominal compartment syndrome, sometimes ascites is so tense, you can do controlled paracentesis, 4 to 6 ml per kg initially, followed by 2 to 3 ml per kg. In my entire 20 years, probably we have done paracentesis in only 10 patients, not more than 10, routinely not needed. HLH is a issue we see if routine improvement is not seen. Yes, if there is hyperferritinemia, you can consider HLH. IVIG, methylprednisolone, anakinra are all used. For resistant cases, cyclosporin, etoposide, genetic testing has a role. Dengue encephalopathy is not a neurotropic virus. Usually encephalopathy is secondary to other features. Transverse myelitis, all are described. Usually benign, but can be fatal. Sometimes the basal ganglia are so necrotic encephalitis also we have encountered, but they also have recovered. Only 2 cases are on follow-up which are not doing well. Myocardial involvement, not a routine feature. Global dysfunction has been reported. Acidosis is contributory. Take care of the metabolic component. myocardial involvement recovers on its own. It has got a good prognosis. Liver injury is common in children, but it also responds to supportive treatment. Avoid hepatotoxic drugs. AKA very rare, not more than 3% of cases. Shock, rhabdomyolysis, glomerulonephritis, ATN are all causative factors. COVID and dengue, in this pandemic, they can coexist together. Earlier studies have shown dengue has shown a positive impact on COVID outcomes. That's the reason Japan and South Korea have overcome their COVID pandemic very rapidly. Maybe dengue antibodies are protective. However, COVID antibodies have been shown to have no effects on dengue outcomes. Very few studies. One of the study has been done from our hospital that is due for publication over the next 1 month. We didn't find any association between COVID antibodies and dengue outcomes. So vasopressors should not be used routinely. Be careful while using vasopressors. Unless you have ensured good volume, then only consider, even then better to avoid. Intubation dengue is a nightmare because it is a very compromised scenario. Preference for NIV, peri-intubation PPV and apneic oxygen are mandatory. Peri-intubation, vasoactive infusion, ketamine is preferred. Avoid midazolam and other benzodiazepines. ABCS, take care of acidosis, bleeding, calcium and sugar. Dengue vaccine has been approved in USA, but it is not yet available in India. So should not be used, should be used only if there is evidence of earlier infection, because otherwise this will provide scenario for a secondary dengue. So when to refer, when shock is not improving, major bleeding symptoms are there, all these things. Future directions, no role for steroids, IVIG, all these molecular inhibitors, chloroquine, lovastatin. So not much of a fresh drug is available for future. These are the do's and don'ts. Don't use steroids, don't use platelet transfusion, no half normal saline. IV fluids may not be necessary at all. Do tell patients about impending development of DSS. So discharge criteria, we all know it. Take home messages. The COVID pandemic, don't neglect dengue, vice versa also. So clinical assessment investigations do help. Co-infections are common. Fluid therapy is life-saving. Guarded, appropriate fluid therapy. Colloids can decrease fluid overload, but stay cautious. Watch for bleeding. Abdominal compartment syndromes, be careful. So I think that's it. So this is the same X-ray. If the same X-ray is seen on day 3, be aggressive. The same X-ray is seen on day 7, day 8, master inactivity. So in this X-ray, if it is day 3, so if it is on day 7 and day 8, we all know the famous thing. Thank you so much.
Thank you, sir. Thank you for the elaborate lecture.
Sorry for overshooting a little bit.
Thank you for your wonderful presentation, sir. Now I would like to request Dr. Tatama Naidu to felicitate Dr. T. Chandrasekhar. Next, I would like to request Dr. Narasimha to felicitate Dr. Tatama Naidu.
Dear delegates, the general body meeting is at 5:10, but suppose most probably it will be running half an hour late. And after that, the banquet is at around 7:30. Please try to be on time.
I would like to call the chairperson, Dr. Muralidhar Reddy, President of Andhra Pradesh, for the session Nephrotic Syndrome, Old Problems and New Perspective on the stage to introduce the speaker, Dr. Murali Krishna. I would like to call the chairperson, Dr. V. Bangaru Krishna, for the session Nephrotic Syndrome, Old Problems and New Perspectives on the stage to introduce the speaker, Dr. Murali Krishna.
Good evening, all of you. I am introducing Dr. Murali Krishna Bhagavatula. He is MBBS MRCP PH UK, MRCPH UK, CCTS Pediatrics UK, FPN Canada, and Hong Kong. He done his MBBS in Mysore University, India. Krishna.
It's okay.
Okay.
That's a good enough. Thank you very much.
Thank
sir.
you.
So good afternoon, everyone. I am Dr. Murali, pediatric nephrologist. I know it's hard. Post-lunch session is a bit challenging from both ends. Before starting, I would like to thank the organizing committee to give me an opportunity like this, and also thank the chair for a kind introduction. With no further ado, I'll get on with my presentation. So, nephrotic syndrome is not a new problem. It has been there for ages, say from 1970s, 80s, where a masterly inaction was the usual approach. From there on, nephrotic syndrome has been seen sea of changes with the latest updates and guidelines coming across the globe. The PEDICON guidelines coming up in 2021, which is the latest update, and Indian Society of Pediatric Nephrologists have come up with their own new latest review guidelines, which is aligned to the international guidelines now. So I'm covering this topic, steroid-sensitive nephrotic syndrome, focusing on diagnostic criteria, definitions, investigations that are recommended at presentation and at subsequent relapses, therapeutic options that we have, complications and management, and supportive care. Need not be in the same order, but I'm trying to cover these areas randomly at different points. So nephrotic syndrome, the incidence is about 12 to 16 per 100,000, 1 lakh children. Majority of them are idiopathic. Very few of them, say about up to 10% are secondary. When we say secondary, they are mostly secondary to SLE. Sometimes infections do cause nephrotic syndrome as a part of multisystem involvement. Coming down to idiopathic nephrotic syndrome, your steroid-sensitive nephrotic syndrome, SSNS, is the most common entity. About 90% of them are steroid-sensitive nephrotic syndromes, of which half of them, 50% of them, are frequent relapses, and about 30 to 40% are infrequent relapses. And the late resistance, where they are sensitive to steroid treatment in the few episodes, but subsequently the later on relapses become resistant to steroid, which we call them as late resistance. Most of my talk, in fact, this whole talk is focused on steroid-sensitive nephrotic syndrome. Steroid-resistant nephrotic syndrome is a completely different entity and different beast to deal with. So if you look at the nephrotic syndrome, based on how it is at presentation, you can classify them as primary or idiopathic,
or secondary. If you do a biopsy, kidney biopsy at presentation, 80% of them will come out as minimal change disease, and others will constitute about 20%, of which your FSGS and mesangial-proliferative glomerulonephritis constitute about 7 to 8% each. So most of your others are FSGS or mesangial-proliferative glomerulonephritis. If you start your treatment and classify based on the treatment, 80% to 90% of them are steroid sensitive, and remaining 10 to 15% are steroid resistance. If you start the treatment and based on the response to the treatment, if you classify them, that's the classification. So before diving into the deeper layers of the topic, I just want to briefly cover and update you with the definitions that has been reviewed by Indian Society of Pediatric Nephrology, and the guidelines have come out in 2021. So I'm just briefly talking about few changes that they have made. Previously, it used to be urine protein 3+ or 4+ on dipstick, or urine protein creatinine ratio of 2 milligrams per milligrams, where your protein and the creatinine are measured in milligrams per deciliter units. Usually the first morning sample is taken as the gold standard. Subsequently, they added this 40 milligrams per meter square per hour as the additional criteria. You don't need to measure it, but if that is other criteria used to be in the blueprint is now part of the definition. Remission is defined as urine protein nil or trace on early morning dipstick measurement, or if you measure urine protein creatinine ratio, which is less than 0.2 milligrams per milligram, on 3 successive morning samples. A relapse is defined as when your protein goes back up to 3+ or 4+ on urine dipstick, or your protein creatinine ratio more than 2, again measured on 3 consecutive days. Frequent relapses were slightly tweaked, and the new aligned definitions or the criteria are 2 or more relapses in 6 months, excluding the first presentation. They come out with the first episode of nephrotic syndrome, you treat them, they come out of it, and within the next few months, if they have 2 more episodes, that is 3 episodes in 6 months, include the initial episode. Or if they are relapsing regularly in the second 6 months or later, if they have 3 or more episodes, or if they have 4 or more episodes in 1 year, so 3 or more in 6 months or 4 or more in 1 year, are called frequent relapses. A slight adjustment to the protein creatinine ratio in young kids less than 2 years, your protein creatinine ratio can be normal up to 0.5 instead of 0.2. So 2 years and above, older children, the reference value for normal protein creatinine ratio in urine is 0.2, but kids younger than 2 years is 0.5. Some of the labs are measuring the albumin creatinine ratio for checking the protein creatinine. There is a confusion in the calculation, so it's better to be watchful and make sure that protein creatinine is measured. Albumin creatinine ratio is not part of the diagnostic criteria. Steroid dependence is when a child is having recurrences, relapses within 14 days of stopping the treatment, or as we are weaning the steroids. That's when you call them as steroid dependent. They should have 2 successive episodes where you can't wean them off it, or you take them out, and then within 2 weeks. So I remember it as 2 and 2, 2 recurrent relapses, 2 weeks within stopping treatment, or as you are weaning it, then you label it as steroid dependent. Steroid resistance is where there is a lack of complete remission in 6 weeks of full treatment. That is slightly in variance to PEDICON guidelines, which are the international guidelines, where they take 4 weeks for partial remission and further 2 more weeks for complete remission. Even though the total duration is 6 weeks, there is a slight variation in 4+2, partial remission in the 4 weeks and complete remission by 2 more weeks. That is 6 weeks is treated as responsive. If they don't respond by 6 weeks, whichever way it is, either you follow the Indian guidelines or you follow the PEDICON recommendations, 6 weeks, if you are not out of nephrotic syndrome, then you are steroid resistant.
Stable remission is a new word, a new definition where you are responding to treatment and you have sustained remission, or if you are a infrequent relapser before and then after treatment, your relapses become infrequent, that is also accepted as stable remission. So someone who is having 4 attacks in a year, suddenly you start them on levamisole or one other medication, steroid sparing agent, they respond and they became infrequent relapsers. That's a win-win situation. Even if they have 1 attack in a year, you can tolerate it. A complicated relapse is when you have a life-threatening episode. Most of the life-threatening episodes are infections or hypovolemia needing intensive care and rapid IV management. Thrombosis is other major life-threatening complication in these children. Significant steroid toxicity is defined as hyperglycemia, obesity, short stature, raised intracranial pressure, cataracts, myopathy, osteonecrosis, and psychosis. The confusion in this group is your raised intracranial pressure and psychosis are confusing on a clinical grounds. So if you are suspicious of raised intracranial pressure, one way of looking at it is getting a CT scan to see the indirect evidence for dilated ventricles. The other way of looking at it is getting a fundus examined to see if there are any raised ICP changes in the fundus. Difficult to treat steroids, difficult to treat to steroid sensitive disease is when you have 2 steroid sparing agents already being used and the child is having either frequent relapses or infrequent relapses. So even after 2 steroid sparing agents, if the child is getting frequent or infrequent relapses, you label them as difficult to treat disease. This is a new entry into the guidelines now. So a quick review of KDIGO guidelines, which is originally originated from European nations, and the ISPN review recommendations done and come out as guidelines in 2021. Both of them are pretty recent, come out in the last year. If you look at the definitions, nephrotic range proteinuria is common for both, but your low albumin and edema for ISPN, low albumin or edema for KDIGO guidelines. So you need either low albumin or edema in addition to nephrotic range proteinuria for KDIGO, but we need all the 3, that is nephrotic range proteinuria, low albumin, and edema. All 3 are needed for Indian classification. Steroid resistance, again, 6 weeks, as we have just briefly mentioned, 6 weeks and no response, you call them as steroid resistance. But for KDIGO, they define it as 4 weeks, but they have given a leeway of 2 more extra weeks that you can wait before labeling it. So in practice, it is 6 weeks, but by guidelines, it's only 4 weeks with KDIGO. But with Indian guidelines, it's up to 6 weeks. You still can wait, giving the full dose steroid to see the response. Steroid for initial episode, again, 6 weeks daily and 6 weeks alternate days, the recommendation from Indian review guidelines. But with KDIGO, they left it little loose, saying 4 to 6 weeks of daily and 4 to 6 weeks of alternate day, leaving a small room for clinicians to decide. And when you collect the data for, with that guidelines, you can't compare the like to like. Someone with steroid sensitive nephrotic syndrome, one group might be getting 4 weeks and responding well. The other might be getting 6 weeks of treatment before labeling it as steroid sensitive or resistant. And when you start comparing both groups to compare the outcomes, probably you are not comparing the oranges, compare the oranges to oranges and apples to apples. Just for that reason, that might be the reason why the Indian guidelines have aligned to 6 weeks and 6 weeks to avoid the confusion. There is no indication for prolonged treatment in the Indian guidelines, but the KDIGO guidelines for younger children less than 5 or 6 years, they tend to extend the steroid treatment, the whole course. So that 6 weeks plus 6 weeks is about 3 months. They can go up to 4 to 5 months or sometimes to 6 months for the younger group. That's a small leeway left to the clinician to decide. Dosing regimes previously used to be based on the weight, but now body surface area calculations are also incorporated so that both guidelines are agreeing, preferably with the body surface area. But we have to bear in mind, it's easy and convenient for a practitioner to use the weight-based calculations. Younger kids tend to have higher body surface area. If you use the weight-based calculation, you undertreat them. That's the only caveat with the weight-based calculations. Frequent relapses, as we mentioned before, slight change with 2 or more in the first 6 months after the initial episode. So 3 altogether when they are having the first episode of nephrotic syndrome, or 3 or more episodes in any further 6 months, or more than 4 episodes in 1 year, as against the KDIGO guidelines where 2 or more in 6 months or 4 or more in 1 year are labeled as frequent relapses. Prolonged alternate course for steroids, people who are not responding to treatment or who are having frequent relapses, you end up giving a small dose and extend the duration. We call them as Slovene long tail, which we go through in the subsequent slides. On top of this medication, supportive care, advising on diet, especially the low salt diet, focusing on immunization, calcium and vitamin D supplementations, and management of edema are the crucial components. So looking at the investigations, essential investigations at presentation, urine analysis, complete blood picture, liver function, renal function, including electrolytes, cholesterol, and your tuberculin test that is specific for Indian guidelines. It is not part of the KDIGO, but this is part of the Indian guidelines that we have to get the PTT done for the patient. Additional investigations at onset or at subsequent relapses, chest X-ray and abdominal ultrasound scan, C3, C4, ASO titer, and ANA to pick up the secondary causes of nephrotic syndrome. Hepatitis B and hepatitis C serologies as part of general screening to risk profile and stratify. Some of the nephrotic syndromes, secondary nephrotic syndromes, can be due to hepatitis B and hepatitis C infections as well. So it is not only diagnostic, but risk proliferation, stratification as well. Periodic tests for relapsing disease that you need to follow them up regularly to pick up the early relapses and the complications of the medications that might evolve during the course. On top of the investigations that we talked, focus on the history, specifically the asthma, allergies, family history of renal diseases and nephrotic syndrome. Asthma and allergies are managed with giving steroids. You are trying to see which of these patients have received steroids for other medical conditions, so that your risk stratification changes if they are exposed to steroids for other conditions before. Subsequent evaluations involve your urine dipstick at home. We don't need to do them every day, probably 2 or 3 times a week to see if they are to pick up the early relapsers at home so that they can present to the hospital early. Frequent clinical reviews are strongly recommended for infections and edema. We just need to see and evaluate them to rule out any infections that can be covered with simple antibiotics if they are picked up early. Renal biopsy is not mandatory. If there is persistent microscopic hematuria or a gross hematuria or acute kidney injury, not due to hypovolemia, make sure there is no hypovolemia, and AKI not due to hypovolemia is one of the indications for renal biopsy. Systemic features like fever, rash, arthralgia, low complements, low C3, all highlight SLE or any other connective tissue disorder that might present as nephrotic syndrome in the multi-organ involvement. Steroid resistance, either initially, right from the beginning, they are resistant to steroid, or they are steroid sensitive in the first episode, but subsequently become steroid resistant as the subsequent relapses evolve. If you are using calcium urine inhibitors like your cyclosporin or tacrolimus before starting them, or if you have started them and if you're using them for a prolonged time, probably 2.5 years, if there is a decreased renal function while the child is on calcium urine inhibitors, these are the indications for renal biopsy. You send the renal biopsy mostly for the light microscopy and immunofluorescence assay. Electron microscopy is not mandatory, but ideal, especially in hematuria, or if there is a low C3 or disorders of glomerular basement membrane. These are the indications for definite
electron microscopy as well on top of your LM and IF. Even after you start, you do your renal biopsy, 90% of your minimal change disease, 50% of a membranoproliferative glomerulonephritis, and 30% of FSGS are still steroid sensitive. Just because they are focal segmental glomerulosclerosis doesn't mean that you have to stop steroids and use some other agent. So this 30% of your FSGS are still steroid sensitive. That is the reason why your early diagnosis or the first episode, you still stick to steroids and wait for the response before you offer a renal biopsy to these patients. We have to remember why only CNIs, why not others? The recommendations are heavily now slanting towards tacrolimus and cyclosporin. If you are considering these medications to give to do the renal biopsy, but why these two? These two are notorious agents that not only protects the kidneys from nephrotic syndrome, but can also damage either acute CNA toxicity or chronic CNA toxicity, especially for someone who is on tacrolimus or cyclosporin for 2.5 to 3.5 years. 25 to 43% of them tend to have chronic CNA toxicity. That's the reason why before CNIs, before calcium urine inhibitors, it is strongly recommended to do a biopsy. Or while you are on CNIs, follow-through biopsies are recommended after 2.5 to 3 years. Going through therapy for the initial episodes of nephrotic syndrome, 6 weeks and 6 weeks, high-dose steroids daily for the first 6 weeks, and alternate day for the next 6 weeks. Risk of relapses at 1 to 2 years after the initial diagnosis is low for 3-month therapy compared to 2 months. Why 3 months? Why not 2 months? Why can't we stop at 2 months? Relapses are higher if the kids are treated only for 2 months rather than the 3 months. So to prevent to make them infrequent relapses, you are adding in 1 extra month to make sure they won't get too many relapses. At the same time, why 3 months? Why not 5 months? They can give 5 months of steroid as well, steroid course as well. But if you end up giving 5 months, the risk of side effects of steroids are higher. So risk and benefit calculation, ideally 3 months, probably 4 months, but not 5 months. That's what the current recommendations are. Either KDIGO or the Indian guidelines all agree the same criteria. Doing by weight is a convenient calculation, but bear in mind, weight calculations are little underdosing in younger children. Use prednisone or its active metabolite prednisolone, but there is no evidence for other medications except your IV methylprednisolone when the child is really edematous and oral tolerance is of question. Then you can at least give few days of pulses with IV methylpred before switching over to oral prednisolone. Treatment for your relapses. Prednisone, again, you give the daily doses, body surface area or weight-based calculation until they have remission for 3 successive days, and then you change them into alternative days with an aim to wean them off 4 weeks after they start to go into remission. So probably about 1.5 to 2 months is what most of the children need to come out of the relapses. Again, remission is when you have 3 successive days of negative or trace in the urine dipstick, negative or trace of protein and urine dipstick. If there is no remission at 6 weeks of full dose, you start them on treatment, they don't go into remission for 6 weeks, then you call them as steroid resistant. These are the ones we call as late steroid resistance. They responded to steroid in the initial presentation, but subsequent relapses, they failed to respond to steroid. These are called late steroid resistance. If you look at the numbers, that how much the steroid that they receive, especially for those who are in the first presentation, and initial 12 weeks, they end up getting 3.4 grams of prednisolone per square meter. And if they relapse for 4 relapses in a year, frequent relapses, full-blown frequent relapses per year, they end up getting nearly 5 to 5.6 grams per square meter of protein. This is a heavy protein load for the child, especially in this growing age. These are the kids when they are having frequent relapses, so low threshold. Frequent relapses, you are weaning them off the steroid. You manage to bring them to smaller dose. So say less than 1 gram per kg, and then they start spilling more protein. They are called low threshold relapses. You can try slow wean. Instead of giving 3 months, or instead of giving 2 months for a relapse, you treat them over 3 months or 4 months. That's a slow wean. Or you can have a long tail where you give small dose and leave them on that small dose for 6 months or 12 months. That's one strategy which has been practiced before, but never into the guidelines. But now they have put it in the guidelines that you can try that strategy and see. If they relapse as you are weaning the medication, and if they relapse at the higher dose, so more than 1 milligram per kg alternate day, and you are unable to bring them below 1 milligram per kg, or if they have a complicated relapse, where life-threatening complications that we have mentioned before, or if they have significant steroid toxicity, that's when you consider steroid-sparing agents. If they have those, high threshold or complicated relapse or significant steroid toxicity, MMF and mycophenolate and cyclophosphamide are the alternatives. If they fail on these medications, as we discussed before, difficult to treat disease, you can label them as difficult to treat disease and then move on to cyclosporine, and final pathway is rituximab. Just move on to the next one. So frequent relapsers, infrequent relapsers, but significant steroid toxicity, or prolonged course of steroid, which is a slow wean, or significant steroid toxicity. These are the ones where you can consider steroid sparing agents. Even after steroid sparing agents, if they are having frequent relapses, or if they are having infrequent relapses but heavy side effects either from steroids or from the steroid sparing agents, or if you have already used 2 steroid sparing agents but still unable to control the relapses, that's when you consider CNIs, calcineurin inhibitors, or rituximab. So KDIGO labels them, put them into 2 groups, either frequent relapsers and steroid toxicity as one group, and steroid dependence as one group. But the Indian guidelines have subgrouped them further and recommended using MMF prior to using CNIs or cyclophosphamide. So it was never. So what order are we going to use the medication? Is it a linear order that you start with levamisole, then MMF, then cyclophosphamide, then CNI, then rituximab, or you have everything on the table, pick one? So it's neither a linear nor a round table. It depends on the patient. Some of the patients you might choose, especially those who are high threshold. There is no point in giving levamisole or MMF. You might jump straight to CNIs. As you all are aware, all these medications come with side effects. Most common side effects are leukopenia, pancytopenias, transaminitis. Levamisole tend to have vasculitis. Cyclophosphamide and CNAs have their own cluster of side effects that we need to be aware of. And these side effects are to be considered before offering any treatment to the patient. Supportive care. Things that I would like to mention, special note on hypovolemia and edema and steroids. Anyone who used steroids more than 2 weeks in the last 1 year, during stressful infections, severe infections, dehydrations, invasive surgeries, major traumas and burns, we need to consider steroid stress dose. Edema, especially more than 7% edema, the risk of intravascular volume depletion is high. The clinical features for volume depletion: abdominal pain, vomiting, lethargy, prolonged capillary fill with cold extremities, tachycardia with low pulse volume, low BP or postural hypotension, biochemical markers like your high hematocrit, blood urea to creatinine more than 100, urine potassium index more than 0.6. All these indicate aldosterone activity, and these are the ones who tend to be hypovolemic. The old approach, classification is you are hypovolemic, RAS activation, INACT activation, sodium absorption, and then hypovolemia. That was a pathway, but the new evidence is pointing towards an underfilled and overfilled, two different theories. So you may have to give IV fluids, treat the hypovolemia before you consider giving albumin, 20% albumin and diuretics. If you give 20% albumin and diuretic for someone who is hypovolemic, you end up creating further renal loss and AKI. Infections are the major contributors for hospitalization. Peritonitis, pneumonia, and cellulitis are the most common infections. Viral infections, viral infections can cause exacerbations during the nephrotic syndrome, but major note is with varicella and influenza. SARS is a special note. Risk of AKI is high, both from COVID infection and the nephrotic syndrome, and the treatment that we use for both conditions, especially the diuretics that we might use in both these conditions. Immunization, you can give killed vaccine, subunit vaccines, but the response, especially for those who are on steroids, they might not mount the same immune response. Live vaccines are no until it is safe. Special vaccinations like pneumococcus, influenza, chickenpox, and hepatitis B needs a focus and special attention. Someone who is on high dose steroids, but used only for 14 days, the moment you stop steroids, you can vaccinate them. But those who needed the steroids, either high dose or low to moderate dose, you have to wait for 1 month after stopping steroids before vaccinating. A special note for cyclophosphamide is you have to wait for 3 months after giving the last dose of cyclophosphamide. CNIs, levamisole, and MMF, 1 month of waiting post steroids is enough. Rituximab, you may have to wait until 6 to 9 months before you vaccinate them with the live vaccines. Avoiding oral polio vaccines, not only for the kid, but also for the siblings living in the household because of the fecal shedding with the OPV. We just need to bear that in mind. We just mentioned about pneumococcus, varicella, influenza, and hepatitis need a special look into for covering up in these conditions. We'll just skip through this. Transition care, most of them outgrow by puberty. Frequency of relapses decline with age. Active disease can roll into adulthood. About 40%, 5 to 40% of them end up having some kind of nephrotic syndrome in the adult life. If you look at it, kidney failure, diabetes is only 2%. Most of the complications, most of the side effects that you see are metabolic bone disease that is not picked up clinically early on. Ocular complications and hospitalization from infections are the major complications. In summary, definitions are new. Most of the definitions are accepted into the guidelines now. Strategies are elaborated for frequent relapsers and steroid dependent. Renal biopsy is not mandatory for everyone. Probably in few situations that we have to do the renal biopsy before offering that particular medicine, especially the CNIs. Otherwise, you can tailor the treatment to the patient and give a targeted therapy to the patient, even using MMF and other medications. Thank you.
Thank you, sir, for your nice presentation, elaborative illustrations for nephrotic syndrome latest guidelines. Thank you one more time.
Thank you. Thanks for the opportunity.
Any questions, please? Yeah, thank you for the wonderful presentation, sir. Now, I would like to request the chairperson, Dr. Bangaru Krishna Garu, to felicitate Dr. Murali Krishna Garu. And now I would like to request Dr. Narasimhaya Garu to felicitate the Dr. Bangaru Krishna Garu. Yes, sir. Now, let us start the next session. I would like to call the chairperson of the session, role of interops in PICU case-based approach, Dr. Ram Prasad, consultant neonatologist at Rainbow Children's Hospital, Vijayawada, on the stage to introduce the moderator, Dr. K. Rafiq Ahmed Gar, and the speakers too.
Good evening, one and all. I think today's last topic is role of inotropes in ICU. We have very fair list of very young pediatric intensivists who are as panelists, and to moderate them, we have another very young dynamic academic pediatrician, Dr. Rafiq Ahmed sir. Sir, please. Sir doesn't require any introduction. He's a true academician. He, along with Sudhakar sir, are the torch bearers, and I can say they are the initial persons who have started pediatric critical care, and they have highlighted through PALS program throughout the AP. Sir was my assistant professor when I was doing my post-graduation. And I think to encourage and moderate this session, Rafiq sir is the correct person. And we have a team of very young pediatric intensivists. First, I can call upon Dr. Vamshi Krishna, pediatric intensivist at Ankara Children's Hospital, Tirupati. He has done his pediatric critical care from SRMC Chennai. Dr. P. Anurupa, she has done her pediatric critical care from Ankara Children's Hospital, Hyderabad, and at present she is the pediatric intensivist at Noori Children's Hospital, Vijayawada. Dr. Vishwateja, he has done his pediatric critical care from Mehta Children's Hospital, Chennai, and at present he is working at Google's OmniOrc as a pediatric intensivist. And last but not least, another young dynamic, Dr. Balakrishna. He has done his fellowship from Chennai Apollo Children's Hospital. At present, he is a pediatric intensivist at Andhra Children's Hospital, Vijayawada. Over to you, sir. Rafiq, sir.
Thank you, Ram Prasad, for that wonderful introduction. Good evening, everybody. I know you're all tired by this time, but let us infuse some fluids and inotropes in you and make you activate before you leave this hall and try to attend the banquet today. Now, we all know that shock in pediatrics has a considerable mortality and morbidity. And this is not recognized in early stages. It can have a high degree of mortality. Now, before we go with the case approach and discuss with our panelists, just let me go through just few basics of shock. Now, how do we define shock? So shock is a state where there is a mismatch between the supply and demand of metabolites and oxygen to the tissues, right? So this may happen with decreased cardiac output, increased cardiac output, or normal cardiac output. It doesn't matter, right? So how to recognize shock? See, the whole purpose of discussing today's shock in this PEDICON is to recognize the shock in its early stages of compensation so that no child should die or should have a morbidity. Even if he is resuscitated, he should not have any long-term morbidity. He should have intact survival. So for this to achieve, we need to pick up shock in early stages. So that is nothing but compensation. So when you want to pick up a child in early stages of compensation, early stages of shock, you need to understand the physiological response to shock in body. The signs of shock are nothing but the physiological responses you see in the body to compensate for the shock, right? They are nothing but whenever there is a shock, you will have tachycardia, the first important, even though it is a non-specific sign, but very important sign to recognize that child is in shock, and very important in monitoring, especially when you are treating a child in shock. So this is followed by low volume of peripheral pulses, increased capillary refill time,
especially when you compare the volume of peripheral pulses with the central pulses, there is a disparity between volume of peripheral and central pulses. You will have cold and clammy peripheries because of decreased perfusion, because of diversion of blood from non-vital organs to vital organs. Skin suffers the blood circulation and you will find cold and clammy peripheries. Blood pressure starts falling it. And once the blood pressure, even before the blood pressure starts falling, you will have oliguria. Usually this is more appreciated once you diagnose shock and keep on monitoring his urine output. Initially, it may not give you a right picture, but definitely urine output is going to get suffered. And once the blood pressure is low, once the driving pressure is low, whatever may be the cardiac output from the heart, if it is not driven into tissues, the first thing to suffer is the vital organs. So you'll have impaired consciousness of the child, and then this is followed by even the central pulses are also going to be weak. So these are the signs which we have to pick up. So pick up the signs before the blood pressure falls. Those are the compensated stages. So if you pick up children in shock in those stages, the mortality and the morbidity will be kept very low. So how to classify the severity of shock? Just as I said, all the signs of shock, if you pick up before the blood pressure falls, we call it as a compensated shock. Once you see the signs of shock, along with that, if there is a fall in the blood pressure, then you call it as a hypotensive shock. We all know how to categorize hypotension in children. It is an age-dependent factor. Children less than 1 month, 60 is the lower limit for the blood pressure. Above 1 year of age to 10 years of age, 70 plus 2 into age, we know that is a minimum blood pressure that is to be taken as cutoff for hypotension. And about 10 years, we all know less than 90 is taken, less than 90 of systolic blood pressure is hypotension. So if there is a hypotension along with signs and symptoms of shock, we call it as a decompensated shock. Believe me, try to pick up children in compensated shock. If you happen to see a child in hypotensive shock, very little time is left before this child can go into arrest anytime, and you can have high mortality. Unfortunately, if you are seeing a child in hypotensive shock, you should have a good team approach where you will be carrying out multiple interventions at the same time, because time is less before he ends up in a cardiac arrest. The classification by type, we all know, for having to have a good perfusion of all tissues, first important thing to have in the body is normal intravascular volume. When the volume is less, you will have decreased stroke output, you will have decreased cardiac output and decreased perfusion. So this, when volume is less, we call it is a hypovolemic shock. When pump is not acting, when volume is good but pump is unable to, heart is unable to contract and produce sufficient amount of cardiac output, you call it the cardiogenic shock. Both are good, but the blood is getting distributed unequally. We call it a distributive shock. And if there is everything is fine, volume is fine, contractility is fine, but there is some obstruction from the left ventricle into the greater arteries, then we call it as an obstructive shock. So never bother, as far as managing the child of a shock in PSU is concerned or emergency room is concerned, never bother about the etiology, because the principles of treatment of shock is going to be same, which we are going to discuss through cases. The plan of management is same, whether you are dealing, say initially when you do a primary assessment, if you are all are pulse positives, you know how to do a pulse primary assessment. In primary assessment, even if you are unable to make out what the cause of shock is in a given child, whether it is a hypovolemic shock, or cardiogenic shock, or distributive shock, doesn't matter, because the lines of principles of treatment of shock is same for all the causes. So lines are, you need to take care of airway, you need to take care of oxygen, supplemental oxygen. If he is in respiratory failure, do ventilation and take care of oxygenation before you get a IV access, attach him to monitor and go with the fluid boluses or inotropes. So these are the broad management guidelines. With this brief introduction, now we'll go ahead with the case scenarios. So management plans, as I said, for correcting the shock state, what do you have in your armamentarium of treatment? You need to normalize the intravascular volume. So if preload volume is less, you can give fluids to normalize the intravascular volume. So never ever consider giving inotropes before you are sure that volume is good. So if there is a hypovolemia, however strong inotrope you may use or a vasoactive you may use, you may not correct the shock state. So always the principles of treatment for correction of shock as a cardiovascular support is concerned, take care of fluids first.
So give correct volume, then try to, if even after correcting the volume, if the stalk shade is still persisting, then you can try improving the contractility of the heart so that you can increase the stroke volume. And sometimes if there is a maldistribution, try to use certain drugs which can alter the vascular tone. Thereby, you can improve you can adjust the distributive nature of the shock. So these are the three important modalities of treatment which are available for us. Now in this panel discussion, we will not discuss about the fluid boluses. Once the child shock is not getting corrected, even after fluid boluses, even after intravascular volume is normalized, what next to be done? So next to be done is to go ahead with inotropes and vasoactive agents. So how to use these inotropes and vasoactive agents? Let us go to the case scenario. To clarify or to manage these cases, we have 4 young pediatric intensivists of AP. I hope you will enjoy this session. We'll go ahead with the case now. Now, case 1, the mother brings a 4-year-old child to the ER. Child has a history of increasing lethargy, fever and dizziness when she tries to stand up. We'll know the meaning of what it is. Why on standing up child is becoming dizzy. There is no history of vomiting or diarrhea. That means there is no volume loss. Her intake has been poor for the past 12 hours. Typical chickenpox lesions developed 7 days ago. Over the past 18 hours, several lesions on her abdomen and lower limb have become red, tender and swollen. So very clearly, this is indicating that there is a post-varicella cellular skin infection is there in this child. So on primary assessment, you can see heart rate is 165, respiratory rate is 60 per minute. Child is highly febrile, 103 degrees Fahrenheit. Blood pressure is 90/30. We'll all know the meaning of each one of these specific findings by our intensivists. Auscultation reveals clear lungs with good air entry. Extremities are warm and bright red. Central pulses are full and bounding, and peripheral pulses are palpable but feel thready. The skin is warm up to mid forearms and mid calves. Capillary refill is 2 seconds. The skin lesions on her abdomen and lower limbs are bright red and tender. Pulse oximetry shows SpO2 of 100% while the child is receiving a high flow oxygen. So this is the scenario. Let us see what our intensivist has to say. Now, may I ask the first question to Doctor, who is answering this? Okay. So how do you categorize the child's condition?
Sir, by looking at the case scenario, we can clearly see the child is having tachycardia. The child is having tachycardia with tachypnea, and the child is febrile at the point of time. And the blood pressure is clearly showing a 4-year-old child with systolic of 90 is okay, but there is clear-cut wide pulse pressure 90/30, and which is by other examination findings also, like extremities are warm and bright red.
Yes.
So we can categorize this child as compensated shock. Compensated shock with the vasodilatory states.
Yes. So just now we have discussed the signs of shock are cold, clammy peripheries, we said, and usually pulses will be low volume, we said, disparity between peripheral and central pulses. Of course, as Vamshi has said, Vishwateja has said, when child is having vasodilatation with wide pulse pressure, you may not have the pulses thready. You may even capillary refill time may not be prolonged. It may look like a brisk one. So definitely this child is looking like having a severe vasodilation with a sepsis background. Okay, now what decisions and actions are indicated now? Balakrishna? Mic not working. Mic is not working. Yeah, I think we can pass on.
Good evening, everyone. Coming to the case scenario, as my colleague has mentioned already, the child is in compensated shock, probably vasodilatory shock as per the clinical condition. So the first station would be, initially I want to maintain the airway breathing circulation, so ABC. So I'd initially start the child on oxygen for supporting the breathing. Then I would secure 2 large bore IV cannulas. Why 2 large bore IV cannulas? Because initially I wanted to give fluid bolus. And if SOS, if the child is not responding to fluid bolus, I wanted to start the inotrope. So, and I will ask the sister to take the samples. I would like to attend CBP, CRP, routine investigations such as LFT, RFT, and electrolytes. And also I would like to take a blood gas because I want to see the lactate and I wanted to see the any metabolic acidosis there. So I want to know the bicarb levels and pH. And also I would like to take a blood culture because we are suspecting it is a secondary infection post chickenpox, and see the lactate levels in the blood gas. And also at the same time, after blood culture, give initial broad spectrum antibiotics, ceftriaxone. And for this particular case, I would like to give vancomycin also. Why? Because we are suspecting secondary sepsis, most probably skin infection. So better to go for vancomycin for covering staph aureus. And these are the initial steps would be taken.
Yes. Okay. Now, what is the significance of pulse pressure and the elevated respiratory rate in this child? Why is he having tachypnea?
Firstly, the pulse pressure is the difference between the systolic and diastolic blood pressure. And if it is normal of 30 to 50, and if it is less than 20, we call it as a narrow pulse pressure. And the conditions having low cardiac output status will have the narrow pulse pressure. And the wide pulse pressure, if it is more than 50, then we'll call it as a wide pulse pressure. And it can be due to increase in the SBP. It can be due to the fever or any pain or decrease in the diastolic blood pressure. Again, it can be due to the septic shock, the conditions. And the elevated respiratory rate, it can be due to the compensatory for the metabolic acidosis, what is occurring.
Yeah. What additional assessment studies are indicated, Vamshi?
Good evening to all. According to the recent Surviving Sepsis Guidelines 2020, only clinical monitoring is not enough to classify the septic shock into warm shock and cold shock. It clearly mentions when you are having additional invasive monitoring such as cardiac index monitoring, SVRI monitoring, as well as we need serial echoes to look at the contractility of the state. When we do such invasive monitoring, then only we will be able to differentiate whether it is truly vasodilatory shock or vasoconstrictive shock based on the SVRI index.
Yes. So all of our panelists agree that and they strongly recommend this surviving sepsis guidelines. So if initial within 1 hour of coming in contact in an emergency room, a child is suspected to have septic shock. We need to achieve all these 6 steps. First, obtain IV-IO access immediately. Collect blood culture. As Balakrishna said, he would like to do some investigations preliminary like CBC, CVRP, blood cultures, and other like lactate, other things he would like to do. And immediately start antibiotic. And whenever you are suspecting a sepsis as a cause of shock, there should not be a delay in giving a antibiotic, because all the studies have proved that delay in giving antibiotic has a higher mortality and morbidity. So we'll start empiric antibiotic treatment. We'll not go into what antibiotics to start. Then measure lactate. As said, this is the one important indicator which will tell you the prognosis of a child with septic, whatever may be the cause of shock, especially in septic shock. So we measure the lactate levels. Those children who have very high lactate levels initially before starting treatment will have higher mortality and morbidity. Then administer fluid boluses if shock is present within 60 minutes. And even you need to be ready to start even vasoactive agents if required within 60 minutes. So these are the 6 steps that are indicated whenever you are dealing with a septic shock child. Now, despite the fluid boluses, the child's condition deteriorates. She becomes unresponsive to voice and barely responsive to painful stimulus. Her distal pulses are now no longer palpable. Her extremities are cold. Her heart rate ranges from 170. Previously from 150, it has jumped to 170. And her blood pressure decreases to 70/25. Previously it was 90, now it is 70/25. She remains tachypneic on a non-rebreathing oxygen mask. Her lung fields are clear, but pulse oximeter is not picking up her pulse accurately. Now, what is the assessment and next intervention, Dr. again Vishwateja?
Sir, as we can clearly see, the child in this scenario is clearly progressing from compensated shock to hypotensive shock. Is it audible, sir?
Yes, yes.
So from compensated shock to hypotensive shock, tachypnea, tachycardia, and all are persisting. So as a next intervention, since if there is any available dedicated peripheral line, I can categorize this child as fluid refractory shock. So if there is any wide bore dedicated peripheral line, I'll upfront start the vasoactive agent here. And along with that, I'll shift the child to PICU. I'll procure a central venous line for safe administration of vasoconstrictor agents. And along with that, I'll secure arterial line also for invasive arterial monitoring.
Yes.
Along with these things, I'll reassess the child. If the sensorium is still worsening or at the same level, I may consider intubation also in this scenario.
Yes. So it is very, very important to secure 2 large bore IV access for this child and plan further inotropes for this. Suppose if you are planning for inotropes, what to choose? These are all the drugs that are available with us in PSU.
Sir,
And what is the reason behind choosing it?